most of our cases land up into 20 to 40, 30-year age group, and the most common diagnosis in our preoperative cases were AAD presented with BI associated, and few other cases were there where AAD was present alone. So in most of our cases, we did C1, C2 fixation and OC and FMD, and our second choice of surgery was C1, C2 fixation alone. And in few cases, we did hybrid fixation also, where one side we have done OC fixation and one side C1, C2 fixation, depending upon the anatomy of the case. Most of the cases we have used bone in the joint, and few cases we used spacer. So when we come to the neuric grade, average neuric grade improved in our post-op cases, and we have noticed that in cases where we used C1, C2 fixation, the neuric grade improvement was better than the OC fixation cases. And the same way, when we come to MJOA score, we have seen that cases where we have done C1, C2 fixation, MJOA score improvement was better than the compared to the OC fixation. So we can say in our cases, patient who underwent C1, C2 fixation showed a more significant improvement than the OC fixation cases. So when we come to complications, we encountered wound dehiscence. Post-op ventilatory support was required for one case where we had to do tracheostomy, and one case we encountered dural injury and the vertebral artery injury. So if I have to conclude, I'll conclude that pre-op discussion of radiology is at most important with 3D reconstruction. 3D bowl model always should be used. C2 nerve root to be preserved for wound complication in post-op. A post-op scan is mandatory to see the screw positioning. Regular revision of neuroanatomy is important, and interdepartmental association with ICU team should be there. Thank you.
Any questions from the judges? Any questions?
Retrospective analysis, or is there any aim for this study?
Sorry, sir?
What is the aim of this study? What is the aim?
Sir, aim of the study was to clinically decide that whether we should go for C1, C2 fixation or OC fixation in our cases. Where we have done C1, C2 fixation, we have seen the clinical improvement more than the patients of OC fixation.
What do you see that CT 3D angio being available, is the 3D model is going to make any difference compared to the CT angio?
3D models is going to make difference in better planning of the patient in preoperative phase.
Okay, nice presentation. Now we move on to the next speaker.
I'd like to call upon Dr. Ashutosh Carpenter.
Good morning, everyone. I'm going to present a retrospective study of medial cavernous wall histology in cases of functional pituitary adenomas and its correlation with imaging, subtypes, and outcomes. So coming on to functional pituitary adenomas, in which leaving even a little bit of tumor leads to the non-resolution of the disease. And this was shown by Oldfield in his paper in 2002, where he found that the medial cavernous wall was the foci of the residual tumor in cases of Cushing disease. Similarly, in pre-op evaluation by NOSP, it also predicts the probability of invasion of the medial cavernous wall by the tumors. And it was in 2018 in which Gardner et al. In his paper described the steps of resection of medial cavernous wall. So keeping these things in mind, we did a retrospective single-centered study from January 2021 to December 2023 with a total of 40 functional tumors, in which 25 tumors were those in which we intraoperatively suspected the invasion of the medial cavernous wall, and then the tumor was resected, which was then examined histopathologically along with the evaluation of its pre-op radiology and its outcome. So of the 25 cases, we had 12 cases of GH secreting adenomas, in which 8 were fresh cases, in which we achieved 100% remission, and 4 cases in which we achieved 50% remission. In ACT secreting tumors, 7 were fresh cases, in which 86% remission was there, and in recurrent cases, 50% remission was there. We had 2 fresh cases of prolactinomas, in which we achieved 100% remission, and 1 case of TSHoma was there, which was a recurrent case in which 100% remission could be achieved. And 1 case of somatomammotroph type of tumor was there, in which we could not achieve a remission. So overall remission rate was 80%, and The important thing that in fresh cases, we got 88% remission and in recurrent 57% remission. And comparing the pre-op NOS grade, so if you can focus on the third column, it shows the rate of invasion of medial cavernous wall as described by NOS. But in our study, we found that in NOS 1, 2 and 3, there is a very high rate of invasion of medial cavernous wall. And also, if we dissect the medial cavernous wall, we could achieve a 100% remission rate even in high grades such as 3A, in which almost resolution was in 90% cases, and 3B, in which resolution was in 100%. When ROC curve was made keeping grade 3A of NOSPES cutoff, it indicated that it has a better, that interop visualization of medial cavernous wall as a greater predictor of cavernous wall rather than the NOS grading. Other factors which had a greater incidence of microscopic invasion of medial cavernous wall, the only significant factor we found was the tumor size more than 2.15. And rest of the factors such as transcription factors were not significant. Coming on to other things, we specifically found a specific pattern also. So the first pattern in which we found was that there is a focal invasion of the medial cavernous wall, that is the dura itself, without any involvement of the adjacent ligaments. There were 7 of these types of cases, and another was, the next pattern was in which carotidoclinoid ligament was involved. So the basically tumor involves the carotid clinoid ligament and extends into the dorsal clinoid space. The third pattern was where the inferior ligaments, inferior paracellular ligaments were involved. Usually a small perforation was found below the inferior carotidoclinoid ligament. And fourth pattern was in which there was diffuse involvement of the medial cavernous wall as well as the ligaments. We had 1 CSF leak which was managed, and 2 cases of transient 6-nerve palsy, 4 cases of hyponatremia. So the limitations were, it was a single-centered retrospective study, and 7 were recurrent cases. So in conclusion, the intraoperative assessment of medial cavernous wall and its resection leads to a higher remission rate, especially in cases of functional pituitary adenomas. So NOSP is a good tool for non-functional tumors, but it grossly underestimates the invasion of medial cavernous wall in functional tumors. Thank you.
Any questions?
You have 2 cases where
Sir.
prolactinomas, what is the presentation? In prolactinomas, it is not described to
Sir,
remove them.
no, sir, we have also done prolactinomas also. So if I can, I'm
No,
not.
it's okay. What
Sir.
is the indication for prolactinoma?
Sir,
When you know that it can be controlled with bromocriptine or some other.
Sir, if it is not being responding to bromocriptine and the patient is either having CSF, if the patient is not responding to the bromocriptine, then we go for resection of those tumors.
Any more questions? Okay, then we move on to the next speaker. The 4th speaker is absent, so we are moving to the 5th speaker.
Thank you, sir.
So judges
I'd
have
like
the
to call
topic
upon
present.
Dr. Milan Khatri for the next presentation.
Milan. Okay, good morning, everyone. My today's topic is factors affecting hormonal outcomes in the patients undergoing surgery for the non-functioning pituitary adenomas, a prospective observational study. So aim of our study was to evaluate the changes in the hormonal function following the surgery for the non-functioning pituitary adenomas and to identify the various factors affecting the hormonal changes in these patients. So we enrolled 50 patients from the April 2023 to March 24. It was a prospective observational study, and we included all the radiologically confirmed non-functioning pituitary adenomas and excluded all the recurrent tumors and the functional tumors. We evaluated hormonal axis, mainly 3 hormonal axes we evaluated in this study, corticotropes, thyrotropes, and gonadotropes. And the hormone we tested preoperatively on post-op day 7 and the post-op day 90. In 90% of the patients, we used endoscopic transsphenoidal approach for the surgery, and out of which 86% of the patients underwent gross total resection. So coming to the results, so hormonal, after 90 days, post-op day 90, we evaluated the various hormones, which we already given 3 hormonal axes. And the result shows improvement in the 36% of the patients. It remains unchanged in 34% of the patient, and it gets worsened in 30% of the patients. While coming to the individual hormones, there were significant changes seen. There was significant increase in the cortisol, ACTH, growth hormone, luteinizing hormone. There was significant reduction in the prolactin due to relief of the stalk effect. There was no change in the TSH, FSH, and testosterone. So we evaluated the various predictors of the post-operative hormonal axis dysfunction. So we concluded with the male sex, tumor volume more than 8.8 centimeter cube, and the tumor diameter more than 2.95 centimeter are the main predictors of the post-operative hormonal axis dysfunction. On ROC curve analysis, tumor volume more than 8.8 centimeter cube and the tumor diameter more than 2.95 centimeter has sensitivity of 96% and 92% and specificity of the 88% and the 76% respectively to predict the post-operative hormonal axis dysfunction. So we noticed one complication also in 30% of the patient, transient diabetes insipidus. So coming to the discussion and the conclusion, in our study, more than 1/3 of the patients showed hormonal axis recovery post-operatively, out of which corticotropic axis had the highest recovery and the thyrotropic axis recovered least. And the hormonal level changes did not always reflect with the hormonal axis dysfunction grading. So key predictors of the hormonal axis dysfunction were tumor volume, tumor diameter, and the male sex. And the most importantly, extent of the tumor resection did not correlated with the hormonal recovery. The clinical relevance of this study was to assist in preoperative counseling and the hormonal therapy planning. And the study strengths were, it was in prospective design, it has ROC curve analysis, it has clinical utility, it fills the critical gap in prospective data on the endocrine outcomes in the giant non-functioning pituitary adenomas. And limitation of this study was it has very small sample size, and we have, currently we have very short follow-up up to 90 days only, and it was, visual outcomes were not evaluated in this study. Thank you.
Okay, any questions?
Yes, sir.
How many of your patients who had hypofunction of cortisol, post-operatively, all the patients, you give cortisol for some time?
Yes, sir.
So how many days you gave? We are assessing cortisol function. And you stop everything for assessment, or I don't know.
No, sir, we didn't stop.
So all the patients were on replacement steroids. No, let me ask, many patients have hypofunction before surgery. So you cover them with the perioperative steroid and even post-operative steroids.
Yes, sir.
Understand? So when do you stop the steroid for them for assessment of function?
So we, preoperatively, mainly the hypopituitarism was due to the compression effect on the normal pituitary. So if there was a hypocortisolemia, we started cortisol preoperatively, then gradually taper down it postoperatively.
You have told that cortisol improve in many patients. So all those patients you have stopped and then assessed.
So we have assessed the postoperative day 7 cortisol and postoperative day 90. The 7 was the critical, to evaluate the critical deficiencies acutely.
I have 2 questions.
Yes, sir.
One is, in how many of these patients were you able to actually see the pituitary gland and preserve it during surgery? Because with endoscopic surgery, you can often see the pituitary gland separately from the tumor and preserve most of the gland. Was that information noted or not?
No, sir.
That's, I think, vital, because if you have noticed no pituitary, sometimes you don't find any pituitary
Yes,
tissue at all.
Yes,
The
sir.
whole cella is empty after the procedure. In such a patient, I would expect that there's a greater degree of hormonal dysfunction
Yes.
after surgery.
Yes.
So I think that's one important point that you should have noted, and maybe you can go back to your records and check that.
Okay, sir.
Second thing is, what is your testing protocol? Is it just measuring at basal levels, or did you give any kind of stress test to evaluate the hormonal axis?
No, sir, we are just measuring basal level.
I think that is not sufficient.
Yes.
I think you should do what is called as stress testing, and that is the one that will really tell you, because basal level of hormones do not reflect much. What happens during stress, especially for corticotrophic axis. So those are two things that you should note in the follow-up of the study.
Okay, sir. Thank you, sir.
Thank you so much. So we move on to the next presenter.
I'd like to call upon Dr. Prachi Garg.
Good morning, everybody. Today I'll be speaking on radiosurgery for trigeminal neuralgias, secondary to dolichoectatic vessels. This is a rare disease accounting for only 2% of the total cases of intractable TGN. These vessels are tortuous and elongated, often greater than 4.5 millimeters in diameter, and are often part of the vertebrobasilar system, producing a neurovascular conflict, compressing the fifth cranial nerve, as can be visualized here with a thinned out and distorted nerve. The standard of care for such disease was MVD because it had an excellent long-term pain control profile but had multiple perioperative complications. Therefore, a shift towards gamma knife radiosurgery exists as it has a better safety profile and is a day care procedure requiring decreased time for post-op recovery. Nevertheless, the outcomes of patients with vertebrobasilar ectasia leading to TGN versus classical TGN are variable, and patient selection is important. In our study, we took patients who had refractory TGN, who refused MVD, and were not subjected to any previous surgical procedures. They underwent a comprehensive preoperative clinical and radiological evaluation with evaluating the BNI score, sensory evaluation of the fifth nerve, and an MRI emphasizing on cis sequencing to identify the neurovascular relationships and to precisely delineate the target point. A 4 mm single shot was placed at the Marseille point, that is the cisternal component of the trigeminal nerve, which is 7 mm away from the brainstem. As can be seen in this preoperative planning imaging, these dolichoectatic vessels tend to distort the brainstem, and there is a displacement of the fifth cranial nerve, thereby paradoxically aiding in targeting because there's an increase in distance between the two structures and there is decreased radiation spillage over the brainstem. Our patients were followed up at 3, 6, and 12 months intervals respectively. The demographic data represented in this table suggests that the patients had multiple comorbidities, making them poor surgical candidates. They all presented to us with a pre-op BNI of 5, as can be noted in this heat map. At the 3-month interval, there was measurable improvement in pain with a drop in BNI to 3. These patients referred to this as return to normalcy and were all smiles. However, by 6 months post-procedure, the pain was back and worse, with a BNI of 4 or 5. All 3 patients in the study had a minimal sensory disturbance, which self-resolved at 6 months. These patients, patient A in the study, had severe pain and at 11 months required repeat gamma knife radiosurgery and eventually defaulted to MVD post-procedure after 1 year. To summarize the results, there was poor pain control, a longer latency period requiring 6 to 12 weeks prior to improvement of symptoms, early recurrence, and a pain relief which was substandard to MVD. Mechanical distortion in dolichoectasia is axiomatic, warranting physical separation of the vessels. Therefore, MVD is theoretically ideal. However, in these patients, due to the firm and immobile nature of the vessels, it is difficult to separate this intraoperatively, and it leads to multiple post-op cranial nerve pathologies, and therefore leading to 11% permanent cranial nerve morbidity. Gamma knife radiosurgery, on the other hand, is non-invasive, and not all cases are straightforward. That is, there are some cases in which the nerve is separated. However, some patients have a completely distorted nerve, and therefore the target must shift to the root entry zone or the Meckel's cave, leading to damage to eloquent structures. Our series mirrored literature, and as seen in this table, compared to 2 studies on 29 and 30 patients respectively, there was a decreased pain-free interval progressively, with about 10 to 20% sensory deficits, and about 70% of these patients eventually requiring surgery. Therefore, the emerging guidelines suggest to offer gamma knife surgery as a salvage or rescue procedure for high-risk cases and reluctant patients, and treatment must be tailored based on safety and efficacy profiles, complication rates, feasibility, and overall patient expectation and satisfaction. Thank you.
So questions from the judges?
Did we stop all the medications following the gamma knife?
No, sir. Post gamma knife, in the second and third patients in our study, they required escalation of the pharmacotherapy as they did not have adequate pain control. But they were such poor surgical candidates that we could not do anything else apart from escalating the drugs.
Did you consider doing any radiofrequency ablation for these patients?
We did, sir, but the patients refused in the second and third cases, and the first underwent MVD and is now completely pain-free.
You said it was difficult to visualize the trigeminal nerve for doing the GKRS because of the distortion. Would you consider using MR tractography for this? Because that's one of the methods by which you can demonstrate the fifth nerve more clearly than with just a standard CIS 3D image.
That could be a new horizon, sir, but we did not look into that in our case study.
So if there are no questions, then we move on to the next
Thank you.
speaker. Thank you, Dr. Prachi.
Thank you, sir. Next, I'd like to call upon Dr. Pranav Yalakara.
So good morning everyone. Today I'll be discussing a rare transclavial CSF rhinorrhea case under the title Transclavial CSF rhinorrhea unmasked and role of Valsalva in a rare skull base leak. So coming to the patient history, she's a 47-year-old female presented with 4-year history of clear morning nasal discharge, leak consistently triggered by early morning Valsalva menus. Initially, she was misdiagnosed as sinusitis, and later she developed meningitis. When she came to us, we have done beta-2 transferrin assay, which showed positive for CSF, and MRI showed transclavial meningocele. CT cystonogram localized the defect in the transclavial defect. So we have taken her for endoscopic endonasal repair. Intraoperative fluorescein localized the leak. We have performed multi-layer closure using facial data, fat graft, and vascularized nasoseptal flap. Outcome, at the end of 3 months follow-up, there was no recurrence of the leak. So the main thing here is her early morning Valsalva maneuver increased her ICP, which lead to the increased transclavial leak. So consider CSF leak in unilateral clear exertion induced rhinorrhea. Early use of CT cystonogram is pivotal in localizing the leak. You have to recognize subtle clinical signs, pair your radiological precision with endoscopic mastery. More important than all these things, it is the basic medicine tool which helped in the preventing the recurrence, which is proper history taking. Spend more time with the patient, listen to what patient is telling, even though it sounds trivial. So you can educate the patient about the recurrence via habit modification.
Thank you, Pranav. So any questions from judges?
How can we draw so many conclusions from one case?
Sir?
How can you draw so many conclusions from one single case? I think this is theory aspect. Now, from one case,
Yes, sir.
how can we conclude so many things? Did you understand my?
Sir, it needs study, sir, but it is a very rare case. In literature, it is given as less than 2% of the spontaneous CSF leaks. So we are proposing that.
No, your conclusion could be the clival defect or something related to that.
Yes, sir, yes, sir.
conclusion cannot be
It is a
generalized.
already thin clivus, which is triggered by the continuous morning Valsalva menus, which lead to the increased ICP. Thanks.
Now we move on to the next presenter.
Next, I'd like to call upon Dr. Pratyush Mishra.
Good morning, sir. Despite of having various treatment options, TGN still remains to be an enigma for us. MVD, though remains to be the gold standard procedure, this retrospective study illustrates pre-op analysis of 101 and post-op analysis of 97 patients, including 76 primary and 21 secondary TGN cases managed with MVD for a period of 7 years. MRI was performed after clinically diagnosing the patient with drug refractory TGN, including utilizing the ICS D3 criteria, distinguishing them into primary and secondary TGN. Pain level were assessed using BNI grading. Only patients with at least 3 months of follow-up were included in this study. During the surgical intervention, careful arachnoid dissection was done, and cisternal segments of trigeminal nerve was evaluated for all the NBCs, followed by placement of shredded interposition Teflon graft between the nerve and the offending vessels. BNI scores of less than equal to 3 was classified as good outcome post-MVD. Female outnumbered male in all the groups. More than 3/4 of the patients were less than 60 years of age, and the average duration symptom was 4 years. Despite being on long-term medication, 98% had experienced the inadequate pain relief, with 96% being BNI grade 1 or 4 or 5. On pre-op MRI, AC only was identified in 91% of the patient, with SCA being the main culprit. Intra-op evaluation led to the reduction of AC only cases to 51%, but SCA persisted to be the predominant cause of compression. 50% had morphological change in the trigeminal nerve, with 2% patient had negative exploration. CP angle tumors and posterior fossa AVMs formed the secondary region cases. V2, V3 was the most common facial region affected, involved in 40%, and immediate complete pain relief was seen in 95% of total and 94% of the primary region cases. 87% of total and 84% of primary region cases had sustained pain relief at the last follow-up. 27% of total patient had recurrence. Of these, 2/3 patients were managed with drugs, while 4 patients underwent redo MVD. All recurrences in the secondary TGN cases were managed with drugs, and 2/3 achieved adequate control. Overall, the most common complication was facial numbness. Consistent with the existing literature, there was slight predominance of female, potentially related to the difference in the estrogen levels. 40% cases had been localized in the V2, V3 region. AC only was the predominant conflict, and SCA was the most frequent offending vessel. Immediate pain relief was identified in 95%, while long-term pain control was achieved in 84% of cases. These findings align with the previous studies reporting early success rates of 80 to 96%. Also, outcomes were similar across all age groups, with younger patients demonstrating similar pain relief as the older ones, indicating that age is no bar while performing the MVD. Shorter pre-op duration achieved 100% pain relief, emphasizing that better outcomes can be expected if early MVD could be performed. Research also indicates that arterial compression alone results in higher success rates, while outcome associated with venous or absent compression was less favorable. However, our patient did not reveal such results, necessitating that thoroughly evaluating the entire cisternal segment of the trigeminal nerve was important for any potential hidden conflicts. We also observed that patients exhibiting nerve morphological changes demonstrates better outcome than that with only contact, which can be because of the increase in the trigeminal nerve cross-sectional area post-MVD procedures. 27% patient in our study were 27% patient had recurrence in our study, with predictors of recurrence being pre-op symptoms duration of more than 4 years, more than 2 conflicting vessels, and inadequate immediate post-op pain control, which is also seen in various studies. Redo MVD remains the most effective strategy to control them. Mild transient facial numbness was the most commonly encountered complication in our study.
Okay, thank you, Dr.
Thank
Pranav. So, any question from the audience?
Do you mean to say that in every case of your secondary trigeminal neuralgia, you are able to find a vascular compression? Because I think they had some tumors and AVMs and all that. In all of them, were you able to find a vascular cross compression also?
In all the secondary cases, we had the tumor, compression with the tumors and the AVMs. For that cases, we have dissected the tumor but have not placed the Teflon patch for that.
You did not find any arterial vascular compression in any of them?
In that, no, sir.
I think these are two different things altogether. I mean, you cannot compare this and that. The entire pathology is different in these two.
Yes, sir. So we actually include both the secondary and primary region cases, but primarily we have done the series for the primary cases only.
One question, you told that microvascular decompression should be performed anywhere along the cisternal segment. Is it what you told, or it is at some specific area, MVD, where the nerve has to be decompressed on the vessel loop? It has to be, you told, anywhere along the cisternal segment it can be decompressed.
So we should thoroughly look for the whole complete cisternal segment, but the patch should be placed at the readily obstructed zone most probably.
Absolutely, it should be at the root entry zone. You passed a comment, it can be done anywhere. It's not correct, no?
Thank you, sir.
Thank you, sir. So next I'd like to call upon Dr. Sagar Balal.
Good morning. I'll be presenting a study of the clinical outcomes of silent corticotrophic adenomas versus non-functioning pituitary adenomas, also known as PITNITs. So what are silent corticotrophic adenomas? They are non-functioning pituitary adenomas which positively immunostain for ACTH. However, they do not have the clinical or the biochemical excess of cortisol. In the event of recurrence, radiation or radiosurgery, it's still a debate. Coming to our study, we had a total of 150 patients, 73 of them being silent corticotrophic adenomas and 77 of them being other PITNITs, which were followed for a minimum period of 2 years post-surgery on the basis of clinico-radiological profile. So we used the Pearson chi-square test for an analysis with the p-value less than 0.05 being considered significant. So coming to the silent corticotrophic adenomas, the patients who underwent gross total decompression, that is around 50 of them, 23 of them underwent, despite undergoing gross total decompression, had to undergo redo surgery. 12 of them had to undergo radiation. And coming to the near total decompression ones, 10 of them had to undergo redo surgery, 5 of them had to undergo radiotherapy. Subtotal, the patients who underwent subtotal decompression, 4 of them had to undergo redo surgery and 2 of them underwent radiotherapy. While coming to non-functioning pituitary adenomas, the majority of them being gonadotropic adenomas, 47 of them underwent gross total decompression and they were kept on follow-up. Only 1 of them had to undergo radiotherapy. Coming to the group which underwent near total decompression, 16 of them were kept on follow-up. None of them received radiation. And the group which underwent subtotal decompression, 4 of them had to undergo redo surgery and 1 of them was kept on, had to undergo radiotherapy. It was noted that despite gross total decompression, silent corticotrophic adenomas had a higher recurrence rate as compared to other PITNITs, 23 versus 2. So the p-value was significant. It was 0.013. The requirement of radiation was significantly higher in silent corticotrophic adenomas, 19 versus 2, p-value being 0.008. The relation between tumor size and the need for radiation or the need for redo surgery was not significant, p-value being 0.12. To conclude, silent corticotrophic adenomas are a highly aggressive subset of tumors. Recurrence may need adjuvant radiotherapy for achieving adequate tumor control. Thank you.
Thank you, Dr. Sagar. So any questions from the audience?
What is the new information you are giving? This is known only, no?
So there is no conclusive evidence as of now for the patients who, regarding radiotherapy versus radiosurgery. So what I am giving is that radiotherapy is a far better alternative. If the tumor has a recurrence in the cellular or the supracellular region, we can take up for redo surgery. However, if it is in the cavernous sinus, it is better to undergo radiotherapy.
So if there are no more questions, we move on to the next speaker. Thank you, Dr. Sagar.
Thank you.
The next speaker, please.
Thank you. Next I'd like to call upon Dr. Sarvesh Goyal.
Good morning, respected faculties and delegates. I will be presenting on building AI-ready data sets for dural-based pathologies, a systematic approach to data curation, annotation challenges, and potential solutions. So in today's era, artificial intelligence is an indispensable part of clinical research which helps in enhancing surgical precision and patient outcomes. So artificial intelligence tool development is mainly reliable on a machine learning algorithm which requires highly annotated data sets. So in India, there is lack of quality clinical, radiological, operative, and pathological data, which necessitates creation of national data repository in India to facilitate AI tools. So we aim to develop standard data sets and metadata sets of neurosurgical dural-based pathology for creation of AI tool under joint initiative of MIDAS project by ICMR, IISc Bangalore, and Artificial Robotic Technology Park, Bangalore. The aim of the project is to develop an AI tool which can diagnose, which can correlate histopathology with pathology, with radiological data. We also aim to identify hurdles and challenges encountered during the dataset creation and identify potential solution for the same. So it was a multi-centering ambidextrous hub and spoke study model. And the inclusion criteria was all dural-based pathology with MR images, T1, T1 contrast flare, histopathology details, clinical and operative details. And exclusion criteria was incomplete data set, poor image quality, and consent not given by the patient. And the study was ethically cleared from our institute. So it comprises of the hub and spoke model. We had 6 spoke centers from all over the country, including various states like Chandigarh, Bhubaneswar, Lucknow, Bangalore, and Trivandrum. And the data was given to the Apex Institute in Delhi, which was then, after verification, was given to IISc Bangalore. So the step of the study was that for each patient, first we will identify a patient with dural based pathology. Then we will collect the data, which includes MRI, pathological data, and operative data. Then data will be anonymized so that all the patient identifiers will be removed, and each patient will be given a study specific code. Then the data curation will be done, and then the data annotation has to be done. For data annotation for MRI, we have Doodle DICOM software and ITK Snap software, and for histopathological images, we have Histack WSI slide scanner. So after then, the quality assurance will be done by the neurosurgeons and neuroradiologists, which are specifically trained in this. Then after data analyzing and data will be uploaded to MIDAS project. So as a part of the project, we also developed an annotation tool, which was known as Doodle DICOM, which helps in annotation of the data. On MRI images, we have to annotate the tumor, the dural lining, and the normal brain, and the edema in the flare sequence. So the result till now, we have been able to collect data for more than 428 patients in past 2 years from all over the country. And then during the study, we also tried to identify what were the challenges we faced during this dataset creation, which include time-consuming nature of the dataset creation, long follow-up, poor quality of the data which were stored in the hub and spoke centers, and the intense training required for the technical personnels and interpersonal variations in annotation. And there is potential for breach in server while transferring of data from one institute to another institute. And we also are working on the solutions which include the centralized data collection protocols, the semi-automated annotations, encrypted data transfers, and external validations and rigorous evaluation metrics. So discussion, this is the first multi-institutional hub and spokes model to create data sets in Indian neurosurgery. And our conclusion is that standardized and mandatory data collection is essential in high volume Indian healthcare center to ensure quality, interoperability, and scalability of AI model integrating radiology and pathology data. And we would like to acknowledge ISC Bangalore and ICMR for the grant for this study. Thank you.
Thank you, Dr. Sarvesh. So any questions from the audience?
Nice topic. New AI is spreading everywhere.
Yes,
No
sir.
wonder it is into neurosurgery also. Just want to know, when you collect the data, the similar data collection is already done at several places.
Yes, sir.
Did we compare how they are collecting and what are the annotations they are making?
Yes, sir, we have compared, sir. The first limitation is that at many institutes, the patient records are not properly maintained. There are missing information in the discharge summaries, and many institutes, they are not performing the MRIs themselves also. And the MRI patients are being operated on outside MRIs, and that MRI data is also not stored in the
These
PAC
are all
system.
some social concerns you are telling.
Yes,
I
sir.
want to know what technical points which you are trying to teach to the machine. What are the points which you have to consider for a meningeal pathology?
Yes, sir. So in this first, we want pathological data, the histopathology images, and the MRI data. In MRI, we have the tumor marked in T1 sequence, T1 contrast sequence, flare sequence, and in T2 sequence also. And we are also marking the edema on the flare sequence. Then we will feed this, we are providing this information to the IISc Bangalore. where they will create a AI data set, AI tool which will try to correlate whether we can diagnose the histopathology based on MRI.
I think I want some more clarity. Edema means what edema you are telling? Are we grading it 1, 2, 3, something like that, so that the machine learns? You are understanding my point? We all know that edema is there.
Yes, sir.
The machine has to learn tomorrow. So are we grading, or is the system of data collection is taking into this consideration?
Sir, currently we are not grading the edema as such, sir. We are just marking the edema on
yes
the
or
annotation
no?
rule. We are not
Data
grading.
which you are giving to the computer is yes or no? Edema is there or no?
Yes, yes, yes.
That is one. And
Yes.
for meningeal thickening, any thickness, anything you are measuring?
No, sir, we are not grading it at all. We are just doing annotation.
yes or
and-
no? Yes,
yes,
or no annotation?
Yes, sir. Yes, sir.
What do you hope to come out of this? I mean, what is the purpose of doing all this?
So the thing is, for many dural-based pathologies, currently gamma knife is also an option. So in that, whether we will be able to, if we are diagnosing a meningioma on MRI, whether we will be able to classify into grade 2 or grade 3 meningioma based on MRI alone. So that because in this study, we are, our aim is to gather so much data so that we are able to diagnose histopathological diagnosis based on MRI alone. That is what our aim is to, and to guide clinician for better operative or radiosurgical management.
Is there any way to identify the cystic changes inside the tumor? I'm here, sorry.
Yes, sir.
Is there any way to just annotate the cystic changes inside these tumors?
What, sir?
The cystic changes, because sometimes you have a cystic changes inside the tumor, the necrosis inside the tumor, or
Yes,
sometimes you have a peritumoral cyst, because that is one of the major complications.
Sir, intratumoral cyst, we cannot like label it as such, but in the AI tool, when it will be created, then it will obviously compare the different annotations in the like tumors, which may have cyst in it, or like which may be homogeneously enhancing, and it will compare that data with the histopathological data, and will try to correlate that.
I think one of the major parts which you need to evaluate is the dural tail.
Yes,
because
sir.
sometimes you have a confusion whether it's just an inflammatory reaction to the tumor, rather having a tumor element into that tail.
Yes, sir.
Because you do not treat, many times you do not treat it with
Yes,
the
sir.
radiosurgery,
Yes,
or
sir.
even with the surgery you leave that part behind.
Yes, sir.
So that part needs to be evaluated with your AI tool that is going
Yes,
to
sir.
give
We
you a
are
full
also marking dural tail in it also, during annotation.
Manzul, I think, see, if the computer will only know whether the dural tail is there or not. That's all. Yes or no? And it is, again, you have to correlate with the histology. Again, the data has to be fed.
Yes, sir.
See, it's only that our learning, our thinking, whatever is there, the computer you are trying to teach.
Yes,
and
sir.
next time when one image comes, immediately it will tell.
Yes, sir.
But it can draw a conclusion based on whether tail is there or not. How can it compare with the histology also? That's all. Okay, that's a higher.
I think we
yes,
can
sir.
move on to the
In
next
the basically in the study also, we are using 3D Histack WSI slide scanner, in which the histopathological image is uploaded to the server as well, and the MRI images are also uploaded to the server. So then there will be correlation.
So you mean to say that the computer is going to evaluate much better a tile which is tumorous and non-tumorous, it will be able to detect.
Yes, sir. Because we are
Which
in
we
the-
cannot do.
Yes, sir. Our currently the minimum data which we are trying to achieve is 1100 patients, but since AI depends on machine learning and any increased data sets, increased number of patients, which help in better AI tool development.
Okay, thank you, Dr. Sarvesh. I think that's okay. So we move on to the next presenter.
Thank you, sir. Next, I'd like to call upon Dr. Sudhakar Mathesh.
Good morning, everyone. I'll be presenting a post-operative visual outcome in tuberculum cella meningiomas. So, coming to introduction, tuberculum cella meningiomas, they account for 5 to 10% of all intracranial meningiomas. And apart from direct compression on the cysternal segment, tumor extension into the optic canal is a major contributor to the visual decline in these patients. Therefore, the dual objective of any surgical intervention is both maximal tumor resection and preservation or improvement of the vision. Coming to the methodology of the study, it's a 10-year retrospective observational study of 40 patients, and preoperative assessments include a clinical examination, visual acuity testing, fundus examination, and radiological imaging in the form of MRI. The vision loss was categorized based on severity into mild to moderate loss or severe loss to blindness based on the WHO classification system. And the post-operative visual outcome were evaluated in the immediate post-operative period and as well as during the follow-ups. And statistical tests were used were the chi-square test and Fisher's exact test. Coming to result of the study, majority of the patient, they presented with almost 72.5% of patients presented with the severe vision loss to blindness in the pre-operative period itself. And the patients were operated by endoscopic endonasal, supraorbital keyhole, and traditional transcranial approaches. And post-operative visual outcome were noted as 42.5% shows improvement in the vision in the immediate post-operative period, which increased to 65% in the follow-up. And delayed improvement was seen in 32.5 patients, and the mean follow-up period was 52 months. Coming to factors which affect the visual outcome in this patient, the meningothelial histology showed the favorable outcome. Approximately 44.5% patient shows improvement in the this category, and the younger patients age less than 40 years, they showed favorable outcome, as well as the approaches what we have used is endoscopic endonasal, supraorbital keyhole, and traditional transcranial approaches. Among these approaches, the supraorbital keyhole approach has shown the most favorable outcome, followed by the traditional transcranial approach, followed by the endoscopic endonasal approach. And the optic canal de-roofing was done in patients, and 56.3% patients with the optic canal de-roofing, they showed the improvement in the visual outcome in the post-operative period. Coming to discussion, our analysis shows that nearly 72% patients presented with the severe vision loss, at least in one eye at the presentation, and it translates into only a moderate visual improvement of approximately 42.5% in our series. While an early optic canal de-roofing does play a role in post-operative visual recovery, our study is a reminder that patient counseling and surgical goal must be based on certain non-modifiable factors like patient's age, visual function at the clinical presentation, including optic atrophy as well. So minimally invasive methods may be beneficial in properly selected patients. However, a pterional approach with optic canal de-roofing remains the gold standard approach for the tuberculum cella meningioma in this era. Our study reveals a unique scenario of tuberculum cella meningiomas, unlike the issues faced by the Western world. In our settings, the tumor and patient-related factors, they overpower surgical mastery when it comes to post-operative visual outcome. So our study underscores the importance of early detection, education of primary physicians, and the need for overall societal awareness about these issues. Thank you.
Thank you, Dr. Sudhakar. So any questions from the audience?
This is a univariate analysis, what
Yes.
you've done. But actually you might have selected the better patients for SOCA, and therefore they might have improved better. So that you will not know unless you do a multivariate analysis.
Sir, I didn't get the question, sir. Sorry.
Question, I'm giving you a problem with your study. The problem is that it's a univariate analysis.
Yes.
You cannot conclude that patients with SOCA will improve after surgery more than other routes of surgery. That's the conclusion that you've reached. SOCA showed better improvement is what you said.
Yes, sir.
That may not be true if you do a multivariate analysis. What appears good on a univariate analysis may just, your benefit may just evaporate when you do a multivariate analysis.
Sir.
You understand what I'm saying?
Yes,
That
sir.
is, you might have selected the patients who are more likely to improve for SOCA than for other procedures.
Sir.
Like for example, the larger tumors probably would have done a traditional transcranial approach. They would have had more optic nerve compression, they would have had poorer vision, they would have also, they would have been less likely to have improved after surgery. So it's not that the surgical technique is the one that makes all the difference.
Yes, sir.
But also be a bias in patient selection.
Yes, sir.
See, look, what he was telling is absolutely correct. How many of the patients had medial optic canal invasion? You had 3 approaches. All of them should have the same number, medial optic canal invasion. And you do this approach and then tell this approach is okay. Otherwise, you are contrary to the teaching. The endoscopy is good for medial optic canal invasion.
Yes.
Understand?
Yes.
So that is what he is telling. Okay.
Sir. Yes, sir.
Who does the visual assessment? Ophthalmologist or surgical team?
Sir?
Who does the visual assessment pre-operatively?
Sir, we only do senior resident, sir.
No. I think
And we get it done from the ophthalmology department also, sir, the documentation.
I think it's better to do OCT in all these patients.
We get it done, sir.
Prognosticate.
OCT, visual acuity, fundus examination, we get it done through ophthalmology department, as well as we also do it, sir, to confirm it.
So better that you included that data in the study.
Yes, sir.
Pre-operative OCT versus post-op, which are the patients with poor OCT, how they improved. It would have been nice to have that data also.
Sure, sir.
So there are no more questions. So this was the last speaker. So I'd like to thank all the I'd like to thank all those presenters to finish the presentation on time, and thank you all the judges also. So the results will be announced later on. Thank you all. So I'll conclude this session.
Hello. So before we start the next session, some preparation needs to be made for the 3D screen. Some important announcements. All those residents and young neurosurgeons who had submitted their papers which were evaluated, of them 11 were the top 11. There was a tie, we decided earlier for 10, but since there was a tie, a total of 11 residents were selected for award paper presentations, which you just witnessed. And all these 11 people, the precondition was that they had to attend the full meeting, and if they attend the full meeting, at the end of the valedictory function, they can collect their refunds of the registration fees. So please don't go, wait till the valedictory function is over. There are a few awards also there in the valedictory function. The first 3 residents or young neurosurgeons will get attractive cash prizes. Then we have awards, certificates for the poster presentations which happened yesterday, and the quiz competition that happened on the day of the workshop on Friday. And yes, this year the society has decided, they have started an SBSSI Excellence Award. So the first 3 awardees will be getting medals as well. Thank you.
सही है.
Good morning, everyone. We'd like to proceed with the second session now. I'd like to call upon our moderator, Dr. Amit Thapa, sir.
Thank you. This is a very interesting session, session number 2 on anatomy and approaches to the posterior fossa. I will request the chairpersons, Dr. Midul Shahi, Professor B.K. Mishra, and Dr. Sachin Adhikari to take the first row seat. And I invite Dr. Abhida Shah from Mumbai to give her talk on 3D anatomy of the CP angle and foramen magnum.
So good morning, welcome back to the second day of the course. And as we have finished the anterior and middle cranial fossa, let's transit from the middle fossa to the posterior fossa. So if you see this image, so this is a transition from the middle fossa here into the posterior fossa here. You see the tentorial edge, you see the third and the fourth nerves here, you see the fifth cranial nerve coming and dividing into V1, V2, V3. This is the region of the cavernous sinus. Here you can see that we are entering the posterior fossa. This is the region of the petrous apex. Here you see the ICA coming in, and you cannot see the eustachian tube and other structures, but this is the ICA. And here you see the semicircular canals, and let's enter the posterior fossa now. So these are the three compartments. Here you can see that the posterior fossa has the following bones: the petrous part of the temporal bone, the occipital bone here, the occipital part of the clivus, and the rim of the foramen magnum. So the petrous has many parts. We will not go into the details now, but this is the anterior surface, this is the posterior surface, this is the petrous ridge, this is the petrous base, and this is the petrous apex. This houses many structures: the cochlea, the semicircular canal, the facial nerve in its transit, the internal acoustic meatus, and the jugular foramen. So all these structures are lying here in this posterior part of the petrous. This is the mastoid part of the petrous of the temporal bone. So you can see the huge mastoid process here. This is the styloid process which gives attachment to various muscles. Here you will see the region of the asterion. I will show you better in another image. This is the squamous part of the occipital bone, and this is the occipital bone forming the foramen rim, the occipital condyles. So what is the posterior fossa housing? It houses very important neural and vascular structures. As you can see that the brainstem with all the cranial nerves and the cerebellum form the main constituent of the posterior fossa. And to understand the anatomy of the posterior fossa, it has been anatomically the region has been divided into three zones. So the upper zone, the middle zone, and the lower zone. Each zone has its own set of nerves, vessels, and neural structures. So this is the anterior view of the brainstem with all the vasculature. Here you see the basilar, the vertebral forming the basilar. This is the ICA, this is the pica. Here we cannot see the SCA, we will see it later. This is the flocculonodular lobe. This is the choroid plexus. This is the 7th, 8th complex as it is coming out. Here you can see the 5th cranial nerve jutting out. Here you can see the lower cranial nerve jutting out. So let's look at the zones. So the upper zone comprises of the tentorial surface of the cerebellum. It is the artery of this upper zone is the superior cerebellar artery. The fissure of this upper zone is the cerebellomesencephalic fissure. The part of the brainstem, the midbrain, belongs to this upper zone. So here you can see this is the cerebellomesencephalic fissure. I have retracted the cerebellum down. Here you can see the midbrain with the colliculus. You can see the 4th nerve coming from posteriorly and running anteriorly. Here below is the 5th nerve. So you see the superior cerebellar artery coming here and dividing into rostral and ventral trunks. So it is in this region when these branches of the SCA are in close contact with the root entry zone of the 5th nerve. This is where your neurovascular conflict occurs for causing trigeminal neuralgia. So once the vessel enters here, it turns here and becomes the quadrigeminal part, supplies the quadrigeminal plate, and also supplies the superior part of the vermis. Now, the middle zone consists of the anterior inferior cerebellar artery, the petrosal surface of the cerebellum. The nerves that lie here are the 5th cranial nerve, the 7th, 8th complex, the 6th, 7th, 8th complex. So here you see the 6th nerve that is coming out from the pontomedullary junction. Here laterally you can see the 7th and 8th complex as they are coming out. The branches of the ICA as they are running along and supplying the petrosal surface of the cerebellum and turning laterally. Here you can see this is the view from the CP angle. Now you can see the loop of the ICA as it is coming here and turning from the anterior part of the flocculonodular lobe and going on to supply this part of the cerebellum. Anteriorly you see the 5th cranial nerve. Here you see the 7th, 8th complex. Here you see the lower cranial nerves. And this is the ICA. Here you see the subarcuate and the labyrinthine branches of the ICA. So this, here I think the image is a little bit cut. Here this part is the subarcuate artery, and here you can see the labyrinthine artery. This is the recurrent branch. You can see the choroid plexus, which is a major landmark for identifying the medial part of the facial nerve. So when you see this, just superior to this will be the facial nerve and inferior to it will be the glossopharyngeal nerve and the lower cranial nerve complex. The third zone is the lower zone. The part of the cerebellum that comes in this zone is the suboccipital surface. The vessel of this area is the pica. The brainstem component that forms part of this is the medulla. And the neural structures are the lower cranial nerve complex, as you can see here, coming down and running into the jugular foramen. Now you can see the pica as it is coming as a branch of the vertebral and going and turning, going towards the midline here and forming both its loops. Here you can see the glossopharyngeal vagal nerve complex. The spinal accessory will come from down and join here as they all enter here into the jugular foramen. So now this is a sagittal view and you can see the three zones. So here this is the upper zone where the midbrain you can see here, the fourth cranial nerve, the third cranial nerve, the superior cerebellar artery. Here you can see the pons, the fifth, sixth and seventh, eighth complex. And here you can see the medulla with the lower cranial nerve complex and the pica as it is looping and coming, turning medially. So now, what are the main approaches of this region? This is the workhorse of the posterior fossa, the retrosigmoid approach, and we generally operate in the sitting position, and this is the position, sometimes you need to turn the head a little more. So this is the incision. Now this is the site of the first burr hole, and here you see it is at the junction of these three sutures, the lambdoid, the parietomastoid and the occipitomastoid. This asterion marks the junction of the sigmoid and the transverse sinuses. A more convenient landmark is if you draw a line from the external acoustic meatus and go all the way to the inion, the junction, that is where actually the transverse sinus lies. This might not be a very consistent landmark, but that is what we generally use. So this is the exposure that you will perform in a retrosigmoid approach. This is the size of the craniotomy, typically. Then the first step generally in tumors or large tumors where the brain is little tense is opening the cerebellomedullary fissure and reaching the cisterna magna. This releases the CSF, and once the brain becomes lax, you can move forward into the cerebellopontine angle. This is when you're coming from the supracerebellar region. So when you depress the cerebellum down, this is one of the first structures that you'll see is the Dandy's vein or the superior petrosal vein. And then you can get access into, this is the avenue for the lateral supracerebellar approach. More laterally here, if you go, this is the view when you get from retracting the cerebellum laterally. So now you see here the fifth cranial nerve, this is the seventh, eighth, this is the ICA, on top here is the SCA, and this is the lower cranial nerve. So this whole panoramic view you can get from retracting the cerebellum laterally and entering into the CP angle. Here you can see anteriorly you will have the facial and the cochlear nerve, and posteriorly you will have the superior and inferior vestibular nerves. Here you can see the fifth with its motor and the sensory root. Above you can see the third cranial nerve and the fourth cranial nerve as it is entering into the cavernous sinus. So now coming more down, here you see the region of the jugular foramen. The foramen magnum rim has been removed here. Here you can see the vertebral artery as it is entering from the arch of the atlas and turning medially. This is the region of the atlanto-occipital joint and going and entering into the intracranial part, becoming the intracranial part. The next approach that is important for this posterior fossa is this supracerebellar infratentorial approach. So generally to approach the posterior third ventricular region, you can actually come from top here, occipital transtentorial, or you can come from here, supracerebellar infratentorial. So of course you don't have to do it so big, but this is the avenue. So here there are some veins that need to be cut before you enter into here, enter into the region of the posterior third ventricle. So laterally it is a little safer to cut these veins rather than in the midline. So here you enter, once you depress the cerebellum and the superior part of the vermis, you start seeing the region of the midbrain, the colliculi, the tectal plate, and here you see the splenium of the corpus callosum. And you can see the large veins that are there in this region, and you will see them more clearly now here. So the internal cerebral veins and the basal veins of Rosenthal joining here to form the vein of Galen. This is the cerebellar vein that is also coming and joining the vein of Galen. Here you see the superior and inferior colliculi, and this is the pineal body, as you can see there. Now the veins have been retracted laterally, and you can see the pineal gland more nicely. So the approach for this posterior third ventricle is traditionally dictated by the presence of these veins. If the veins are are pushed superiorly, you can come from below. If they are pushed inferiorly, you can come from the occipital transtentorial approach. So this is, we have seen the CP angle, we've seen the posterior third ventricle. This is the lateral supracerebellar avenue. So when you depress, come from laterally and retract the cerebellum down, this is the view you will get. This is the third cranial nerve, as you can see in the depth there. This is the tentorium. Here you see the superior cerebellar artery. This is the region of, this is the fifth cranial nerve here. Here is the 7th, 8th complex. So here the fifth cranial nerve will be the most superior structure. So here you can see from laterally, you can see the fourth cranial nerve. You can actually enter the brainstem from this region. There is a lemniscal triangle. Also we have described an approach to go through the temporopontine part of the crus cerebri, which is also safe to enter the ventral aspect of the brainstem. So here you have to cut the tent, go above the fourth nerve, and then enter the brainstem from this region. So again, this is the cerebellomesencephalic fissure, and you can see, now this is the basilar artery, the superior cerebellar artery as it is branching into superior and inferior trunks, the third cranial nerve, the fourth cranial nerve, which is the only nerve that arises dorsally and then runs forward in close proximity to this free edge of the tentorium. This is as the superior cerebellar artery is turning upwards and going to supply the quadrigeminal plate. The other fourth ventricular tumors are generally approached by this posterior midline suboccipital approach, and this is the view that you get. You don't need to remove the arch of atlas. Here the foramen magnum rim has been removed, and then you elevate the tonsils. Actually this image is ulta. It's okay. So once you enter this, you will see the tonsils. Once you retract the tonsils here, in this fissure, in the cerebellomedullary fissure, you will see the pica as it is running. Once you retract the tonsils, here you see this structure, that is the inferior medullary velum, and here you see the obex and the fourth ventricle. This is the loop of the cranial loop of the pica as it is turning in the cerebellomedullary fissure. Here you can see the pica with the, and this is the tila choroida of the fourth ventricle, as you can see here, running in the inferior medullary velum, and this is the region of all the triangles. We don't have the time to look at that, so this is just a view of the fourth ventricle with all the nerves coming out. So you can see the vertebral as it is running medially here, medial to the atlanto-occipital joint. Here you see this nerve that is coming down. This is the spinal accessory joining the cranial accessory here and entering the jugular foramen. This is the, with the brainstem removed, you can see the basilar artery with all its branches, the SCA, the ICA, and here this is the pica coming out. This is the branch of the vertebral as it is running down to supply the anterior part of the spinal cord, that is the anterior spinal artery. So I think my time is up, but I'll just show you quickly a little bit of the foramen magnum. So this is coming down. Now this is another region that is important, the craniovertebral junction, which is the region of stability and mobility. There are some important things that you should remember here. So there are, after you remove the first layer, you have the after you remove the sternocleidomastoid and the trapezius, this is the first muscle that will come, that is the splenius capitis. Once you reflect that, you get the semisplenius capitis. Once you reflect the semisplenius capitis, you enter this suboccipital region and the muscles of the suboccipital triangle, as you can see them nicely here. So this is the superior oblique, the inferior oblique, the rectus capitis posterior major, the rectus capitis posterior minor, and the constituents of this suboccipital triangle is the vertebral artery and the C1 nerve root with this venous plexus, and they lie on this posterior atlanto-occipital membrane. The second important thing you should remember here is the C2 ganglion, which actually lies right in front of the of the C1, C2 joint, and only when you reflect this ganglion, you get a panoramic view of this joint. So now we have removed the bone here, and also the spinous process is in the next view, and you can see this is the C2 nerve root, and this is the largest spinal ganglion, and it is the only one that lies outside, just posterior to the C1, C2 joint. So now you can see this vertebral artery, this is the atlanto-occipital joint, this is the C1, C2 joint. The vertebral artery as it is coming here from C2, turning over the arch of atlas, here it has formed a bony cover and then entering intracranially. So you can see it go nicely here. This is the denticulate ligament, this is the spinal accessory as it is entering. You can see the relation, the spinal accessory lies in front of the vertebral artery when you come from posteriorly here. Now you can see it all very nicely, the cranial and the spinal accessory joining together. Now coming downwards more, these are the lower cranial nerves as they are coming outside. So this is the relation when they come, and this is the rectus lateralis, and once you come here, They run with the with the internal carotid artery and the internal jugular vein. So I will just show you the image nicely. So this is the region of the, here you can see the lower cranial nerves and the hypoglossal nerve coming out of the jugular foramen and running downwards into the neck. So this just see the view. This is the C2 ganglion. Now once we lift it, you will see the C1, C2 joint here. This is the region of the nerves as they are coming down. So, and this is the view from the far lateral approach. And you can see here, this is the occipital artery. The muscles have been retracted. And this is the endoscopic view we've already seen yesterday. And I think I will end my presentation here. Thank you very much.
Thank you, Dr. Abhita, for an extended presentation. Now I request all our distinguished chairpersons to please take their chair on the dais. There's a little change in the program. We will have to invite Professor Suresh Nair for his talk on understanding the microsurgical pathoanatomy of vestibular schwannomas and lower cranial nerve schwannomas.
Can you make it full screen? Yeah, thank you. Let the chairperson sit. But before they sit, I have to tell, thank you, dear Adesh, for inviting me to Bhopal, a place I always love. Adesh was one of my best residents ever at Chitra Tirunal Institute. And I to confess, I had worked for some time at All India Institute of Medical Sciences. I came here just because of Adesh only. What a great meeting, Adesh. Thank you very much again. And thanks, Adesh, for preponing my talk. It is very difficult to give a talk after B.K. Mishra. So I am saved now. Okay. Okay. Can I start, Chairperson, with your permission? Okay. Say, always, Adesh has put me in a googly. So he has asked me to tell about microsurgical pathoanatomy. Let me see. This is based on my experience. You see all these tumors in various shapes, sizes, and this is, many of the things that have been demystified. What is written in that yellow is still, people have confusion. Whether CP angle is one CSF compartment, whether vestibular schwannoma, all these schwannomas are epiarachnoid in origin. And let me tell about this CP angle. This is saffron colored, BJP colored. It is described as one cisternal space. Is it correct? Let us see. And this is the publication from none other than Professor Majid Sami. He has also written it is all same. But is it true? Let us see here in a quick video. Sorry. Hope video will run. Select, no? Hey, can one of you sit here? Come here. It's very difficult for me now. No. What is that? No, I don't know whether one of you have to stand here. There it was running. Hey, put the other ordinary laptop for me. Are they sorry? It's not working. Unless I show that video, you won't understand. So all of us have all of us believe that CP angle is one cistern. Not that. CP angle has multiple CSS spaces. And when you have a cerebellomedullary cistern down where you have the lower cranial nerve. You have a trigeminal cistern where the trigeminal nerve is there. Then you have acousticofacial cistern where 7th, 8th nerve run together. Understand? If these tumors arise in this particular cistern only, intracisternally, a tumor arising from 7th nerve or from the 8th nerve, vestibular nerve in the acousticofacial cistern, it has no arachnoid separating it from the adjacent nerves which are in that cistern. Like that vestibular nerve, it arises in the cistern. There is no arachnoid which separates it from the 7th nerve. Always it has arachnoid which separates it from the lower cranial nerve. Always it has arachnoid which separates it from the trigeminal nerve. Message first you should know. Am I ready? Say, he's not coming, boss. What actually?
That is not available in your presentation.
No, it was working there yesterday. then none of the videos will run. Say that laptop, everything was running. You take it. So what I get some time. So this you cancel. This is not, stop this one. Stop this, otherwise I'll break it. Okay. So, so what I am telling, if a tumor arises in the acousticofacial system from 8th nerve, you imagine, there is no arachnoid which separated from the 7th nerve, from the vestibular nerve. From the vestibular nerve it arises, there is no arachnoid which separates this from the 7th nerve. Like that, these tumors, now I will tell you whether it is arising epiarachnoid. The epiarachnoid or subarachnoid. So for that I have to show the video. Anyway, we are ahead of time. We have them 20-30 minutes ahead of time. So this just changing of computer. No, I want this presentation here. Yesterday I had given the presentation there. That smart boy had taken my presentation. You want me to come again? I will come later. Yeah, I will come later. Okay. Next I will come. Let me go there.
Sir, just give me. Sir, give me.
Hello. 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 Hello.
The next presentation is Professor Girish Menon from Manipal. Again, he doesn't need any introduction. He's the editor of Neurology India, very, very accomplished neurosurgeon. Please, Girish.
Thank you, sir. Thank you, Chairperson. Thank you, Adesh, for this invitation. A long time since we had a meeting in Bhopal, and it couldn't have been better than this. Thanks again, Adesh. Now, I have a very specific mandate from Adesh, and specifically told that it is a PG resident-oriented program, and I need to emphasize on approaches to the CP angle with emphasis on patient positioning, incision planning, and bone work specific to pathology. So I must apologize and take disclaimer from the seniors here. You might find this presentation a bit redundant and obsolete and below par. So this is basically focused on the residents and the postgraduates, whom I unfortunately do not see plenty. Anyway, now that the anatomy was so brilliantly described by the Indian Rottens, that is Abhida and Sukhdev, just to summarize, I won't run through all that, and it's very difficult to duplicate or replicate what they presented. Just to summarize, and what she emphasized was basically CP angle has 3 compartments: the upper complex, the middle complex, and the lower complex. And each complex, as Rotten had originally described and as Abhida just now demonstrated, has a artery, nerve, some part of the brain stem or the peduncle, a fissure, and a cerebellar surface. So obviously pathology is in this region, and that is where neurosurgeons need to visit this region. It will be related to one of these structures. So you will have from an artery you can have an aneurysm sometimes, you can have, but not so common, as you know. You can have schwannomas, you can have schwannomas from the 5th nerve straddling into the CP angle. You can have classically the vestibular schwannomas and lower cranial nerve schwannomas. You can have any combination of that. Then of course when they come in conflict, you have neurovascular syndromes. From the meninges you have meningiomas. From the brain stem you have gliomas, which might require approach through the CP angle. And of course fissures, epidermoid. From the vitreous bone, the chondrosarcomas, endolymphatic sac tumors. I'll just show you some examples of these. So basically, we have this classical, and of course is the vestibular schwannoma. You can have it sometimes intracanalicula, which necessarily does not spill into the CP angle. Yeah, the next in line would be the petrous meningioma, then lateral meningiomas like this. Petroclival meningiomas which straddle all the compartments, the middle and the inferior. Yeah. The other group of tumors which you have to encounter or we have to approach through the cerebellopontine angle would be lesions like this, the epidermoids. Sometimes the brainstem cavernoma, as it's shown here, need not necessarily be in the cistern, but again, the axis is to the CP angle, so we need to be familiar with that. Then you have the ependymomas, which can come from the fourth ventricle and spill into the CP angles. And sometimes you need this approach for lesions within the petrous bone, like an endolymphatic sac tumor, or rarely, if you're a surgeon, again, a rare entity nowadays who clips aneurysms, you might have to reach a basilar, mid-basilar, or a vertebro-basilar junction aneurysm through this space, and of course the vertebro-pica aneurysm also through this retrosigmoid approach, or the cerebellopontine approach. But the classical or the main one would be the vestibular schwannomas, and for the resident's sake, for your exam purpose, you have classically 3 approaches described: the middle fossa approach, the translabyrinthine approach, and the retrosigmoid approach. And I would not be emphasizing on those 2 approaches, the middle fossa approach and the translab approach, because translab, again, I think Kuntal has a talk on this, comparing translab with the classical retrosigmoid approach. And then the middle fossa approach, just one word on that would be specifically for very small intracanalicular tumors. So I wouldn't put it as a classical cerebellopontine angle lesion, so I would not delve into that. So I will restrict my talk to retrosigmoid approach and its extensions of the retrosigmoid plus approaches, as I would say. So it could be an extension, as I showed earlier, superiorly, anteriorly over the Meckel scale, which can spill into the middle cranial fossa, or it could go medially, it could go in the retroclival or into the prepontine space. It could go down into the jugular foramen, it could go laterally, posteriorly into the, as I said, into the tentorial area. So basically we need, or as I said, as I showed the endolymphatic sac tumor, it can have a lesion which goes into the petrous bone. So primarily lesions which are confined to the CP angle, or lesions which have an epicenter elsewhere and go into the CP angle, or lesions within the CP angle which spread out. So you need primarily one approach, that is the retrosigmoid approach, and then you need retrosigmoid plus approaches to tackle all these extensions. So how do we go about it? So just a few words about because Adesh specifically told me, so I would just about the positioning, the incision, and the burr holes. So now you have 4 options: the lateral, the supine oblique, the park bench, and the safety semi-sitting. As Abhida mentioned, she preferred the semi-sitting, but I guess majority of us are comfortable with the lateral approach. And of course, if you have a slim patient with a very long neck, you can try the second one, the supine oblique. But you can see here that it puts a lot of stretch on the neck, and particularly not very happy doing that, because you can see in this position itself, the neck is put under a lot of stretch. But of course, if you have a very slim patient with a long neck, that is a viable option. A park bench position, I prefer it especially because the head is little down in this position. You can see the difference here in the supine and the prone position. Of course, it gives you a very parallel oblique angle along the petrous bone, and I prefer it when I need to tackle lesions which are quite anterior near the petrous apex. The incisions, now all these incisions revolve around these 2-3 lines rather. One is the mastoid tip, the digastric groove, and the other zygomatic line, which was again mentioned earlier. So you can have a multiple varied combination. You can have a semicircular incision, a straight simple incision, a lazy S incision. That is for the first 3 I've mentioned for the classical or simple retrosigmoid approach, and now that is your choice. And as beginners, I would recommend to go big. There's no point being doing fancy stuff with a small incision and struggling with the small exposures, especially in the initial, because there's a lot of muscles, as 3 layers of muscles which Abhida was showing, and your incision, if it is small, your bony exposure will be still further smaller, and then you need to struggle. So in the initial phases, prefer a lazy S or something big so that you have adequate exposure of the bone. And of course, the other incision which I showed you here is the ones which you need, like you have, as I showed you, tumor spilling out into the pre-sigmoid area, and you want to combine, you want a pre-sigmoid and a retrosigmoid approach, you need to have this kind of large incisions, which again are becoming obsolete because people prefer to do it in stages. And the last one is one where you need to go into the midline. You have a combination where you need to approach the midline, or you want to go far lateral. So you need this large incision. So these are the, in sum total, the major incisions which you would use to approach the CP angle or reach other corridors through the CP angle. The next is, once you have put the position, you put the incision would be the burr hole. And again, this is a busy slide, but just wanted to show you the number of research and number of publications that have been that have gone into choosing the ideal place where you need to put your burr hole. And the simple thumb rule would be just to follow the external aortic canal or the zygoma to the inion, and it would be somewhere in that area. But again, this is again just to show the position of the asterion, and Abhida had just shown it how, just to reiterate the fact that asterion need not coincide or need not correlate with the transverse sigmoid junction. And actually the best way is, because again, once you after you position, you lose all that orientation of the Frankfurt line or the zygomatic line. So once you open, it is better to follow the sutures which you are obviously going to see once you deflect the muscle. So the line from the squamous-peritomastoid junction to the mastoid, so generally that corresponds to the sigmoid sinus. And the junction of that to the occipitomastoid suture will give you the orientation of the junction. So best is expose that area, expose the sutures, the lambdoid, the peritomastoid, and the occipitomastoid, and that would give you a orientation to the so now, I'm just running short, so I'll just to run through the approaches. A simple approach, the trigeminal neuralgia, where you don't have much dissection or much exposure required, is a small craniotomy around the transverse sigmoid junction, and now it is called the asterional craniotomy, just something like the pterional craniotomy. If you want to go down, say a smaller approach for, again, lesions like hemifacial spasm, glossopharyngeal neuralgia, or maybe a small vertebroapical aneurysm, you just need to do, this is the incision. What is shown in the picture is the small incision and the small exposure, the bony exposure required, that we call it as a basal craniotomy. So if a small, in the retrosigmoid, you can have small exposure, the asterional and the basal craniotomies. But that does not suffice. These are okay for spasms and hemifacial spasms or neuralgia and so forth, but you have tumors like this, you end up doing the classical standard retrosigmoid approach. So you need the same exposure but a larger craniotomy, just expose the entire length of the sigmoid, and that is what we generally do for our acoustics. So this is just to show the exposures that you get through the asterional, the basal, and the combined approach. And generally for tumors, you go in for a combined, Then again, this transpetrosal, as the lesions which I showed you, like you have a lesion in the petrosal, all that you need to do is just keep drilling the bone over the sigmoid sinus, so that helps us a little more approach, which a little more access in front of the sigmoid into the petrous apex. But in the if you have more lesions inside the petrous bone, you need this extra, I won't go into the details, so you have this extra drilling of the supra, we call it the supra within. So these are all retrosigmoid plus. You do the retrosigmoid enter, and then you do the suprameatal, the transmeatal, the inframeatal drilling for specific pathologies. But then if you have lesions like this which straddle multiple compartments, like a type C trigeminal schwannoma or a large petroclival meningioma, you have these kind of various approaches which will be required. Generally a combined approach, or best is, as I prefer to do, is stage it. Never rush and try to do heroic surgeries and take out multiple compartment tumors in the same sitting. Better to do separate approaches. You do sigmoid, retrosigmoid one day, and then you can go subtemporal the next day. Then, yeah, just last. Then, of course, the far lateral and the esogloforamen approach, you are all familiar, just requires more bony drilling of the occipital condyle sometimes and the C1 arch. The transmastoid, as I just mentioned, you reflect the sinus more so that you have a more ventral approach. Lateral supracerebellar approach, especially for meningiomas in this location, and then when you have lesions like this, ependyma which straddles into the CP angle cistern from the posterior fossa, you need this kind of, so just to summarize, these as pteronal craniotomy is become the pteronal craniotomy for the posterior fossa, and you just need to add some extensions to it, which will gives you a panoramic view of the entire, I would say, a lateral half of the posterior fossa. Thank you.
Yeah, we don't need to introduce Suresh.
Yeah.
If you don't know
Okay,
Suresh, then you are not a
thank you.
neurosurgeon in India.
Sorry for that glitch. Thanks, Adesh, again. And let me tell you first, first I should clarify CP angle is not a single CSF space. It has multiple CSF compartments, as seen in this video. Okay. Okay, so what we are looking now is for a trigeminal neuralgia. You are looking at the acousticofacial system, which houses all the 7th, 8th, vestibular, all glued together. You see some CSF space here. This is the trigeminal system. Trigeminal nerve is there, totally in another cysternal space, lower cranial nerve, cervelo-medullary system. So CP angle area is not a single system. Let me go. Okay. Simple laptop is always better. So Professor Assergill, who passed away very recently, he always told us these tumors arise at the far lateral end of the internal auditory canal. That was his concept, and this was his concept. This tumor arises at the far lateral end, and then in the epiarachnoid space. And as this tumor grows towards the angle, it carries with it the arachnoid which was inside the canal. And this gets juxtaposes with the parietal arachnoid or the CP angle. Any surgeon who operates through a retrosigmoid or a translab route, he has to peel off this double layer of arachnoid. This is what I taught everybody, but is it true? No. Now we know that the CSF space extends up to far lateral end of the internal auditory canal. There is no potential epiarachnoid space at all. And this is a vestibular schwannoma which is arising inside the canal. Had it been arising at the far lateral end, this CSF space would not have been there. So now we know that these tumors arise inside the internal auditory canal. I don't be inside the internal auditory canal in the subarachnoid space. And this is the concept. Concept is this tumor arises inside the internal auditory canal, then gets adhered to the dura of the internal acoustic meatus. And this arachnoid adhesion moves towards the canal. So intra subarachnoid here, this behaves epiarachnoid to become subarachnoid again. And the arachnoid reflection is like this only. Tumor arises here. It is not like what Assergill has told. Then the duplication occurs like that. So you get double fold of arachnoid. And this is the tumor. If this is the tumor, capsule of the tumor is the epineurium of the vestibular nerve from where the tumor has arisen. And the arachnoid is stuck to the tumor. Arachnoid is always, seventh nerve is stuck to the tumor. If you understand that, you will start seeing the seventh nerve, and this is the arachnoid. These tumors are in the subarachnoid space, not in the epiarachnoid space. This is again one of the tumors which we operated at AIMS Bhopal only. I brought it. You can see this subarachnoid space at the far lateral and the internal auditory canal. 99% of the cases vestibular schwannoma is like this. Some 1% it can arise epiarachnoid. So these things have been told retrosigmoid approach. Everybody was talking about Frankfurt line and all, where exactly you make the burr hole. So first you have, let me see whether I have, no, I don't have that picture. So I will tell, to brief that I will tell you, you draw the Frankfurt line. This is the Frankfurt line. This is the Frankfurt line like that going. So you go to the top of the mastoid groove. You can palpate that, top of the mastoid groove. Draw a perpendicular to the Frankfurt line. Top of the mastoid groove, draw a perpendicular to the Frankfurt line. 1.2 to 1.5 centimeter is the distance where you should make that burr hole. Correctly, you will, that is the key burr hole. which what Girish Menon was telling. This is the key, one area key, small craniotomy, and this is all, vestibular schwannoma is all, the point I am making is these tumors arise subarachnoid. So there cannot be any arachnoid which separates the tumor from the seventh nerve. So just I will run it forward. First internal auditory canal or whatever you want. Identify the nerves there, running it fast. So you have identified the nerves here. I am running it fast. Already I have identified. I am going back to the cisternal part where I have decompressed and then connecting the canalicular part with the cisternal sharp dissection. And ultimately you can see the nerves are all flattened out nerves. Canalicular seventh nerve is here. So many a time you don't see it in a bundle and take it out. Next to go, I will show multiple videos in this limited time. Next. Thank you, boss. Patient after surgery. Again, one good video I will show. This is a little older video, how to do VLC. VLC. And then, yeah, say sharp dissection. You can use your scissors also. Peel off that initial arachnoid. How to run it now, boss? Eh? No. It's not running, man. Ah, fine. Okay. So now we are seeing the seventh nerve. You can see something like arachnoid here. This is not the arachnoid. This is the vessels over that arachnoid-like thing, which is the epineurium from where the tumor is arising. It mimics like arachnoid. Fifth nerve is here in another arachnoid. Lower cranial nerves are there in another arachnoid. So a membrane which mimics arachnoid, but which has a blood vessel over that is epineurium. And this is the patient, and this is this case is special because this we did at Bhopal only. So this is, after this surgery, small tumor, how to do that, man? Here. Yeah. So we have removed everything, and we thought we have removed everything. And then we put an endoscope and to see, they are seeing everything there inside. So endoscope assisted microsurgery. Again, can you remove it? Close it there. Next one. Now, jugular foramen. Same, jugular foramen tumor arises in the jugular foramen. Again, say it is separated from the seventh nerve by arachnoid. But it is not, it is the jugular foramen, 10th, 9th nerve, they are all glued together. They are not separated by arachnoid. So always this question, everybody says jugular foramen is a posterior, lateral or anterior approaches. Posterior approaches is what all of us know. Retrosigmoid approach, what we do, it approaches jugular foramen is a look down up to the cisternal part of lower cranial nerves. It is a look down. While you can do a look-up procedure is paracondylar. These two access the cisternal component of lower cranial nerve. But to access the jugular foramen, it has to be through mastoid process. It is either a superior lateral or inferior lateral. You can combine with cervicomastoid. And for other lesions like glomus, you have to come even an anterior approach. This is just, this is what all of us tell. If I ask somebody what is approach to jugular foramen, immediately they will tell it is a retrosigmoid. It's not correct. Retrosigmoid is just to the cisternal part of jugular foramen. You can come far lateral, a look-up procedure to the jugular foramen. Rest of the things you have to do other approaches through the mastoid bone or coming from above. These are the colors. I won't waste time. Here, can you do the same thing here? This is a jugular foramen schwannoma. Again, you can see the perineurium we can dissect. I'm sorry. So this perineurium you can actually peel away. Let me see. I will just show you the perineurium. The perineurium is coming there. It's not arachnoid. It's the perineurium. So this is all subperineurial dissection. Can you just escape? Next one. So this is, vestibular schwannoma. You should know that it is something, you should work in a hospital where you have enough load and sharp dissection. Everything is sharp and all. And the arachnoid peeling, initial double fold you have to peel, intratumoral decompression, no coagulation over the surface because it loses your plane, circumferential dissection and intrameatal removal hemostasis. And giant and large vestibular sternum and lower cranial nerve sternum, you should know that there is no arachnoid which separates it from the adjoining nerve. In vestibular sternoma, which arises from the vestibular nerve, there is no arachnoid which separates it from the seven. Like that, a jugular foramen schwannoma, if it is arising from glossopharyngeal, there is no arachnoid which separates it from the vagus nerve. Thank you very much.
Thank you, Suresh. I think we'll take the questions at the end. Yeah.
Next speaker, please. Dr. Rajneesh Arora from Rishikesh. Approaches to the pineal region tumors.
Very good morning to all of you, respected chairpersons, and I thank the organizers for inviting me here. So, during the last century, many approaches to the pineal region has been described, including supracerebral infratentorial, occipital transtentorial, combined approaches, posterior transcallosal intrahemispheric, transcortical transventricular, and ETV and biopsy. Out of these all, the most commonly used one are the supracerebral infratentorial, the occipital transtentorial, and the posterior transcallosal intrahemispheric. To choose a correct approach, one has to take into consideration many things like what is the location of the tumor, whether it is central or paramedian, whether it is extending supratentorially or infratentorially, then what is the venous displacement and how is the slope of the tentorium, and further the patient, whether it is having a sloped neck or supple neck, or we can position him according to sitting or some positions, etc. So like in the diagram A, and B, you can see that the deep venous system has been shifted up and the slope of the tentorium is good, so you can approach them by the supracerebral approach. However, this lesion is displacing the veins downwards and also pushing the splenium anteriorly. So you can simply go ahead with the intrahemispheric approach. And in the last picture, it is the tactile glioma which looks to be a high grade, and the slope is again very steep. So in this, to reach the inferior pole of the tumor, an OTA approach would be the best. So this slide summarizes the comparison between the three major approaches. The supracerebral is essentially a midline approach. The occipital transtentorial is the widest, is the approach which gives you widest exposure and is suitable for tumor which are having lateral or supratentorial or large inferior extension, and in patients where the torcula is low-lying or the slope of the tent is very steep. But the problem with this approach is that it is a oblique approach for essentially a midline lesion. So a novice who is starting with this approach might be disoriented in initial few cases. The intrahemispheric approach is suitable for lesions which are truly in the posterior third ventricle without extension posterior serpulinium. The occipital transtentorial approach has been described beautifully by Dr. Anita yesterday, so I would be going through the Krause's approach. So she was a 44-year-old lady which has a moderately sized tumor filling the whole of third ventricle, and she was operated in sitting position. The head is fixed in 3 pins with the legs at the heart level and appropriately padded. And this is how the patient looks from behind. These are the markings. I'm sorry, I've done the marking on another patient because I forgot to take the picture. So the incision extends about 6 centimeters above the inion and up to the C3 spinous process, and this is the marking of the transverse sinus. So this is how it looks after the exposure of the bone. So we have made 2 burr holes, one above the inion, another below it, 2 across the transverse sinus, and this is the extrapolation of the superior sagittal sinus over the craniotomy. You can use navigation. I use BrainLab system. And this is the, after the craniotomy, we preserve the rim of foramen magnum, and these are the bilateral transverse sinuses and the venous confluence which is visible. So after the craniotomy, the dura is reflected upwards and microscope is brought into position, and now we are starting with the microscopic work. The cerebellum is covered with the moist cottonoids, and now we focus the microscope to the apex of the tentorium, where the cerebellum is adherent to the apex. These adhesions are divided. The arachnoid in this region is generally quite thick and opaque. So one should be wary of the fact of where the nerves could be. So though they are not visible, but one must appreciate that this must be the likely position of Galen and the basilar vein of bilateral basilar vein of Rosenthals. They are not visible, so to avoid injury, you should anticipate where the tumor might have displaced based upon the preoperative radiology. Sorry. The arachnoid dissection is done essentially in the same way as you does for a Sylvian fissure. You can use the needle knife and the micro scissors. The idea here is to protect the deep venous system. So this brings the tumor into view. Now I'm dissecting the arachnoid over the precentral cerebellar vein. The precentral cerebellar vein has been now denuded, and it can be easily divided, but close to the cerebellum, not to the near to the vein of Galen. As I'm seeing the lateral extent of the tumor, it is bleeding on touch, and it was a moderately vascular tumor. Now the standard microsurgical procedures, you have to coagulate the capsule, divide it, and go inside. The advantage of sitting position is that whatever you use like irrigation, blood or CSF would come down, and your feed would be generally clear. So here the tumor is taken for biopsy, and if you see, the blood is trickling down. Suction, coagulation, irrigation. Now I'm using a cottonide for a hemostat, for a tamponade. And I'm looking at the lateral sides. Now, after decompression of the tumor from one side posteriorly, I switch my dissection to the other side. Again, the same principle, coagulation of the capsule, then internal decompression. So we have done the posterior decompression from both sides. Now using high magnification, I'll focus on this area, which is the anterior part of the tumor, occupying the anterior third ventricle. And you will see the glimpse of foramen Monro here. Now the tumor is separated from the walls of third ventricle on the right side. And the procedure is repeated on the other side. So this is one of the blind spot in this surgery, which is anterior to the cerebellum. So for this, you have to depress the cerebellum, either using a self-rotating retractor or the suction, as I'm using here. So in tumors which have a large extension into the cerebellum mesencephalic system, one has to use the occipital transnatural approach, because this part of the tumor would be left invariably then. Here the tumor was a bit of a fibrous one, so we has to use scissors and all those things. So this is small remnant in the 7 o'clock, 8 o'clock position. So after this, large part of the tumor has been removed, and one can see clearly the foramen of Monro on the right side with the choroid plexus in it. Similarly on the left side. One must inspect the walls of the third ventricle for any thin layer of tumor which is there. And it is clear now. So Sagittal is used temporarily. When the hemostasis is done, you can easily remove the Sagittal after that. There is no need to leave any hemostatic material inside the ventricle unless absolutely required. So this is another blind spot. where the vein of Galen is formed. So if you see this area, I have left my bipolar here. I'm using a microbayonet forceps just to avoid any coagulation near to the deep venous system, because any coagulation can initiate a coagulopathic cascade in the deep venous system and can be dangerous for the patient in long run. So now I have removed the excess surgical which I applied and using the irrigation to see, and the returns are clear. That means hemostasis is adequate, and then the dural closure proceeds. We generally do not extubate these patients on the table. Because of this, because the sitting position has a complication that pneumococcus would be quite significant at the end of surgery. And this is a patient on the same day evening. There were no motor deficits, and neither there was any difference of the extraocular movements. This was CT 2 days after surgery. Air has been resolved and there is no significant hematoma in the operative bed, and patient did fine. So take home messages are that the case selection is important. You should respect the venous anatomy and avoid any coagulation near the deep venous system. You have to leave minimum hemostatic material inside the ventricular surgeries, because that may lead to obstructive hydrocephalus later on. Endoscope can be used as a useful adjunct. Thank you.
I would like to invite our next speaker, Dr. Amit Thapa from Kathmandu, and he will be presenting his work on use of ultrasound guidance for foramen magnum decompression.
Thank you, chairpersons. Thank you, chairpersons. Well, at the outset, let me thank the Skull-Based Society of India and the organizing team, particularly Dr. Adesh, for creating such a wonderful platform. It had been very interactive and very academic section for all of us. Well, I present here a very unique topic, which I do not see any second presentation on it. That is the use of ultrasound guided foramen magnum decompression for carry malformation. I think this is a way to go ahead for, and I will be discussing how we are doing it, and it may be a sort of a discussion point where we can discuss about it much more ahead. I have nothing to disclose in this except for the fact that this is a proof of concept presentation which I'm doing it, and it's open for various suggestions, and it is purely academic and education sharing. Well, POCUS, as we all know it, is a point-of-care ultrasound, and we call it as a POCUS rather than an ultrasound because we are not doing a detailed analysis of these structures. We are only answering few questions, very specified questions, when we are using it for an intraoperative purpose. And we all know POCUS is cost-effective, it's a non-invasive procedure, provides a real-time information. It's very specific in diagnosis and therapeutic utilities, to such a point that it has now become a superior imaging options in emergency and critical care setting. However, in neurosurgical practice, it is not routinely being used, maybe because of the learning curve. And that's why we also started very late, maybe after, I think, almost a decade after I was entered into a medical practice, I was using ultrasound in my practice. And we used it as a first course in 2012, where we started using it systematically for resuscitation in emergency. And this is something I think is one of the best intervention we had, because now I'm proud to say that in Nepal, most of the emergencies are using this ultrasound-guided resuscitation procedure, and we are getting very, very well-managed patients when we are referred to the definitive care. So there's a way to go ahead with this, and also we have used it in an ICU setting, a systematic protocol, where we have identified that 1 out of 4 patients, where we are using these protocols, patients have been benefited. We have been able to give these patients an intervention which was far more easy and faster as compared to any other diagnostic therapy. I'm coming back to this slide. There's been some fault. So this is something which we have realized has helped a lot in the patient's care. However, so this is how we are doing it. We have a routine protocol in which we actually follow it on a day-to-day basis, and all these POCUS is being done by our ICU registrars, by neurosurgical team who does this on this routine basis. Also, we have published our report on how we can use it to identify the patency of the shunt, VP shunt, in an outpatient basis. However, the focus of this talk is how are we using it for the carry malformation. Now, when I say carry malformation, this particular study is very specific for type 1, where we are dealing with a tonsillar herniation, which is leading to a syrinx formation. Now, we all know that in carry malformation, because their tonsil does not ascend further, there's a crowding at the level of the foramen magnum. There's a compression over the cerebellum, the medulla, and the brainstem, which can cause various clinical manifestation, as well as the CSF flow abnormality can not only cause hydrocephalus above, it also causes syrinx below. And this particular pathology, which we are dealing now, is by a surgical option of decompression. Now the problem is that there is a lot of things which we can do in the surgical decompression. We can just do away with a foramen magnum decompression, plus minus remove the posterior arch of the C1. We can do a duroplasty, expansion duroplasty as they say, or we can do a tonsillar manipulation, which can again be a selective repositioning or reduction or resection of the herniated tonsils. Now this is a small video of how we are doing a tonsillar reposition, or rather reduction in this case. The idea is to open up the fourth ventricular roof, so the apex needs to be open, and this whole procedure has to be bloodless. So you can see in the video we have tried not to spill even 1 millimeter of blood in the cavity, so that the patient do not have a post-operative adhesion, and we finish it up with a expansion duroplasty, as we all do. But again, the question lies where to stop. Will that a bony decompression is good enough? Should we add it with the expansion duroplasty, or we should go with a tonsillar repositioning? Now, to answer this question, we can use a point-of-care ultrasound in the operation. How? So the idea is that just after the foramen magnum decompression, we can use a linear ultrasound, place it sagittally over the operative site, and see whether the tonsils are way above the bony landmark, that is the C1 posterior arch. If in case it's not the case, then we can even eat away the posterior arch of the C1. There's a point catch that we also have to look for the fibrous band, because sometime even after removing the C1 arch, we will see a thick fibrous band which is not allowing the CSF to flow underneath the dura. So for that matter, we have to also see whether there's a free excursion of the cerebral tonsil with each respiratory effort, and then there is a freely flowing CSF from the foramen of Magendie into the central canal and the subdural spaces. If the answer to any of these questions is yes, that means you have achieved adequate decompression. You do not have to go to the next step. So this is how we can actually do it serially, point by point, the use of ultrasound to answer our questions and then lead to the next step as to how much extent of decompression we require. So this is just an explanation of what we are doing. So this is a case of a syrinx with a carry type 1. So you can see even after the bony decompression, the patient do have a thick fibrous band which is not allowing the CSF to flow under the dura. This is the foramen of Magendie. This is the cisterna magna, from where the CSF is not flowing inside the central subdural spaces below. And also you can see the tonsil is still stuck way below that particular margin. So this means just by bony decompression, this patient is not going to be healed. So we need to move ahead. Now, this is one of the pictures from our publication. So this is the linear ultrasound, a usual linear ultrasound, which is available in most of the ultrasound machine. So this is how it appeared after the bony decompression, and this is after the expansion duroplasty we have achieved. And you can see the CSF is now flowing way down, the cerebral tonsils are moving up. So this is a very good method to even satisfy yourself clinically inside the theater that your decompression is adequate enough, and this is the point where you can stop. So this is before the duroplasty. As you can see, there is no movement and there's no flow of the CSF, but here you can see even with the respiratory excursion, the tonsils movement is free and the CSF is flowing throughout. So this was after the duroplasty and tonsillar manipulation. So this is how it looked like. So all the patients in this series we have actually followed up with an MRI, and this was within 3 months of the decompression. The syrinx is all gone, the patient is doing better. So in this study, we had actually done a retrospective analysis of 10 patients divided into 3 groups. And even by just posterior fossa decompression, we could have a benefit in almost 100% of the patient. And despite of not having a good clinical improvement, or rather a very satisfactory improvement in the most aggressive form of decompression, we did find that almost all patients with syrinx improved on the syrinx. So there was not a single case in which we have to come back on the procedure to have an extension of the decompression. And we did publish this in 2022 also. However, this study is limited because of a small sample size. In our place, we see much more of a carry 2 rather than carry 1. And also because most of the patients do not come for our follow-up, so we could not get the proper MRI in the follow-up patients. So that's why we have to restrict this case number to 10. However, the study is still ongoing, and now we have actually got an approval from the from our ethics committee, from National Ethics Committee, to run our multi-centric trial or sort of thing. So I invite all of you from India, for various centers, to please contribute your sample if in case the institutes allows you. So we can actually develop on this particular study, and then we can find out whether this is reproducible and we can have a good outcome on these patients. Second thing is, of course, it's an operator-dependent modality of investigation, so most of us may not feel that much confident enough to use an ultrasound. Idea is to place the ultrasound probe lightly on the tissue structure which we're trying to scan, because the moment we push it hard, all the benefit is lost. We'll not be able to see the CSF flow underneath. So this is something which we have to have that tactile sensation of how much pressure we have to put it on the operative part. But then this is not a very steep learning curve. One can learn it within 1 or 2 procedures and can use it very much easily in the subsequent things. So fear of not using an ultrasound, which we all have during our MBBS days, this is something which is unfounded, and we've also documented it in short studies where we have been running courses, and we have found that the patients, that the study subjects had a very good confidence after just attending few of these sessions. And we have even promoting that we can use the sonoscopy or POCUS in the undergraduate medical education, so that they can get exposed to this technology as soon as possible, so that they can actually use it in the subspecialties or in the specialties later on. To take home message would be that a point of care ultrasound, it provides a real-time visualization of structures. It allows confirmation of adequacy of decompression. This can limit the surgical decompression, which is often asked for and has been found to affect the outcome in the resolution of syrinx. However, it requires a multicentric study, and of course, I invite all of you to be a part of it. So we are running a WFNS Foundation Postgraduate Training Center in our place, and all the trainees are invited to join us. This is a supported program. And also, we open an invitation to the 5th International Conference of NASON, Diplomat Society of Neurosurgeons. This time, this is being conducted with in association with WFNS, ENS, and the Singaporean neurosurgical team. So this is between 13th to 15th of November, a best time to visit Nepal. I heartily invite all of you. Thank you for your patience listening.
Thank you, Amit. That was an elegant presentation. You're just lucky that Dr. Goyal is not here. But any other question, comment you can ask. Yeah, please go ahead. Use the microphone, no?
Microphone.
Can't hear it.
Nice presentation, sir. We have some experience on using ultrasound for this treatment modality. I just want to ask how many times you have to just done bony decompression based on your ultrasound findings, you know?
So in this series, we have done in 30% of the patients, only bony decompression, not even lax duroplasty.
So what are your criteria, you know, for leaving the patient with only bony decompression?
So the one I said was, is that if the tonsils are actually way above the bony level. Second is that with each respiratory effort, the cerebral tonsil should move up, allowing the free CSF flow from the cisterna magna into the subdural spaces in the cervical canal. So if in case you see all of them, then you don't need to open up the dura. The bony decompression and the fibrous band decompression is good enough.
Yeah, I think Dr. Suresh, yeah.
Question, suppose the tonsil is descending below C2, what will you do?
So like in any other microsurgical decompression, we open up the dura and then we see how much thick is the fiber, is the bands.
I know that, but will you remove C2 or not? That is the question.
So, but then, we always try to open up and see whether the tonsils can be mobilized ahead, mobilized up. If in case it can be mobilized up, then there's no need to remove the C2.
Yeah, but C2 one should try to not to remove because
Yes.
it gives tension band. So if at all it has to be, it is not ascending up of what you have told, then you have to supinely exercise that rather than removing C2 spinous process. Understand?
True, sir.
Yeah, please go ahead.
Yeah, Dr. Kuntal.
Very nice presentation indeed. Me and Kamlesh, we work in the same institute and we have some experience of using this. So the way we do it is, any patient who has a Chiari malformation and a syrinx, there is absolutely no way this patient is going to be relieved by only bony decompression. And there are studies to prove that. So the way we do it is, any patient with a syrinx will invariably undergo duroplasty, no matter what the finding says. What we can really utilize this ultrasound is for those who have a syrinx, who have a CRE symptomatic, but no syrinx as such. So those are the patients who we really don't know how many of them are going to be relieved, or how many of them are going to have a syrinx later on during the follow-up. So by doing this categorization, maybe we can make it more effective, because if there is a syrinx, I have never seen a patient who improves only with a bony decompression. Thank you.
Yeah, there are many ways of doing a thing. Any question to comment? Thank you, Amit. Any question to Dr. Suresh Nair and Dr. Girish Menon, their presentations? Amit, please, thank you.
Yes.
Suresh, yeah, so I think, if there any other question to Dr. Girish Menon or Dr. Suresh Nair? No other question. Thank you very much. We'll close this session.
Thank you, sir. So starting with the session 3, that is schwannomas and paragangliomas of posterior fossa. The moderator for the session is Dr. Narsingh Rao, sir. May I call upon the stage the honorary chairpersons for the session, Dr. Sandeep Sorte and Dr. Ali Asgar Moyadi.
Good morning, everyone. Is Dr. Narsingh Rao here, our moderator? No, Dr. Narsingh Rao? Okay, so if there is no moderator, maybe we will double up as moderator and chairpersons. And with that, I think I'd like to invite Professor Mishra for his talk on complication avoidance in vestibular schwannoma surgery. Dr. Mishra needs no introduction here. And over to Dr. Mishra for his talk.
Thank you, Ms. Chairperson. Thank you, Ades. This has been a great meeting. The hall is full. At least yesterday it was full. There was no place to sit. So it's a great job. And I understand you supported a lot of young neurosurgeons. That's a very good thing to do. So as you grow older, you see more and more complications. And so you need to know how to avoid, and if there is a complication, how to manage it. So before I go into that, I would like to invite you all to the meeting of neurosurgery meeting of 2026. That's in Mumbai. This will be the Masin Congress, Majid Sami Congress, the International Conference Cerebrovascular Surgery, and the International Neurosurgery Update. Please join us. So this is based on my personal experience of 1,000+ microsurgery, and the list is there. The patients which I have operated, 17% have gone on to get radiosurgery. So these are some of the aspects I will try to cover in this short presentation. So the first important thing is the positioning. And now most of my cases, I do now lateral position. I'll tell you why. The important thing in lateral position, this arm has to be beyond the table. If it goes on the table, the neck veins gets compressed. So that's critical. And then, of course, all the pressure points and all that, you can get it checked up. This humans, there is a volume first chapter, you can check it out. Now, if you're doing semi-sitting, which we do sometimes, the foot has to be above the neck vein to reduce the risk of air embolism. And we already discussed about the position of the hole, so I'll skip that. Now, we all know about the air embolism, and these are some of the critical things you need to take care of. You need to have the transesophageal echo, which we do all the time, central venous access. This is one of those few cases of brain tumors where the anesthetist uses PEEP and the blood volume is full before you start the case. All of the patients we try to dehydrate, but you are doing semi-sitting, blood volume has to be full. I'll tell you why. Now, if there is an air embolism, this is the way to go. They compress the neck veins. So 2 anesthetists are required. One has to compress the neck veins, and the other one has to aspirate the air. So that's a video actually showing the air embolism. Now, it's also very important, which is not so much emphasized in the literature, is to avoid
hypotension. I'll show you an example. This is a lady with this giant acoustic on the right side, which operated. Everything went on all right. The face was saved. And we were very happy the patient woke up with paraplegia. Now, so this is, you see, we took the patient from the theater to the MRI. There's a diffusion restriction there, and that was the cause of paraplegia. When we analyzed our anesthesia records, there was a small, transient, short period of systolic BP below 90. So in my theater, the anesthetists are instructed that if there is a semi-sitting, the systolic BP should be above 100. So what we do today, this is actually, we had a period of time, one of my residents was doing a dissertation, prospectively analyzing if there is any problem of semi-sitting. All the patients of posterior fossa, most of the retrosig approaches were done posterior fossa, and we did find some complication, which is not controlled by the surgeon. I can't control it. So today, most CP angle tumors in my practice are done in the lateral position. I don't do in semi-sitting anymore, except the pineal or giant upper clival tumors. Now, during craniotomy, avoid injury to sinus. This is from Fukushima book. Now, so we do a craniotomy today. So we do is the craniotome, but we don't do it over the sinus. The trick is the emissary veins is about 2 to 3 millimeter lateral to the emissary vein. You find the sigmoid sinus. So once you see that, you do a craniotomy from here and you drill it on this so that you do not inadvertently tear off the sinus. If you tear up the sinus, what do you do? I'll show you one video there. Now the positioning, again, the head is turned when you're doing a retrosig approach. So the vertebral artery gets rotated medially. So one has to be aware of that. So you're going to avoid that. The Legy S, so that the lower down the incision goes more medially. If you want to open up the foramen magnum or C1, go onto the midline and subperiosteally dissect out the C1, and that's one of the ways, especially if you are a resident training program, to avoid the injury to the vertebral artery. Now, during tumor interval, this is very, very critical. I have been emphasizing this for the last 40 years. Monitoring, monitoring, monitoring. It can't make a bad surgeon good surgeon, makes a good surgeon better surgeon. The quality of function preservation is definitely better, and this should be the standard of care according to me. ISC drilling, again, there's a lot of some people, very elegant demonstration without drilling. To my mind, if the internal artery canal is not destroyed, the petrous is not destroyed, drill it. That's the only way you can do a good total excision with preservation. A narrow drilling causes the problem. People who have problems, they do not drill enough. So it has to be at least 180, but maybe 250 drilling, and I'll show you the video on that. Now, ISC drilling takes the total tumor, and you don't need to drill if you want to preserve hearing. You preserve the labyrinth, so you drill about 5 to 6 millimeter, and lateral part, you use the endoscope assistant, and that helps in total excision. I'll just show you one video of one operation. Again, time is short. This has to control the time, since I have come all the way. Now, this is a Coos-3 tumor, and this is the superior. This is edited by one of my residents. The transverse sinus, sigmoid sinus, no advantage of extended retrosig approach. They tell you that go beyond the sinus, don't do it. That it just increases the complication. That's my first step. The ascending pharyngeal supply most of the acoustics, so that's the blood supply, the petrous part, so you coagulate that. Now, staying in the tumor arachnoid plane, Dr. Suresh and I told about the epineurium, whatever it is, there is a shining membrane, stay away from that, whether it is epineurium, arachnoid, whatever. Now, enough decompression before you go for getting into the nerve dissection. So, lot of. Now, this is not a sharp dissection. This is a blunt dissection with my suction. Without a suction, that's a calibrated suction that's using as a decompressor, and also this is trying to find a plane between the tumor and the normal structures. Now, the trick is if you do not know where it is exactly, or on the side of the tumor, leave a thin sliver of the tumor. You can always come back and take it out, but don't err on the side of the normal brain. Or if you hit vessels or blood, there is bleeding. See, this is a blunt dissection. A lot of blunt dissection here, not sharp dissection. There's sharp dissection when you're very close to the nerves. Now, again, this is two-hand tackling. My one hand is lifting up the tumor. The other hand is trying to take out the membrane. It's not written there, what is it, arachnoid or epineurium, whatever it is. Every normal structure is beyond that. All abnormal structures is inside that inside that tumor. And I'll show you why sometimes I think it's still the arachnoid, which the tumor becomes extra arachnoid because of adhesion or whatever. Now we have done that. As I said, we do with the drilling. Now I'm doing a two-hand dissection. Now I go to the drilling. Now first is burr, because that fast drilling, and then once you reach very close to the last parts of the bone, you use a diamond drill. A lot of irrigation. Now there's a wide drilling there. You see there is a wide drill. That's very important. Otherwise your instruments, you cannot use that there. Now sharp cutting, there's a dura going inside the intra-aortic canal. So open that. Very low CUSA, reduce the tumor. Okay? So once you have decompressed and then enough decompression, then we use, now you see these layers of the last layers of the tumor are there, then I use a hook, I then use the nerve stimulator, dissector, and different instruments in trying to take out. Now there is no way you can achieve this total excision, even with endoscope assistance, in a tumor like this without the intra-aortic canal drilling. You're leaving a lot of tumor there. So this makes it much easier. It doesn't make difficult. You need to know how to drill it. The critical point when you're drilling, don't leave any patty there. No patties in the field. That would be disaster. Now you see the nerves are just coming into view. There is a nerve stimulator, hook and stimulator. Now I'm stimulating the nerve, that's the facial nerve. And now you see that is the arachnoid intact over the nerves. And that membrane I want to respect. And that helps me to and then I will close. And the one more important thing, when I close, I reinforce this is a linear incision. There is no lateral cuts, and that helps in watertight closure. And I reinforce this line, even if I do a watertight closure, with fat, which is sutured on that line. And that has reduced my CSLF leak significantly. And this, of course, is a very good function, not always true. Now what happens if it bleeds from sinus, from the tumor, or whatever? Don't coagulate. I'll show you a short video. I'll show you this is a tumor, solid cystic, CUS4. And now this is, as I say, we have a resident training program. They do it. Now this is when I'm called. This sigmoid sinus has been opened up. Don't panic. Just leave a little bit of gel foam there, and then put glue, put another layer of gel foam, patty over that, leave it. You do not need to suture it. You do not need to put a graft over there. It will close. Don't push the gel foam inside the sinus. Don't block it. Just over this. And then if you have a bleeding inside intra-aortic canal for a high jugular bulb, again the same thing. The venous bleeding, do not coagulate. Tamponade, gel foam, hemostatic agent, glue. That's it. Every bleeding will stop with that. Just bear with me for some time. This is bleeding. Now immediately put it, because there's a lot of bleeding there. In a semi-sitting position, this could be disaster. This could be life-threatening. In lateral position, it's not so much. I put a lot of gel foam, which I'm going to take it out, because I want to still drill it. My drilling is not over. So once I get then, my hemostasis is there. So I put a little bit of gel foam with glue. I take out that big gel foam piece, and it's a very small gel foam piece, which I push it slightly inside the jugular bulb. Again, not blocking it, but just slightly push it in. You'll see that there. With the glue there, I pushed a little bit so that I have still space to drill it, and then I leave it for a few minutes, and then I come back and I can still drill that and do a total or near total excision. Now, if it bleeds inside the tumor and the brainstem end, again the same thing. Brainstem end, you damage the brainstem, you damage the nerves because of venous bleeding, not arterial bleeding. Inside the intra-aortic canal, arterial bleeding. Now it's bleeding on the vein, the brainstem side. Again, the veins, you have breached the pia here. When it starts bleeding, venous bleeding, it's breached the pia. So stop there. Again, gel foam, patty, glue, and that's it. No, so I don't have time to go through theory. There's some of the things which has helped. This is something published. You can read it up. Using the sodium fluorescein. Fluorescein enhances the tumor, does not enhances the nerve. Because as we know, large and giant tumors, everywhere, everything looks like a nerve. So use this as an adjunct, and this is sometimes useful. It's in Neurology India, you can read it up. Finding the direction of displacement of the facial nerve, and that's the facial nerve, that is sometimes you know where is the facial nerve, and that's the facial nerve. then you know you're more careful when you reach there. And that's the pre-op DTI. We published it again, Neurology, and you can read it up. Now, air cells inside the intra-aortic canal, critical to take care of that, because that will produce a CSF rhinorrhea, and that can kill the patient. We have lost the last patient I lost in '99 because of CSF rhinorrhea meningitis. You see that air cell there? Sometimes it's not seen under the microscope, so put your endoscope there and you can see, and this has to be patched. Now, if it's a small opening, the bone wax is enough. If there's a large opening, put fat inside, then bone wax, and then gel foam and glue. This I will skip, and this I will skip. This is the, when you are operating on a post-gamma knife or post-radiosurgery failure, trick is to leave thin sliver of tumor. This has been published, please, you can read it up. And post-operative, last part of my talk, this is, again, this is a large tumor, very vascular, a lot of bleeding, post-op CT scan, there was subarachnoid blood, you see that, patient was all right, patient was discharged, and came back after 5 days with infarct. You see the diffusion restriction infarct, vasospasm, and this is because of the blood in the subarachnoid space. So wash everything. When you have finished your surgery, when you're drilling, everything try to wash out. Leave all the arachnoid that is intact. Wherever it is intact, do not open the subarachnoid space as much as possible. This patient, of course, improved over a period of time. This was published in Journal of Neurosurgery Case Lessons. So my paradigm today is intracranial tumor, always a period of observation, drop on hearing, increase growth, then only they go for this side. If an intracranial, very small number of patients, we're treating it, but if it's a good hearing, we still try to do microsurgery because we think we can preserve hearing. As opposed to that, an extracanalicula, 2 centimeter, 2.5 centimeter tumor, earlier on I would advise microsurgery for patients who had good hearing. Today I don't do that because we have analyzed, we published again our last 100 cases, and we have found that hearing is better in radiosurgery in our hands in small tumor, 2 to 2.5 centimeter tumor, rather than in microsurgery. So we give that option to the patient. Or large tumors, of course, the function preservation is critical. It's critical to have the facial function. Hearing is a bonus. So leaving some tumor attached to the nerves is absolutely appropriate. Unfortunately, the last bits of the tumor creates the problem, and that unfortunately comes with the experience. Thank you very much for your time.
Thank you, Professor Mishra. I think it's very important to have a systematic approach to any surgery to avoid complications. We don't have time for discussion right now, but I think we have some time in the session because we don't have one talk, and we'll do that at the end of the second talk.
For next presentation, we invite Dr. Kuntal Das sir from Lucknow. He will be presenting on a comparison of
comparison of retrosigmoid and translab approaches to CP angle tumors.
Good morning, everyone. First and foremost, thank you to Dr. Adesh and his team for wonderful organization of this interim meeting, and especially for the hospitality provided. So I'm Dr. Kuntal, I work in SGPGI, and I'm going to present to you a small comparative experience of mine on retrosigmoid versus translabyrinthine approaches to vestibular schwannoma. So we have listened to the masters of vestibular schwannoma of our country, Professor Mishra and Professor Nair, and these are the modern day goals of operating on large vestibular schwannomas. The first and foremost is facial preservation, then comes maximal tumor resection, and hearing preservation, if it is there, it is almost always by chance. So the approach is nerve-centric. So it may appear that the role of surgeon in vestibular schwannoma surgery has actually reduced, but it is not. It is probably more important than ever that you have good microneurosurgical technique to deal with these tumors. All of us know, especially the students sitting here, that we have got 3 approaches to vestibular schwannoma. But unfortunately, in countries like ours, we most often get very large tumors, particularly in the era of gamma knife. Small tumors have stopped literally coming to us, and we have large tumors. And these large vestibular schwannomas often do not have any serviceable hearing. So as we all know, these are the situations where a translabyrinthine approach actually can come into play. But somehow, the neurosurgical community, we have a reluctance towards this approach. And the idea of my presentation is to highlight on this aspect. So what are the goals of vestibular schwannoma surgery? The most important outcome is facial nerve preservation, and studies have shown that the surgical approach that you take actually doesn't matter. It is the extent of resection, particularly in very large tumors. If the tumor is very large, if you want to go for total resection, the facial palsy rate is very high. So you have to be near total or subtotal. But apart from facial nerve, what are the other goals that we should be looking at as a modern day microneurosurgeon? That is postoperative persistent tinnitus. This can be troublesome. Then lower cranial nerve paresis is an absolute no in modern day microneurosurgery for vestibular schwannoma. And when everything goes right, you also have to pay attention to the fact that many of these patients would have postoperative headache. And cerebellar ataxia can actually lead to worsening in the quality of life. So a modern day vestibular schwannoma surgeon must look at all these outcomes and not only just at the facial nerve. So I'll show you two quick cases, nothing fancy, but just to emphasize to you the basic tenets of these two approaches. This is a 16-year-old girl with a right-sided large cystic vestibular schwannoma. And in a case like this, I generally like to draw this line. As you see, this line is actually going along the internal auditory meatus. And here you see that the majority of the tumor, more than 50%, is located behind. And this patient additionally has a dilated cisterna magna. So in a patient like this, you know that if you go from behind, it is going to be a much more easier job because you have to deal with a small amount of cerebellum. So in this patient, we took a right-sided retrosigmoid approach. This is a short video. We also use a right lateral position, the park bench. And we use, apart from triggered EMG, we use corticobulbar facial MEP, which I learned from Dr. Alice Santa. These are the baseline findings. Now, the beauty of this approach is you can drain out a lot of CSF from the cisterna magna right at the beginning. Now you have the cerebellum. Now it is very, very important to make the cerebellum lax. Once it is lax, you don't even need a retractor, as you see here. The tumor is thoroughly decompressed. And we utilize this Tübingen line, which has been described from Professor Majid Samit Center. This helps us reach the internal auditory meatus. The meatal dura is cut and reflected. And as Dr. Mishra rightly pointed out, we need to drill the meatus widely. We don't have to be thinking too much, particularly in patients who do not have any serviceable hearing at all. Now, this early access into the meatus is very useful. You identify the facial nerve there. Now, this is something that I wanted to emphasize. This is called subperineural dissection, what Professor Nair was showing. Now, as a neurosurgeon, I've realized that if you don't respect this plane, if you want to take it out like meningioma by going from periphery, you will always injure the facial nerve. So this subperineural dissection is very important. You see a thick band of arachnoid, or this could be compressed vestibular nerve, whatever it is, you need to stay inside it. Now, this is a tedious process because it can sometimes bleed, but this is the patience of the surgeon is ultimately what determines whether facial will be preserved or not. So you stimulate continuously, and structures which are not getting stimulated are not to be preserved. You can take them out. Now here you see that a thick arachnoid is present, and you can see the fifth cranial nerve beyond that. So we are working within it, and the tumor is gradually taken out. Now we come back to the meatal side again. As the meatus has been drilled, we have a lot of space there. And with the help of a nerve stimulator dissector, this is a very good tool. You can dissect and at the same time stimulate. You can tease out small remnants of tumor. Here, as you see, I'm not working outside the capsule. I'm still within the tumor. This is very, very important because sometimes the capsule is what contains the compressed and flattened seventh cranial nerve. And this is the area just outside the IAM that the vestibular schwannoma is most fibrous and badly stuck. So this is the danger point. And I generally like to leave some tumor over here. And this is at the end. You see good cerebellum and corticobulbar MEP. It did show 30% drop in orbicularis oris region. And as expected, this patient did develop some facial paresis in the post-op period. But at 7 months follow-up, this has nearly completely resolved. And you see the post-op scan. There is a very, very thin sliver of tumor which was left intentionally, and the facial outcome is excellent. And we're going to follow this patient, and if it grows, we can always go ahead with gamma knife. Now coming to the second case, a 45-year-old lady, and if you look at the scan, if I draw the similar line, what you see compared to the previous patient, this patient has mostly ventral tumor. The tumor is located in front of the internal auditory meatus, and in such patients, the cerebellar cover is actually thick. So a retrosigmoid approach in such patients can actually endanger the cerebellum. So in a patient like this, I generally go for translabyrinthine approach, and my otology colleagues, they help me. So this is the kind of incision that we make. The skin flap is elevated, and the muscular layer is divided in T so that it helps us in closure eventually. These are the structures that are exposed, the mastoid bone and the retromastoid area. This is the triangle of attack through which extended cortical mastoidectomy is done. It is very important to have some middle fossa exposure as well. This is the incus, and this is how we find out the position of the seventh nerve. And by sequential drilling of the labyrinthine structures, we reach the internal auditory meatus. This is the sigmoid sinus, and it is very important to have some retrosigmoid exposure as well, because you want to have a kind of wide exposure. The dura is cut in the pre-sigmoid region, and you see compared to a retrosigmoid approach, you expose only a very small amount of cerebellum, and you are right on the tumor. And since you have drilled the meatus, so the early meatal 7th nerve exposure is what you get here. The rest of the steps are pretty much similar. You decompress the tumor, you roll the tumor into the field. The beauty of this approach compared to retrosigmoid is you don't even see a lot of cerebellum. So you are right on the tumor. It is a true skull-based approach. You are right on the tumor. This is again compressed vestibular, which is forming the capsule. This is the 5th cranial nerve cranially. So neurostimulator is very, very important. Sometimes you may have to use a non-dominant hand as well. Now what you see here is the meatal 7th nerve, you see. Now on the brainstem side again, we can see the flattened 7th nerve. So this is the story of large vestibular schwannomas. They're seen well in the meatus, they're seen well in the brainstem, but in the central part they flatten out. And it is very, very difficult to preserve them. So the tumor is gradually reduced in size, and as I said, you can see the entire course of the facial nerve, the brainstem side, the meatal side, and just outside the meatus is where the tumor is badly stuck. It is almost always found this way, and we generally leave some amount of tumor here, and we have seen that this tumor generally remains indolent. Now the important part of this thing is closure. The incus opening needs to be closed, otherwise you'll have a paradoxical rhinorrhea. The fat which is procured from the fat is used to plug this area, and as Professor Misra has shown, this technique can be used in retrosig approaches as well. So this is how the eventual closure is done. This is the patient in the postoperative period. She did have initial grade 4 facial palsy requiring tarsorrhaphy, and you can see the fat in the posterior fossa. But at 2.5 years follow-up, the facial function is grade 3 or maybe grade 2, and you don't even recognize the tumor that was left behind. So this is what happens. If you leave small amount of tumor on the facial nerve, it kind of regresses over time, and you do not even need gamma rep in many of the cases. So how do I select my patients? Based on my experience of around 41 cases, this is how I do it. I generally draw a line along the internal auditory meatus. And if there is vestibular schwannoma, which has a very large meatal segment, or tumor which is predominantly ventral, with thick cerebellar cover or cerebellar edema, or if the patient has tinnitus in the preoperative period, which is although rare, then I'll probably go for a translab approach. Otherwise, retrosigmoid, as we all have been trained, in 70% of cases that is good enough. But in some patients, probably we can use translab. So ladies and gentlemen, what I would like to conclude is the role of microneurosurgeon in modern day vestibular schwannoma surgery is probably more important than ever. This is not a dead surgery anymore. You need to have good microsurgical hand. Still, we need to do what works best in our hand. But I would like to leave you all with a question that doesn't it make sense to be able to alter the approach to a patient based on the patient and the tumor characteristic? So we need to think about that. Thank you.
Thank you, sir. The session is open for discussion. Any questions?
I think both speakers, session is open for discussion for both speakers. So if there are any questions or any comments from anybody, for both Dr. Mishra, Dr. Kuntal. Maybe I can also ask, not a question, but thoughts on both of you, Dr. Mishra and Kuntal, mentioned about use of intraoperative monitoring. And in your talk, you also mentioned whether it's standard of care. Would you like to comment more or thoughts on that? Whether it should always be used during vestibular schwannoma surgery? And Kuntal, your thoughts also.
Monitoring methods were not available. Even then we used to have this the very simple, there used to be, I can't remember the name, but we used to have, we had a very primitive monitor, the monopolar monitor like that, which used to, like only touching, not the continuous monitoring which we have just now. And then we had the Medtronic had that disposable monitor, that also we had. Because the problem in our country, it fails. Monitor, whatever monitor you have failed. So you do have alternative thing. Now, if you don't have anything, you can use still the bipolar. With a very low current, you can use, say, bipolar, whatever you use. We put it at 2. which I don't have to do it now because I have fortunately, a little bit more, tech savvy department in my hospital. But even if you are in the most primitive center, you have a bipolar, you can use the bipolar in a very low setting. Go down to 1 or 2 in your setting, and you can still use the direct stimulation. Of course, there is more advanced. I mean, we use this advanced monitoring system. We are not using that. We just use the continuous facial nerve monitoring with that. I don't want to name the company, but that's a continuous. We get the waveform. So the muscles are all been, electrodes are there. We also use the BERA for patients who have preserved BERA before operation. Quite a large number of patients, even they say they can hear, you don't get the wave 1, then you can't do the monitoring. But otherwise, I'm a big fan of monitoring. Not very extensive like the Japanese Professor Kono, and I think maybe you may be doing it, I don't know. They have the direct electrode, what is it called? I can't remember the term, but the electrodes put it directly on on the cochlea and the facial. For the facial also. So they have direct stimulation. I mean, the stimulation goes not from the muscles, from the facial nerve and facial nerve nucleus and cochlea, which I don't have it. And they claim that the preservation is much better. So if you have whatever facility, whatever the most primitive or most advanced, do monitor. Some form of monitoring.
Sure. Dr. Kuntal, you're the...
Sir, I think vestibular schwannoma surgery, especially the large ones, should not be done without neuromonitoring, because it is very, very difficult to know where the nerve is. Like sir has said, many times it is compressed so badly that it looks like the capsule. So unless you have a monitor, it is very difficult. Regarding what monitoring, the bare minimum that I think is triggered EMG. But what I have shown in my video, what we have learned from Dr. Ali's center is corticobulbar MEP. Now I want to stress on that. What is that? See, when you use triggered EMG, you stimulate the nerve and you know where the nerve is. Many times what happens is the nerve gets transected at around the midpoint. It does happen, especially if you're using CUSA to thin out the capsule. So what happens is if you put the stimulator on the distal end, it will still stimulate and give you a false confidence that the nerve is intact. But in actuality, you have severed the nerve. The brainstem side is lying separately and the meatal side is lying separately. That is one scenario. And secondly, many a times we do intentional subtotal. Suppose there is a large tumor, the patient is obtunded, the patient is elderly. You do not want to even go for near total, you want to go for subtotal. But you want to leave small enough to be taken care of by gamma knife. Now how do you decide how much residual is what you are going to leave? So I think in both the situations, this combination helps. What does corticobulbar MEP does is you stimulate in the cortex, the area where the facial nerve nucleus is, and the stimulus goes in and supplies the end organs. Now it is different than triggered EMG. Triggered EMG just shows you the CP angle portion of the nerve, whereas the corticobulbar MEP shows you the entire pathway. So when the entire pathway is intact, then you know that your manipulation is safe. So in our experience, we use a combination of both. And when you use a combination of both, the false negative rate it reduces. And it has really helped us. So I think neuromonitoring is must for someone regularly performing these surgeries, particularly in a country like ours. It is very, very important. The bare minimum is triggered EMG, but if you have, you can go for advanced techniques as well. Thank you.
Yeah, very, very good. I think the most important advantage of not just triggered EMG continuous monitoring is whenever little bit of traction, physiologist wants, there's some signals. So your nerve is getting disturbed. So that is, I think, the most important thing. So we reduce, we put some saline and we stop that area, we come back. So that is the most important advantage of using a continuous monitoring.
Absolutely.
Mishra sir, do you regularly use fluorescein intraoperative as you are already using IONM? So when do you use it at which particular step? You use the intraoperative fluorescein. So do you regularly use in all the cases and at which particular step? Because you are already using IONM in those cases.
IONM, what Rupesh said is very important. If you have a continuous monitoring, it dictates when to stop, when to get away from there, and you get a warning. Both the audio and the waveform comes, and you also get a bip. And then the trigger, what we do is we put it at very low. This is very important that don't stimulate with the high current. So for example, you can in fact probably predict your function depending on what strength you could stimulate the nerve. Now, we start off with 0.08 in the machine which I have. I don't know what, I mean, there are different machines maybe. So I start with 0.08 stimulation. So if you are not able to stimulate by 0.2, your function is very bad. So by the, before, I mean, when I was starting the case, it is 0.08, it should get the direct stimulation, the trigger one. But by the end of it, if I stimulate, if I'm getting up to 0.1, I'm very happy about it because the function will be good. 0.2 beyond, patient will have a facial function. Now about this thing, though it is, many times everything looks like nerve, large tumors. So that is the time I can use this, not always. I mean, this is part of one of my dissertation of one of my residents who has already passed. And he did systematically, but we don't need to use it always. But if you have a doubt, it's very simple because immediate, you don't have to do it injection beforehand, you inject and then you can see it. You have to have the filter in the microscope, that's about it. It's a very simple thing, it's very cost effective, it doesn't cost money at all. So it's a useful adjunct. Manas has also some experience and Manas is also quite happy with that. He presented, no, that one? Yeah.
Okay. Last comment, Kuntal, quick one.
So just a couple of comments regarding monitoring. As sir has pointed out, you should not be stimulating the nerve with anything more than 0.5. If it is getting stimulated with high current, it means your nerve has lost some of its integrity. So it may falsely reassure you that the nerve is intact, but actually the function will go down. So 0.5 or below, as sir has pointed out. This is number one. And number two, a beautiful paper has been published by Dr. Roy Thomas Daniel, who is working in Switzerland right now. It's very, very interesting technique. You should all go through that paper. Many times we intend to do subtotal resection. But what happens, we end up leaving a lot of tumor for gamma knife. And the patients will invariably have some problem. So a technique that he has published is, you use the triggered EMG inside the tumor. Suppose this is a tumor capsule, you stimulate. And you put your current to 2 to 3 milliamperes. So there is a rule of thumb that the milliampere actually linearly correlates with the thickness of the tissue to the target. So if the facial nerve contraction is coming with a current of 2 to 3 milliampere, when the probe is inside the tumor, why you are inside, not outside, you tell yourself that 2 millimeter of thickness of tumor is lying there. So this is how he decides what amount of residual that he is going to leave, and he has shown in his follow-up that amount of tissue, it crumples over time. In 3 months' time because of brain pulsation, and it forms a mass, and that mass is absolutely gamma knifeable. So even to do subtotal resection taken care of by gamma knife, you need to have good technique, you need to utilize your monitoring. Otherwise, it almost always happens, sometimes with us, many times the patients have to get as referral, that a big chunk of tumor is lying there and you need to go for another surgery. So it doesn't actually serve any purpose.
So that's actually a planned partial resection, if I can just...
Thank you, Kuntal. Maybe because I think we are past the time. So thank you both speakers. I think it was a good session, and thank you for both of the speakers and my co-chairperson. Thank you very much. We'll close the session with that.
Thank you, sir. Starting with session 4, that is meningiomas of posterior fossa and foramen magnum and clival pathologies. The moderator for the session is Dr. Rupesh Kumar. May I call upon the stage the honorary chairpersons for the session, Dr. Manish Agarwal and Dr. Rajneesh Gaur.
We are moving down to further deeper. So we have 4 speakers. First I call Dr. Narsingh Rao. He'll speak on microsurgery on petroclival meningiomas, tricks of the trade.
Good morning. Voice is clear. Good morning, everyone. First of all, congratulations to Dr. Adesh and his organizing team for a wonderful conference. We are enjoying the conference from the day one. Yesterday, party was too good. Good singers, good talent I could see. So my topic is on petroclival meningiomas, the tricks of the game. We all know that the petroclival tumors are the difficult ones because they are deeply located with narrow corridors you have to operate. Whatever may be the skull-base approach, ultimately you realize that you still have to struggle between the corridors dictated by the vessels and the nerves. So that is the problem. You can do a lot of drilling also, but still the space at which the tumor has to be removed is small. So this is the fundamental thing which you have to understand. So we all know that there are difficulties. So what are the tumors you get here? Petroclival meningiomas, the most classical ones, the trigeminal schwannomas, cholecystomas, they are extradural tumors, chordomas, extradural, chondrosarcomas, and epidermoids. These are some of the examples which I want to just show the images. This is a cholecystoma, which is cystic. I mean, T2, it is hyperintense, and sometimes it can enhance in the contrast. This is a trigeminal schwannoma. This is a classical meningioma with a dural tail and a broad-based dural attachment. What happens is that these tumors, they don't restrict only to the petrous apex. Sometimes what happens is they go everywhere. They go to cavernous sinus. They go to, this is actually the clinoid meningioma, which is coming up. It has extensions into the cavernous sinus and also into the sella. Sometimes what happens is that it doesn't stop there. It goes to the sella, sphenoid, cavernous sinus. They are called spino-petroclival tumors. They're not strictly petroclival, but they go everywhere, as I said. Sometimes these tumors can also extend to the paranasal sinuses so much that they involve the sphenoid sinus, they go into the posterior ethmoids and also go down. So this is one kind of. So what are the surgical options we have? We have mainly the three. You have an anterior petrosal approach where you come from anterior side, and posterior petrosal approach, and there is one more thing which is called combined, where you can have the access from both the sides. That is called combined petrosal approach. These things are very simple. We know that you have three zones of the tumor's location. If the tumor is lying above the internal artery meatus level, you can come anteriorly. This is called anterior petrosal approach. The one in the middle, you go by posterior approach, and if there is an extensive tumor, you go for a combined approach. So this is what just wanted to highlight, that if the tumor is above, you can come by anterior, and if below, you go by posterior petrosal approach. So what is the learning curve? We know that these are the tumors which take out your time, experience, and you should have good three-dimensional knowledge. Most important thing is that you should have a mental preparation to do these kind of surgeries. They are very long and they demand energy as well as attention from you. I would like to highlight an important point here that we should not have a feel that, oh, this is a meningioma and I have to remove completely. You know, you should never have that feel, because it is the consistency which decides whether the tumor has to come out or not, and the plane of cleavage, which is very important, and you gain it by experience, that the plane of cleavage is very important. If the tumor is stuck to the vessel and the brainstem, there is no point in taking out and having a bad outcome. So we should have a three-dimensional anatomy. Why I'm emphasizing this is that we should not only see the MRI and CT, plain CT with contrast, we should also get a 3D CT to really get the orientation of what exactly we are dealing with. It's an important exercise. You do how many times you read, it is not important. You have to do it on the day before the surgery. You have to go to the console and see and feel the anatomy. So what important landmarks you have to identify is that the trigeminal impression. We know that the trigeminal nerve is there, and it is the impression it forms in the petrous apex, roof of the carotid canal, and the roof of internal acoustic meatus. This is arcuate eminence. The anatomy, you have to imagine anatomy. This is the worst thing in this place, because just by locating these structures, it doesn't make any sense, because inside what is happening, you should know. So if you know where is trigeminal impression, it is not sufficient. You should imagine the trigeminal nerve there, carotid artery there, internal acoustic meatus, and the nerves there. You should have that kind of an interpretation to really understand what we are going to do. This is the posterior surface anatomy, internal acoustic meatus, the sigmoid sinus, the endolymphatic duct, etc. But again, I'm focusing important thing that we should have if we drill like this in this direction, what is the structure I'm going to encounter? That kind of knowledge we should develop before we do these surgeries. CT preoperative workup is very important. We should know the anatomy of not only where the tumor is located, but how is the mastoid air sinuses. If they are aerated, it is easy for us. If it is not aerated, it is very difficult because the drilling takes more time. This is an important finding which I noticed, that if you have a sinus which is covered all over by the bone, you should be very careful in drilling because you may injure the sinus. So you should discuss how is the tumor consistency, is there any edema or not, and how the nerves are displaced, how the nerves you are going to encounter during surgery. You have to imagine and discuss with MRI, then only we can have, because by just seeing an MRI, it doesn't make any sense to us. Take for example, in this case, you have a lot of edema to the brainstem, so there is no point. From the beginning, you should have a reservation that this tumor is going to have a bad outcome, and a plane of cleavage is not expected to be fine in this. This is just an angiogram. Sometimes we do an angiogram to really know the blush of the tumor and what kind of vascularity we are having. If the vascularity is too much, you can even embolize, consider embolizing this. So intraoperative monitoring tools, whatever you have in your disposal, you have to use in these kind of tumors. These are big tumors, they are very difficult tumors, so whatever is accessible. You have navigation, SSCP, cranial nerve monitoring, QSA, high-speed drills, what all is there, but what is must is QSA and cranial nerve monitor. So same thing, anterior petrosectomy, posterior petrosectomy. Just I will highlight the anatomy. This is already discussed by my previous speakers. This is the most important thing in the anterior petrous apex bone, and how do you expose this is by elevating the trigeminal V3 segment medially and identifying the GSPN. So GSPN is an important landmark, and we cannot have any discussion on these tumors without having a thorough knowledge of GSPN. So GSPN starts from the geniculate ganglion, goes anteriorly, passes through the groove called sphenopetrosal groove, joins with the deep petrosal, and forms the median nerve. So for endoscopic surgeons, median nerve is important. For microscopic surgeon in this location, most important is the GSPN, because that's an important landmark. And how do we dissect this? There are various techniques, front to back, back to front, but I felt that going from posterior to anterior and always leaving a bit of dura as if the nerve is going to be there. That is the technique I follow, which I found that it is important to not to damage the nerve. So we should have this dural layer anatomy, just like cavernous sinus and the areas of where the double dural layers are there. So this is actually the GSPN. As you can notice that the GSPN location, just want to show in the cadaver dissection photograph that this is GSPN, which is actually lying extradurally. But when you dissect the dura away, it can get torn. That is the whole crux. So this is one example of anterior petrosectomy which I have done for this cholecystioma. Just want to show that, see, this is the V3, this is the medial side and lateral side. See, that's how you have to dissect, so as to think that, oh, every dural layer which comes out could be GSPN. So you can have a feel like that. You have to use monitor to locate, this is the cyst. So this is the GSPN. So you stimulate that GSPN, you will have the facial contraction, which you can see. That is the petrous apex, and of course the cholecystioma is, you can excise it by removing the capsule. Despite that, you see in this patient, there is facial because of the traction which the GSPN is used. So we should have controlled traction of even the GSPN. So the posterior approaches, they are a bit more difficult, as highlighted by the Kuntal previously. That the posterior petrosal approaches, you should have a thorough knowledge, and also the concept of the surgery is important. What we are seeing is that in a retromastoid, you are retracting the cerebellum. From the posterior petrosal, you go through the labyrinth, and based on the types of the extent to which you remove the labyrinth, you have approaches, transcochlear and translabyrinthine. The steps of the procedure, mastoidectomy you have to do, and you have to drill the bone over the sinus, which is very important. And of course, you should do retrosigmoid craniectomy also. So the important thing is that you open the presigmoid dura and temporal dura and connect with the tent. This is an important step which is highlighted in all these texts. But what I found is that you should open the dura as close to the bone as possible to avoid injury to the vena flabae. Incisions could be like this, but I give a different kind of incision. So this is that presigmoid approaches. As I told, this is the, if you want to take out entire labyrinth, it is called cochlear approach. These are the mastoidectomy highlights which are already there. I just want to show the video in lack of time. So this is how you do it. It is, I think Kuntal has directly identified, this is the facial nerve which you identify during the mastoidectomy. So this is just one case, which is the petrosal approach I had to do in this case because it's a large tumor. You have a brainstem distortion with the brainstem edema over there. The tumor is occupying, starting from the lower cranials to the middle cranial fossa to the, almost it is not involving the canvas. So this kind of incision I give because you have to have a bigger exposure. Instead of struggling with one incision, I use an incision like this so that you can do of a temporal craniotomy, do of the petrosectomy from this and also extend the posteriorly. So the exposure is like this. You have to have an ENT colleague if you have, but otherwise we can do it. But I feel having an ENT colleague for this is important. So the most important thing is drilling of the bone over the sinus. Sorry, I think it's... and you can remove the bone only after thinning it very thin. And this dissection is very important in these surgeries. You do the bone work for 1 day and close the tumor and close the patient, and then again on the next day I take up for the tumor decompression. So this takes a painful. This is the anterior petrosectomy, the middle meningeal artery coagulation. This is the anterior petrous apex drilling. So you should have a lax brain. If you want, you can keep an EVD, but we should have a lax brain before we open the dura. And once we open the dura, you can put the metal clips to open the superior petrosal sinus, and this is how you cut the tent. This is a painful process because you have tumor out there. If the tumor is not there, it's simple. So then you decompress the tumor. As I was telling you this, despite all this full 1 day procedure, the corridor, the corridor won't be happy like a retromastoid, and we should understand that. And you should be happy with what you have, and you be operating, mentally preparing yourself to operate within small corridor. That is most important. So this is the continuous this thing. This tumor was tightly adherent, so couldn't decompress completely. But I am happy because the tumor in this location was quite adherent, so I had left it in subtemporal. But patient post-op is preserved, so that is what is important for me. So thank you very much. I have time to have 1 minute. Okay, I'll show another small video, the same procedure. This is a bit larger one. You have I think this calcification at the tumor capsule is important, the large one. Of course, needless to say that enhancement is so huge. Venous anatomy is important in this. So this is after the day 1, the sinus being exposed. The same thing in another case I'm just trying to show. So this is an important step. So you can't be very fast in this. There is no point in being fast here. We need to be meticulous. The same middle meningeal artery coagulation, cutting the tent, taking out the tumor. And of course, this tumor being large, the brain was tense, then narrow corridors, despite doing all this work. So could decompress and see the brainstem vessels. So whenever there is a sputter, we have a doubt that I have injured any perforator. That's the whole stuff, the entire this thing. This patient did reasonably well post-op. This is the scan, and he developed weakness, but it improved over 3 months. This is the follow-up 3 months. Thank you very much for your attention.
Questions at the end. Can we have the next speaker? Dr. Dhaval Shukla. foramen magnum meningiomas approaches and their indications.
Hello, good morning everybody. I thank the Scientific Committee of the Skull-Based Surgical Society for inviting me to give a talk on this topic. So foramen magnum meningiomas are like the distal most skull-based meningioma. We started from anterior cranial fossa, middle and foramen magnum, and it goes beyond the skull base, that is in the upper cervical spine. The foramen magnum meningiomas are not only restricted to the foramen magnum, it goes beyond foramen magnum and requires exposure of craniovertebral junction. So small tumors just ventral to the medulla or spinomedullary junctions are mostly detected incidentally because there is a lot of space around spinomedullary junction at the CV junction level, and tumor has to become enormous in size before patient becomes symptomatic. Whereas such a small tumor placed anterior to spinomedullary junction can present with paresthesias, non-specific neck pain, and many of these patients are not investigated even for many months or years because they do not have any neurological signs. And till the tumor grows further laterally and starts compressing the brainstem or upper spinal cord, then patient develops neurological deficits. So one more thing is, like, if you detect very small tumor just anterior to the foramen, just at the foramen magnum, and the surgical approach will be difficult because you have to go ventral to the spinal cord, and you cannot go from posterior. Even from posterolateral approach it is difficult because it is dead ventral and you see only the medulla or spinal cord. You don't see tumor in spite of removal of lot of bone, and with extended endoscopic transnasal approaches these tumors can be removed. But problem with extended endoscopic transnasal approaches is the tumor extends lateral to the occipital condyle, which most of the foramen magnum meningiomas, they extend beyond the occipital condyle laterally, and you cannot remove. So there is something called far medial approach also you can do through extended endoscopic transnasal, that you can drill the occipital condyle through the nose and can remove up to some extent, but most of the times not. So what happens, as I show, like doing simple midline suboccipital craniectomy will not expose the tumor ventral to the cord or medulla. But as the tumor increases in size, you will be able to see the tumor lateral to the spinomedullary junction even with midline suboccipital craniectomy, extending laterally, as much lateral as permissible. And but if the tumor is small, you will not be able to see the tumor without retracting the spinomedullary junction, which is not advisable. And in that case, you have to do extra drilling, that is drilling the occipital condyle. Now again, there is a lot of controversy, how much occipital condyle to be removed, not to be removed. So one size does not fit all. So you have to tailor the amount of occipital condyle removal depending on the site of the tumor, whether it is dead ventral or ventrolateral, and size of the tumor. Even if dead ventral tumor but enormous in size will provide enough space, so you don't have to drill so much condyle up to the hypoglossal canal. Like classical people describe total resection of condyle till the hypoglossal canal and expose the hypoglossal canal. That is not required in most of the symptomatic tumors, because most of the symptomatic tumors would have become big enough to express themselves laterally rather than remaining only ventrally. So this is how you classify meningiomas, like dead ventral or dead dorsal or ventrolateral or dorsolateral. So besides that, in relationship to the vertebral artery, as I told you, it is not only skull-based meningioma, it is craniovertebral meningioma. So the tumor can be predominantly below the vertebral artery, it can be predominantly above the vertebral artery, or it can be straddling across the vertebral artery. So when it is straddling across the vertebral artery, at that time there are a lot of difficulties in removing tumor. It is akin to our anteroclinode meningioma, which encircles the internal carotid artery, and you may find difficult to remove the tumor without risking the internal carotid artery. So once you enter after doing the bony decompression, there are corridors, like you will have corridors for suprasellar tumors between the optic nerves, third nerves and IC. Similarly, there are corridors at the foramen magnum and spinomedullary junction. There is the first corridor which is shown, it is between the 11th nerve and the vertebral artery, that is upper corridor. And second corridor is below the vertebral artery and lateral to medulla. And corridor 3 is at the more at cervical, it is below, say, to medial to medulla and spinal cord, but lateral to the vertebral artery. And corridor 4, which is very small, which most of the time we don't use, it is lateral to the 11th nerve. This lateral to the 11th nerve, if the tumor is lateral to the 11th nerve, then it can be exposed also with midline suboccipital craniectomy. Again, there is divided opinion about incision. Like from our own hospital, one of the unit prefers this type of incision. I prefer this type hockey type incision. The advantage for me for doing this incision, you can go in layers and it causes less bleeding because you go in the muscle planes. Like superficially you go trapezius and sternocleidomastoid to detach, so that one plane is gone, then spinal capitis and other deeper muscle, then reflect the next layer. So you reflect the muscles in layer, you don't cut across the muscle. Then finally you go to suboccipital triangle comprising of 3 muscles where you will see the vertebral artery. So with this is my argument for my incision. However, people who make this type of incision also claim that they can also see all these muscle layers. But here you are more likely to cut across the muscle, whereas you are more likely to reflect the muscle. Disadvantage with this, like you leave a lot of dead space because it's like a flap. So there is a potential for pseudomeningocele collection of CSF, whereas you go in between the muscles, so there is no flap. So pseudomeningocele probably is less, but we don't know. I don't have proof to support my statement. So I will show couple of cases, and the main purpose is to show these 2 videos that there are different approaches for the same tumor, and it's not the approach, it's the tumor which decides how will you do. So this is so-called far lateral approach. As I already told, how much lateral, it's customized. It's a middle-aged lady with quadriparesis, and you can see the tumor is ventrolateral. And this suboccipital exposure, this is digastric groove, mastoid tip, and it's the foramen magnum region. This is C1 arch. This is vertebral artery. So this is a groove over the C1 arch for the vertebral artery. So dissecting the vertebral artery from the bone, so it is attached to the bone through venous plexus and soft areolar tissue. And you can see the vertebral artery. So when you see a number of veins on the lateral aspect of C1, you know vertebral artery will be below that. It is very well protected by soft tissue as well as venous plexus. So if you use monopolar coagulation to dissect, you are likely to injure the vertebral artery. So better to use sharp dissection using knife or sharp dissector. Even if you use dissector, make sure your dissector is sharp. Like over time the dissector gets worn out and it becomes blunt, and blunt dissector will slip rather than dissect. So we'll make a small burr hole using drill and do a mini craniotomy to remove the suboccipital. It's like a suboccipital craniotomy. Medially, again, how much medial you want to go, you can go all the way up to midline depending on the size of the tumor. Like here, it is almost up to midline. Laterally, we don't do craniotomy. Laterally, we can remove the bone using rongers and drilling the master. Sometimes master drilling is required. And here you expose the sigmoid sinus, and with alternately rongers or drill, you keep on removing the muscle laterally, bone laterally to expose the sinus, and then this is the occipital condyle region. And again, occipital condyle is being drilled. It is not drilled extensively, it is just drilled. And dura is open like C shape based laterally, C or L shape, whatever you want to imagine, alphabet like. Then this is a dural opening across the foramen magnum into the upper cervical spinal canal. So this is how dura is opened and tumor is visualized. You can see the tumor, the denticulate ligament is cut, and we go ventral to the tumor as much as possible. As I told you, it is not possible to go ventral or lateral to the tumor to devascularize and detach completely without some amount of decompression. So alternate decompression, detach, dissect it goes in tandem. There are no rules that you do one thing first and second thing and third thing and so on. So I usually prefer to leave a small sliver of tumor at the attachment, because you try to detach it too early, and if there are feeders from the dura, they get avulse, and it will cause a lot of bleeding, and you don't see anything. So leave a layer of tumor, remove rest of the tumor, and then to so-called complete the extent of excisions, you then detach or devascularize or even cut the dura depending on the space available. The vertebral artery can be protected with rubber sleeve when you are using cautery or any other sharp instrument, and you can mobilize the vertebral artery. Here you can see the vertebral artery is encased by the tumor, and a small layer of the tumor is left all along the vertebral artery. So there are some proponents that you cut the dura all the way to vertebral artery, and you can mobilize the vertebral artery. But in this case, anyway, dura around the vertebral artery was also infiltrated by tumors, so that would not have given me extra advantage. Here you can see small hump of the occipital condyle. So if that hump is interfering in visualization, you can go out again and drill the condyle further if required. So this is the total resection of the tumor. So now this case, again, resident felt we should do far lateral, but it's not necessary that you should do far lateral for all foramen magnum meningiomas, even if it is ventrolateral tumor. So this is again 60-year lady with classical symptoms of paresthesia. You can see the tumor is quite ventral, lateral, but tumor is so big it is coming posterior, it is displacing the medulla, and it is coming in cerebellomedullary fissure, which you see in midline suboccipital craniotomy cerebellomedullary fissure. So tumor has come posteriorly, from anterior to posterior. Though the attachment is anterior or lateral, the tumor has come posterior. So there is no need to do extensive bone drilling in this case. This tumor has itself given enough space for us to reach to its attachment. Yes, in such cases, if you don't go to attachment early, you may have more bleeding. But luckily, we did not have much bleeding in this case. And as you decompress the tumor, tumor gives space and you can reach the attachment. And slowly you cut the denticulate ligaments again, the dural attachments, and keep on decompressing and dissecting the tumor and reach the attachment progressively. So this is how it is done. So tumor will come out, like now you can see the hypoglossal nerve. So tumor is going so anterior, you can even see the hypoglossal nerve. From posterior you can see hypoglossal nerve. It is because of the tumor, not because of your extensive bone work. So sometimes tumor helps you for the surgery rather than the bone resection. So then again superior pole of the tumor is decompressed and gradually being resected. So same principle, decompression, dissection, and detach. So you keep on repeating all these steps, and then you can deliver the tumor totally. So here you can, this tumor was quite big. It was coming from anterior to posterior, medial to lateral. So it took, though the bone work did not take much time, it was just midline suboccipital craniectomy and C1 arch resection. The tumor removal took much more time as compared to the previous case where bone work took more time, but the tumor dissection did not take because we could reach the attachment early. Now vertebral artery is visualized, and you dissect the vertebral artery and remove the tumor. So from this posterior approach also you can have panoramic view of lateral part of spinomedullary junction, even the ventral part of the spinomedullary junction, because of the tumor which has given the space, and this is how you resect the tumor totally, and it looks pretty good. So the purpose of showing this, not all foramen magnum meningiomas, even ventro or ventrolateral meningiomas require far lateral approach depending on the extent of the tumor, the direction of the growth of the tumor. The resection can be done using simple approaches as well. Thank you.
Thank you, sir. That was a fabulous presentation. So we'll have the questions at the end. Kindly wait. So may I now invite my co-chair and moderator of this session, Dr. Rupesh Kumar, to make his presentation on chordomas, choosing the right approach, whether endoscopic or microscopic. Over to you, sir.
Can we have this presentation? So, at the outset, thank you, Adesh. It was a wonderful meeting and very structured. Thank you very much for this. The previous two lectures on meningiomas, schwannomas, they are very common tumors in the posterior fossa. But chordomas and chondrosarcomas are not that commonly encountered. I am going to cover chordoma, and Dr. Prakash will be speaking on chondrosarcomas. Whenever you see a chordoma, it's the decision making, choosing the approach becomes very paramount, because most of us will have limited experience because they are not very common, and they are not superficial. They are very deep. They are the central skull-based tumors. They are, as you see here, this is the distribution of chordomas. Majority of the clivus can go into the petroclival fissures or into the sphenoid sinus. A lot of pathological classification, but the recent one is the conventional chordoma, which is being the commonest, followed by the poorly differentiated chordoma and de-differentiated. They are less than 2%. The 90 to 95% of tumors are the conventional chordomas. And we are all characterized with the physioliferous cells. The residents are here, so you should know about that as a pathological hallmark. But what is more important in the modern pathology is the brachyury. Whenever there is a diagnostic dilemma, pathologically, if you not differentiating chordoma, chondrosarcoma, especially in the de-differentiated ones, this brachyury helps in clinching the diagnosis, because brachyury is positive in all chordomas. We have some prognostic factors in histopathology. As we know that the tumor necrosis, presence of necrosis and more than 6-7% Ki index has a bad prognosis, but we have some good prognostic factors like homozygous PIN21 deletions. The same way in the radiology also, if you see a tumor which is enhancing on contrast, they are aggressive. Non-enhancing chordomas are slightly better than enhancing chordomas, prognostically. If you see a T2 image, the more T2, more hyperintensities, again, they are good prognostic, and a hypo, that means the firm, hard meningiomas are bad. So these are some of the prognostic factors in chordomas. And if we come to the principles of management, the most important is surgery. Yesterday, Dr. Ashish Pathak was speaking on that, and equally is the radiation adjuvant therapy. Surgery alone cannot handle this tumor. We need to have radiation therapy. Chemotherapy doesn't have much role, except maybe the de-differentiated or poorly differentiated, or in very young children, less than 2 years, where you're not able to radiate. Especially the sarcomatous chordomas, they respond to chemo, but generally they are not. As stressing out, the surgery is very important. The role of surgery, we need to achieve a gross total resection. Whether it is feasible or not, it is a challenge. But now people are speaking of the supramarginal resection. That is, you drill the bone around the normal looking, the tumor bone. That means you achieve a little bit better prognosis, and extent of resection is very, very important. So primarily we have 3 approaches, endoscopic approaches mainly for the midline. And if there are lateral extensions, you do lateral microscopic, and sometimes you combine it. Previously, before this endoscopic era, most of these tumors were done multiple lateral approaches. You name any skull-based approach, it is done for chordomas and chondrosarcomas, but thanks to the endoscopic approach, majority of those now are being handled by endoscopic endonasal approach. So essentially, where the tumor is decides your approach, and it's also about the patient factors, re-radiation, recurrent tumors, patient diabetic, and poor wound healing. All those things also need to be considered in influencing the tumor. Now if you come classification, microscopic classification of clivus is different from endoscopy. So you draw 2 parallel lines along the sphenoid sinus line, along the cellular floor, and then you divide the clivus into upper, middle, and lower. And so we have the transcellular corridor for upper chordomas, and a sphenoidal corridor, and the infrasphenoidal corridor for the tumors in the middle and lower. Upper chordomas are better as conventional endoscopic approaches what you do for pituitary, but for a middle and lower, you need to have a transpterygoid approach. Transpterygoid approach is just equivalent to a FTOIZ versus a pterional craniotomy. A standard external approach is like a pterional. If you want to do more aggressive, then you go FTOIZ. Same way, untethering the skull-base endoscopically is transpterygoid approach, where you have an unparalleled view of lower clivus, the petroclival fissure, what we see there, for medial approaches. So this is what the end of the things you get to the see of about the tumors. So now I'll just go to you. So this is a classical tumor, looking very large, presenting actually with dysphagia, little extension to the posterior fossa, and they are midline. So essentially these tumors are conventionally done and comfortably done endoscopically, and you relieve this tumor and we can see this is the immediate post-op MRI. So this is a good approach for an extended endonasal approaches, where because its tumor is essentially in the midline, though it is big tumors are a good advantage because they create the corridor for you and you have a comfortable. Same way, even if there are a little bit extensions laterally, you can still be able to do because you have good midline. You capitalize on that, remove the midline part, then you go laterally, and here image guidance helps in a significant way. Actually here we missed one nodule, and so after doing an immediate intra-op MRI, we found out that we missed a nodule, it went back the same anesthesia, we removed that residual nodule also. So because they are multiple lobulated, you think that you removed the tumor, there may be one lobule which is hidden, and this is what has happened, especially in recurrent tumors. So image guidance helps, and we can see that the post-op MRI complete resection. And again, a residual or recurrent chordoma, you can see most of these tumors, if you see, they are hypo on T2. That means they are going to be firm hard. They are not like pituitary, which is going to be soft. So slightly more eccentric approaches you need to have. So you need to know the dura. Majority of the time, they are extradural approach. But what we have in experience is that these tumors invade the dura. Sometimes you not even realize that you have gone intra-subarachnoid because the dura is so thinned out or destroyed by the tumor itself. So you have a dural margin, and then you know where your internal structures are, and then you try to do. You can see that the tumor is very hard and firm, unlike a pituitary which comes pituitary. Here you have to do berry picking and to remove this tumor. That is a post-op MRI. Here the goal is decompression of the visual apparatus, and because all these patients are going for radiation therapy, so you need to relieve the compression of this structure so that you can go for high dose radiation. If you leave behind tumor close to optic nerve, radiation oncologists will not be able to radiate this tumor. So it is important that the decompression is very paramount. You can see again a residual chordoma which is gone, and then one nodule poking into the pons. It is important to release that because if you want to give radiation high dose to that brainstem, you will have toxicity. So you can see that. So once you clear the tumor of the extradural, the bones, then you open the dura and remove the tumor which is gone into the pons. Try to remove the tumor so that you can go for a therapeutic radiation, which is going to be 72 grays, not like a conventional 58 or 62, which you do for a glioma. So you can see that nodule going lateral to the basilar artery, and then you release that tumor so that you can free. And robust reconstruction is important because clival defects, CSF rhinorrhea is very difficult to manage if there is a rhinorrhea post-op. So a robust multi-layered reconstruction is of paramount importance because these patients are also going for radiation. Similar examples, you can see a midline tumor, slightly paramedian, impinging on the pons. It is very essential that you decompress endoscopically, clear the brainstem so that you are having this immediate post-operative MRI. Most of these cases, better to do immediate post-op MRI so that you are aware and you are sure that you are going to decompress the neuronal structures. Those larger ones in the CV junction, which compresses the cervicomedullary, and we can see that this is again T2 hyper. That means it's going to be a soft tumor. So you can see here you need a bilateral transpterygoid approach. So you have an uninterrupted view. You can go into the cervicomedullary junction. You also drill the odontoid and the C1 arch because the tumor is going behind that, and then you have a good approach. So you do a lot of bone work before you enter the tumor, and you see as the T2 is hyper, the tumor is also soft. But the most important thing is again multiple lobules. So these tumors are into multiple lobules, and then you start removing the tumor, you gain space, and then you try to dissect. You see here, it's a primary case, not a recurrent, but there is no dura. The dura is already infiltrated or damaged by the tumor per se. It's not only that, you will see that the rootlets are also infiltrated by the tumor, which is unusual. Normally an extradural should not behave like that. So you can see the rootlets of C2, the tumor is infiltrating. So that is again, so it's a myth that we believe that they are all purely extradural. They are not really. They behave aggressively sometimes, and then you get a panoramic view at the end of the section. And you can see again, reconstruction is very, very important because such large defects of the clivus, you need to have a robust reconstruction all around. Again, you see the multi-layered reconstruction post-operatively, and then you subject the patient for radiation therapy. Recurrent cases in this case actually operated by a far lateral approach, but then there's a significant compression, and we can see that it is impinging on the medulla. You need to clear the tumor on the medullary surface, and we can see that. So here, this tumor was firm, not a hyper on T2. You can see that. So we have to use sharp dissection because they're recurrent tumors, not much plane. You can see the vertebral artery is infiltrated. So we have to clear the vertebral artery from the tumor, and then the one which is pressing on the medulla oblongata has to be decompressed. And we can see that that is the immediate post-op MRI. We see that the good amount of decompression of the medulla oblongata with this tumor. Now, not all cases are feasible for endoscopy. There are good microsurgical approaches are also paramount importance. We have various approaches depending on the location of the tumor. So this is a case already twice operated endoscopically, but then you see the slightly more paramedian. So we decided to go retrosig, and then we can see the challenge here, retrosig, is that you have to work between the nerves. You can see here, the tumor is projecting, so it is like opening the dura twice. You are opening a dura laterally, again, you are opening the dura medial to the cranial nerves. So in between the nerves, you have to create the corridors. You should not damage the nerves. You have to use IONM. So, and then you remove the tumor. Fortunately, majority of these tumors are not vascular, so you'll be able to do a good decompression. And we can see that, so they are soft jelly. So we could decompress majority, especially more important priority is that brainstem. So the brainstem is decompressed, a little bit of tumor in the Meckel's cave, which we thought that is safe enough, then this patient was given radiation. So if the radiation oncologist is very happy if the tumor is cleared off the brainstem so that they can go for high therapeutic dose. Again, thrice operated, you can see this tumor, we have a dilemma whether to do endonasal or translateral approach, but then we can see that already planes are destroyed and the tumor is significantly coming more into the lateral corridor. We thought we'll go ahead with doing a lateral approach. Yesterday, Dr. Manjul was highlighting that you should keep a little bit of a fat graft between for gamma knife. The same thing holds true for even proton also. So we always keep, you can see the multiple black things in the T2 are the fat. So we keep lot of fat around the brainstem that actually insulates. It's a good insulating material for the proton therapy. And then you can see they're not worried if the tumor is in the bones, but very important is that you decompress the cranial nerves. This is again very difficult endoscopically. You can see the intercarotid distance is very small. Bilateral CP angle corridors are expanded by the tumor. So this patient, we did bilateral retrosig in a staged manner and then got this tumor, decompressed the brainstem, and then the patient was subjected for radiation therapy. Transperitoneal approaches once were a very key horse approach for these tumors, and this patient, we actually thought we'll go endoscopically, but then you see the sagittal view, the vertical extent was quite high, and so we decided we go because it has almost come into the lateral corridor, so we went and do a transpetrosal approach and remove this tumor. The same way, this tumor also more lateral, so we, instead of going endoscopic, we decided that transpetrosal approach will be much better. It's also going to the cavernous sinus, and we could remove this tumor in the transpetrosal way. These are good for microsurgical approaches, so you need to have a hybrid approach. You need to be well versed with both endo and microscopical. This case is interesting. A young boy, you can see a large tumor, the one which I showed similarly. If you see the sagittal image alone, you will think that you are going endoscopically. But you see the axial image, the tumor has come significantly lateral, and you open the neck, you can reach the tumor. So we did a transcervical approach. The tumor is big, it gave the corridor, and we could clear the tumor all around the cervical cord and the brainstem, and we could achieve a gross total resection. Majority of the time, you need also a combined approach. As we see, this is the youngest child which I operated 1.5 years. You can see a large tumor in the clavicle going inside. Young pediatric patients' chordomas behave aggressively. They are not conventional, they are de-differentiated or poorly differentiated. You can see that this tumor going in, again pressing the brainstem. We did an endoscopic, we did a good job. We decompressed the brainstem, and we can see that immediate post-op MRI reasonably good. But this is only 1.5 years, the radiation oncologists were skeptical about radiation. We thought we'll give chemo, wait for some time till the child becomes 2 years, but then child recurred, and this time it was more lateral, so we decided again a transpetrosal approach. We went ahead and removed the tumor, the transpetrosal. Again, 57-year-old female, midline tumor, corridor, midline decompression done. We wanted to radiate the patient, but patient lost for follow-up. It came after 1 year, and then we realized that the tumor was growing more laterally, and then we did, again, a transpetrosal approach and extradural temporal polar, and we could decompress this tumor. So sometimes you need to have this combined approach, either in the same sitting or in the staged manner, to achieve a good decompression. So there are some studies which is good, midline or lateral, and there are advantages of both, as you saw. So the tumor has to decide, and based on whether you can approach this tumor in a single stage, a multiple stage, midline or lateral corridor. So this is a personal experience on 38 patients. We can see the youngest patients. I've showed you 2 patients we had, and it's not a disease of 4th or 5th decade. We see a lot of these tumors in children also, and we could achieve a good amount of decompression, and they also have complications. We had new cranial deficits in 3 patients and CSF leak in 2 patients, but we could manage them. So to conclude, the grade of resection is important, so surgery becomes a pivotal role before the patient goes for radiation. Radiation is equally important, and now that proton is advantageous, it extends the survival rate by significantly beyond up to 10 years. Before that was only 5 or 6 years. We are speaking about midline tumors go endoscopically and lateral we can go microscopic, or you combine based on the requirement. So thank you very much and welcome you all for the Chennai skull-based meeting this year, October end.
Thank you, Dr. Rupesh. Now we call upon Dr. Prakash Nair for his talk on chondrosarcomas, surgical strategies for optimal outcomes.
A very good afternoon to all of you. I shall be speaking on the extended endoscopic endonasal approach for petroclival and clival chondrosarcomas. So Dr. Rupesh has dealt in very great detail about the management of chordomas. And chondrosarcomas are both histologically and in terms of long-term behavior very different from chordomas. But they do tend to mimic chordomas very similarly in radiology. So they arise from the petroclival synchondrosis here, where you have tumors that extend all the way down to the spheno-occipital synchondrosis. So the petroclival synchondrosis high up to the petro-occipital synchondrosis lower down. And while they are malignant tumors, they're mostly extradural placed tumors when they're smaller, but they tend to be extremely indolent. And they have very poor response to conventional radiotherapy at the ROSA 60 grade. So complete resection, or at least a very radical resection, is extremely important in achieving cure. Now, histologically, you have subtypes. You have the chondrosarcomas, which can be conventional, mesenchymal, or dedifferentiated. And the conventional chondrosarcoma, which is the most common central skull-based chondrosarcoma, usually is grade 1, grade 2, or grade 3. So when we looked at our own data of the last 20 years, for 51 patients, we found that nearly 90% of tumors, nearly 90% of these chondrosarcomas were conventional chondrosarcomas, not the mesenchymal or the dedifferentiated chondrosarcomas. And when we looked at their cumulative survival over a very long period of time, for nearly 10 years, we found that, with surgery alone, they tended to have a very indolent course with very small rates of recurrence when we followed them up for a very long period of time. This is why, because you're dealing with very indolent tumors, we need to expand the margins of resection and get very wide resections whenever possible. And this requires our resection to extend into lateral spaces. Now, the conventional center, the core of your approach, is to take you towards the petroclival synchondrosis. And we have two very important landmarks that lead us to the synchondrosis. One is the Vidian nerve, and the other is the pterygosphenoidal fissure. So using these two landmarks, we can direct our approach to the genu of the ICA and the petrous apex, which tends to be the center of our surgical approach. Now, these are various examples radiologically of tumors which are all chondrosarcomas, but they have extremely distinct appearances. So you have one tumor which is entirely extradural, another tumor which appears to have intradural extension but has a dural covering beyond it, and a tumor which is purely intradural. And another thing that is very remarkable is that they are extremely calcified. So surgically and technically, they are difficult to remove. Now, when we look at how we could approach these tumors, can we break the sinonasal cavity into modules? So we have these conventional lines placed between the foramen rotundum and the Vidian nerve, which can be used to differentiate the sinonasal cavity into the sinonasal tract, the pterygopalatine fossa, the infratemporal fossa, and the lateral recess of the sphenoid sinus. And this helps us tailor our approach to various areas like the petrous apex and the retrocarotid space, or to the jugular foramen, to the infratemporal fossa, or the pterygopalatine fossa. Now, this is an example of an upper clival chondrosarcoma in a young male patient, which looks very resectable. So, using these conventional the landmarks that I told you about, the Vidian nerve and the pterygosphenoidal fissure, we first start by going extradurally and mobilizing the posterior clinoid away from the ICA and the cavernous sinus on the left side. Once we have mobilized the tumor, you can see that most of it lies between the walls of the bone, and tumor can be decompressed, and the petroclival synchondrosis that runs from this area to this area can be entirely drilled. So the idea is to expand the margin of resection and get the maximum bony resection possible. And the endonasal approach also allows us to drill lower down towards the petrous. So in this particular way, one can approach the lateral aspect of the cavernous sinus, the bone at the lateral aspect of the cavernous sinus, and get resection which takes us all the way down to the petrous apex. So I have some difficulty with the screen where I cannot see this presentation on the screen, so we'll follow it like this. The petrosal process of the sphenoid bone is a very important landmark which lets us identify the sixth nerve extradurally. And this is a very important landmark because the sixth nerve is very commonly involved in clival chondrosarcoma. So we have the petrous apex here, we have the clivus here, and we have the petroclival synchondrosis of the fissure, which can be seen here. And then you can drill further onto the petrous apex and get resection lower down. So this is an example. So this is how you have drilling done all the way down to the petrous apex from the endonasal route. And this is a postoperative image where you get a very radical resection. Now, when we look at the CT scans of these patients, patients who undergo open anterior petrosectomy have maximum drilling done over the upper part of the petrous apex, which is slightly away from the synchondrosis, whereas the endonasal approach gives us access to this particular area, which lies at the lower part of the synchondrosis, which is the actual area that is affected by the petroclival chondrosarcoma. So this is a very intuitive and a very direct approach to come to the petroclival synchondrosis. Another important caveat is to mobilize the upper wall or the upper part of the clivus, because the clival involvement and the involvement of the posterior clinoids is extremely important. So this requires mobilization of the walls of the ICA and resection of these keratoclinoidal and the inferior petrosal ligaments. So this is an example of a female patient who had presented to us with diplopia and sixth-nerve palsy. And here you have a fairly large calcified tumor that extends into the ambient cistern. Now, once we have had very wide exposure, so you have the pituitary gland, the paraclival ICA, the pterygosphenoidal fissure, and the Vidian nerve, we can now isolate where the internal carotid artery is using the Doppler. And this allows us to open the anterior wall of the cavernous sinus, coagulate the ligaments. So you have the CCL, the keratoclinoidal ligaments superiorly, and the paracellal ligaments inferiorly. So once you remove them, you come straight onto the dorsum and the posterior aspect of the clinoid, and the entire involved bone here, which can now be resected. As I again and again re-emphasize, petroclival chondrosarcomas are bony tumors, they're extradural tumors, and an extradural approach gives us very direct access to most of the tumor. So you can see intact dura, you can see tumor which has been resected, and a small hole in the dura here, which was the tumor extending into the cistern, which is repaired during conventional fashion. So again, you can have chondrosarcomas that extend inferiorly towards the jugular foramen. So you can see this tumor that extends down into the anterior aspect of the jugular bulb. And occasionally you will also have an ICA here which is extremely redundant. So this can come very anteriorly onto the eustachian tube. So this is a risk factor for mobilization of the eustachian tube in this particular case. So here the approach takes us inferiorly. You see the Vidian nerve, transect the Vidian nerve, mobilize the entire ICA and drill towards the jugular bulb inferiorly. Once the genu of the ICA has been skeletonized and the parapharyngeal space has been opened inferiorly by mobilizing the eustachian tube in a not using soft tissue fashion, the tumor behind the internal carotid artery can be slowly removed. And the tumor itself creates a corridor along the petroclival fissure down onto the anterior aspect of the jugular bulb. Since a lot of these tumors tend to have a very soft matrix, some of it can be resected very successfully using a combination of dissectors and suction. So this is how the endonasal approach gives us access to not just the upper part of the clivus, but also allows our approach to go very inferiorly towards the lower part of the clivus. So this is the postoperative image where you can see tumor here inferiorly, and here you can see extension of the resection that goes very inferiorly onto the lower part of the clivus. And images taken many years after surgery show this resection extending towards the lower part of the clivus inferiorly. And another caveat is that most of these tumors tend to be extradural. So even when you have very large tumors, which are very calcified, these tumors can be exposed very well after clival drilling and exposure of the entire cavernous sinus and the Meckel's cave anteriorly. Once the tumor has been drilled and the anterior aspect of the cavernous sinus has been mobilized, the tumor which lies in the bone can be removed. And here, because the tumor tends to have a lot of calcified element, we can also drill the bone. There is very messy bleeding from the cavernous sinus that comes during surgery, but this can be controlled using a combination of gel foam and pressure. And now we can see how a very large calcified tumor can be exposed from the upper part of the clivus here to the lower part. This is the genu where you have the Vidian nerve, which is being traced up to the genu of the ICA. Now, this gives us very direct access to the tumor itself without having to deal with any of the neural or the cranial structures that would be accessed when we have an intradural approach. Again, we open the anterior wall of the cavernous sinus to get access to the posterior aspect of the dorsum and the posterior clinoid. Again, these are the areas that are actually involved by the tumor. And the endonasal approach gives us very direct access to the bony elements, which can be then removed. So these are large chunks of bone, which are very cumbersome to remove using a conventional transcranial approach, where you have to remove these tumors between cranial nerves. But when we come from the endonasal approach, you can use a combination of bone QSARs or drills to remove these large chunks of bone. So because I'm running out of time, you can see these post-op images, which give very good resection of tumors lying in the cavernous sinus and the Meckel's cave. So these are other examples of very large tumors tackled in the same manner. Now, there are certain modifications to the approach, like the contralateral transmaxillary approach or the Denker's approach, which can widen the corridor of exposure. So, without taking up much more time, I shall conclude by saying that the advantages of using the endonasal approach is that it avoids very large craniofacial procedures and avoids manipulation of cranial nerves and brain retraction. It can be paired with other anterolateral approaches to get wide radical resections for these tumors. And at the end of the day, management requires multimodality approach. A majority of these tumors tend to involve the synchondrosis. When you have mesenchymal or dedifferentiated tumors, they require near-adjuvant chemotherapy. So the option would be to do a biopsy, then give chemotherapy, and then attempt resection. But for conventional chondrosarcomas, surgical resection remains the best modality of treatment upfront. The Vidian nerve forms a very key landmark which can be used to identify the genu of the ICA. And at the end of the day, the extension widens the corridor of access and improves the extent of resection. Thank you.
Thank you, Dr. Prakash. I think we have come to the end of the session. We'll have some question answers for all the speakers. I'll have a question with Dr. Rao.
Yeah.
Yes. So the question is, for a petroclavial meningioma, how do you decide whether you go retrosig or you come transpetrosig?
See, basically retroseg is good enough. I mean, there are several papers, even one paper from Nimans also is published recently, that retrosegment also gives a good corridor. But what I found is if the brainstem is distortion is there, and the tumor is located more anteriorly, anterior to the fifth nerve, anterior to it's going towards clivus, I think I would prefer a pre-sigmoid approach in that. But I think one of these speakers have told that, what is the talk, you should have an exposure of both pre-sigmoid as well as retrosigmoid. That would be the ideal.
Kuntal did it. No?
Kuntal, yeah, Kuntal, sorry. So the thing is that you should have both corridors exposed. So fundamentally over years what I understood that all these skull-based procedures, though they describe that the extensive exposure can be done, it doesn't really happen inside. Inside you are still struggle with just a pre-sigmoid approach. It's always better to combine. So it's a tailored thing. There is nothing like, as Chief has also presented, it's all the drilling of the bone is, you know, you after drilling, if you feel that it is not sufficient, you can come back. Whether it is clinoidectomy, whether it is far lateral approach, if you think that your bone drilling is insufficient, you can always put back the dura, drill the bone, and again go inside. That would be the more ideal, I think.
Dr. Ishwar had a question.
Prakash Nair, beautiful paper. I enjoyed your videos. I came in a little late, so I was not there in the initial part of your presentation. You mean to say that a very small number of cases only required a transmaxillary approach? Transmaxillary approach. Okay. Denker and counter. Okay, I got you.
For the infratemporal fossa, there you need much wider exposure. So, so that is another thing. We have done exactly one Denker. I have experience of nearly 70 cases now. But I've had to do only one Denker because now I've realized that doing a maxillectomy, a middle maxillectomy, by taking off the inferior turbinate also gives us a lot of volume. And that is usually enough to get into the infratemporal fossa.
On to Prakash, Prakash as well as you also, that these approaches, what you are showing endoscopic, they really require a lot of experience and expertise. But what is the thing is that what I'm noticing is that are you using two hand and two nostril and four hands technique, I guess, right? So you should have a combination with an ENT surgeon or another neurosurgeon.
I always work with ENT surgeon. My ENT surgeon is there, Dr. Kripa Shankar. So we always work together. So all the exposures he does and he holds the scope. Once the dura comes, I do the intradural part. Again, reconstruction, it takes over. So that, I think the team is very important. These are extensive tumors, takes a lot of time, exposure. So you need to have the support from ENT team. Otherwise, I think difficult to, I think Prakash does mostly in his own way.
Dr. Rupesh is saying is the best of the world. I also have a person who helps me with ENT work, but unfortunately because of the structure of my institution, I'm not able to get him for all cases. So perforce I'm used to doing my exposures myself. But I would also like to emphasize that the ENT person is not just important for your exposure, it's also extremely important for your postoperative care. None of these tumors will do well if they are not managed with ENT douching and postoperative lavage after surgery. And they require, especially when you do a maxillectomy, they require this over many, many months. So it is not only important to have them at surgery. If you don't have them at surgery, it's still manageable. But if you don't have them after surgery, you will not have patients who are doing well after surgery.
A question to both Dr. Prakash and Dr. Rupesh. The videos are fabulous, but they are at the same time very difficult. So especially for somebody who, most of us are trained in microscopy, and this is the next level work. So congratulations to you. But my question is, the anatomy is disorienting, the pathology also distorts it. So in how many cases of yours, both of you, you use some kind of reorientation, for example, navigation? I suspect it is used in most of the cases. Is it so?
See, unlike chondrosarcoma, most of the chondrosarcomas are primary. Chordomas, we do operate multiple recurrent, redo. So those cases definitely I think navigation helps. In spite of navigation, we sometimes miss. I showed one scan which we used navigation. One lobule was missed out, which we thought it is normal. But then we did an MRI intraop, then we found that nodule. And it was accessible location. We just thought that is a cavernous sinus dura. We didn't open that. So, but actually it was a tumor. So I think it's equal important both, unless we have an endonasal CUSA ultrasound where we can really know whether tumor. But today we don't have that gadget, but navigation is very helpful. We need to have orientation to know how far we are come.
No, I think Kuntal's question encompasses a very broad philosophy of neurosurgery also, in the sense that what has changed in the last 30 or 40 years in how we understand neurosurgery is how we understand the anatomy, both the microsurgical, endoneurosurgical, whatever anatomy it is. So the aim of showing all these landmarks like the Vidian nerve or the pterygosinodal fissure is to emphasize that you require hard anatomical landmarks for any surgical exposure. Doesn't matter whether you're doing a transpetrosal approach or a combined approach, you need hard anatomical landmarks. And these hard anatomical landmarks are, you supplement those landmarks using other adjuncts like navigation. So the navigation is not only a primary tool. We use a lot of adjuncts. So we use Doppler to isolate the ICA, we use navigation to keep orienting ourselves, and there is no substitute for that. But the principle is based upon identifying hard anatomical landmarks and going from one landmark to another. And there you will have to use more than one tool available with you to orient yourself. There's no other substitute for
that. And one more question regarding this. So all of you have shown beautiful endoscopy videos. Now, what does the literature say when you compare endoscopic approaches with microscopic approaches in terms of disease recurrence, say at 5 years down the line, versus operative morbidity. Because it is possible we might be mixing apples with oranges. The pathology of the tumor has to be also taken into consideration. The low-grade tumors would anyway not grow, like you have shown your statistics. So how do you, enlighten us from that perspective? Endoscopy versus microscopy, the literature review, what does it say? And lastly, I think with Manjul also being here, if you leave a small residue, is there a way of tagging it as surgeons so that our radiation colleague can find out that? And secondly, how does gamma knife fare in comparison to proton beam, considering the cost considerations? So I hope all of you can pitch in for this.
See, if you see it, maybe up to 2000s, the chordoma publications, most of were microsurgical approaches. But I think after 2000s, I think there's a panoramic shift, because essentially chordomas, they're midline. Unlike chondrosarcoma, which is slightly paramedian, most chordomas are midline. I think it is prudent to go endoscopically. So I think today 70 to 80% of chordomas will require an endoscopic approach. Only those ones which are going lateral, more into the cavernous sinus, they need to go endoscopic. And today people are speaking about supramarginal resection. You drill all the bone, around that you go and drill the bone and cut the dura, so you achieve a supramaxillary, and they maximum survival what they could achieve is 10 years now. Previously you were speaking 6 to 7, now up to 4 years extra. Gamma knife, I think Manjul will agree, gamma knife is not good for chordoma, because chordomas are invasive like epidermoid, they insinuate into the bones. What you see on an MRI may not be real. There could be micro seedling of the tumor, and the volume is much more higher. Unlike, it's not a focal disease. Chordoma, they are generally disease, and there are a lot of extensions. So you need to cover up a large, and you do have a high. Conventional dosage will be 72 gray up to 74 gray. I think which is not feasible in a regular IMRT or a SRT, where that's why the proton has a distinct advantage over regular. But regarding gamma knife, maybe it's a very focal tumor you are left. You're sure there is no other tumor. I think gamma knife may be an option. Yes.
Chief, I would partially agree to it, and the blame goes to the published literature. The blame is in the way because we, as he told apples and oranges, the chordomas, the volume of the residual tumor, its fluidic nature marginating into your surrounding tissues, that vary significantly in the literature. So if you go with a head-to-head comparison, when you go with a propensity-matched analysis of the similar volume chordoma, I totally agree if the volume is large and you need to give a good dose, which you give is 75 to 80 gray in good cases of the chordomas, with proton radiosurgery, definitely the results are going to be better, as in the 80% control as you have shown over there. But if the tumor is small in size, then you can achieve the same thing. The main hindrance here happens with the brainstem, because the brainstem is a radio-sensitive zone. So if it is touching your brainstem, then you cannot deliver that same radiation with gamma knife in a single session. After this icon coming, when the fractionation became a routine with gamma knife, the long-term results are still pending, but what cases we could do with gamma knife with the small residues attached to the clivus away from the brainstem, if you give more than 20 gray in a single fraction, its biological effective dose becomes equivalent to the proton radiosurgery in those cases. Once you are sure about your margin of the tumor and you are away from the brainstem, you practically achieve the similar results. So we had this question, so we did international retrospective analysis. I was a part of that analysis, which we published in JNS in 2021, which was just for the chordomas and the role of the gamma knife radiosurgery. So our results showed that if we are able to give more than 20 gray and the volume is small, then in those cases we matched proton. But if the volume is large, definitely proton is going to be a better answer in those cases.
I think Kuntal's question also talks about the difference between microsurgery and endoscopy. And a lot of the literature gets confused because we tend to compare different histology of tumors. So the commonest tumors that are dealt with endonasally will be pituitaries, craniopharyngiomas, meningiomas, chordomas, chondrosarcomas. And each of them have different histology and different behavior. Now, literature-wise, for pituitaries, for craniopharyngiomas, over the last 15 years now, which is very good literature, definitely shows that for macroadenomas and for cranios, better resections, better outcomes in terms of visual dysfunction and hormonal dysfunction, with a greater incidence of CSF leaks. The problem with chordomas and chondrosarcomas are the largest number of series that you have include less than 150 to 200 cases. Now, one specific problem when you say chordomas and chondrosarcomas tend to be central skull-based tumors. They're extremely indolent and extremely different from chordomas. chordomas are malignant tumors. They are definitely aggressive, and the radiation that you give to them needs to be an oncological concept where you're not just radiating the mass but also the bed of the tumor. That is where any form of hypofractionation where you're giving multiple settings will give a volume of radiation to a radiation dose to the volume as well as to the bed. That concept cannot be obviated. It is just like radiating CA breast, where you not only target the lesion but also the radiation given to the bed is important for sterilizing the bed. And that is where chordomas, in terms of literature right now for chordomas, the only area where they have better outcomes are in cases where there is recurrence. So there what has happened is that the rest of the bed has no recurrence, where you have a small tumor which has had recurrence, and their radiation with gamma knife tends to have better outcomes. I'm assuming that patients there have been resected and been radiated. The problem with chondrosarcomas is that they are indolent. And they have, when you look at central skull-based chondrosarcomas, they have long-term follow-ups which can go on for 10 to 15 years with very significant, insignificant period of growth. There the problem is that by giving a single dose, it is very difficult to predict what their behavior is going to be, because even without radiation or without treatment, they might tend to be of the same size. So there is no literature favoring chondrosarcomas, favoring gamma knife for chondrosarcomas at this point of time. For chordomas, definitely, there are two rules. One, there is no radiation dose less than 60 that is effective. And if you have to give more than 70, it has to be through proton.
So I think we had a good amount of discussion. Yeah, I think one last question. Yeah.
Give him a mic, please.
Yes, sir. My question is for all the endoscopic surgeons. We are doing extended endoscopic approaches, transpterygoid. What about the closure? Head out of the ipsilateral side, head out from the contralateral side. How does this hold in fact? And what is the post-nasal quality and after removing the medial maxillectomy? How is the quality of life later on of the patients? And how to prevent the CSF leak? Do we put a lumbar drain as a routine pre-operatively, post-operatively, or depending upon the CSF leaks?
Yeah, I think Dr. Krupashankar can answer this question. So reconstruction of the skull base, what we do, lumbar drain, but we have come down significantly. We are not using lumbar drain that often as we did before. Very selectively we do lumbar drain. Yeah, then we call something the gasket technique. The gasket technique, actually lumbar drain is counterproductive. It's better without lumbar drain because we want some pressure on the gasket. So, yes, Kripa.
So, large defects like this, we have multi-layer reconstruction. So, we have one layer to reconstruct every layer we have removed. So, many times these defects involve osteodural defects. So, the nasal mucosa is removed. There will be a chunk of muscles which will be removed. There will be bone which will be removed. And then there will be dura which will be removed. Now, under the dura, we place synthetic dural grafts. We have, that is only a layer for the dura. And then the gasketing, we bring it where the bone defect is there. So, there will be a gasket technique where there will be a fascia. And then we have a bony wedge to hedge it in place. Then the volume I fill up with fat, and the last layer will be the nasoseptal flap. So our closure will be watertight, and then the nasoseptal flap just adds on to the mucosal surface. Now post-operatively, it is very important to douche this place and to ensure that the mucosal healing is well before these patients are going in for radiation. So many times it is such that the nasoseptal flap shakes a little bit, and then there are some fat which is prolapsing outside. This can cause a long-term crust, and these don't do well when subjected to radiation or proton. So it's very important that post-operatively we do an endoscopic check, and we do keep suction, and we get the whole mucosa healed, and then that is the time the patient goes for adjuvant therapy.
Thank you, Dr. Kiruba. So one last question to Professor Dhaval Shukla. It's a beautiful presentation, nice videos. My question to you is, unlike chordoma and chondrosarcoma, resection of bone in meningioma is only to expose, not much of oncological benefit. And this is understandable. So my question to you is, in today's time, when the endoscopy has grown prolifically, can't you just cut down on your bony work and use angle visualization and angled instruments to get out that small bit of tumor rather than spending hours on drilling the condyle?
Yeah, that's what I told, that amount of condyle resection should not be predetermined. It should be like intraoperative. I showed one knob of condyle. Like that did not interfere with my exposure. And if it interferes, like as you suggested, we can use angled endoscope and angled instrument to remove the rest of the tumor. And in spite of that you are not able to do, then you go outside dura again and then remove the condyle and then do it. So we definitely do use endoscope from inside rather than from nose for improving the extent of resection. That is commonly used, not only for meningioma, for a lot of other tumors we commonly use endoscope to remove the tumor.
Thank you. So with this we come to the end of this wonderful session. Thank you.
Handing over to the organizers for the next session. Thank you.
So, starting with the last session for the day, that is radiosurgery and new frontiers in skull-based surgery. The moderator for the session is Dr. Rajneesh Arora. May I call upon the stage the honorary chairpersons for the session, Dr. Manjul Tripathi, Dr. Dhaval Shukla, and Dr. Nitin Garg. Nitin sir.
So this is the last session of this event, and I welcome my co-chairs with me, Professor Dhaval Shukla, Professor Manjul Tripathi, and Dr. Nitin Garg. So there is a slight change in the program. Professor Manish Agrawal would present his talk as a first talk of the day, and he will speak on management of posterior circulation aneurysm, advantages of a hybrid department.
Shows the success of the conference that even in the last session there is so much crowd and everybody is interacting over there. So I congratulate Adesh for this wonderful work.
And thank you organizers, AIMS Bhopal, Dr. Amit, Dr. Adesh. Thank you for this opportunity. It's been a wonderful hospitality and a wonderful conference. So I was asked to speak upon this topic of posterior circulation aneurysms, advantages of a hybrid approach. So what is the advantage of hybrid approach? We do both clipping and coiling, and endovascular treatment has now become the first choice for cerebral aneurysms. In India as well, due to its minimal invasiveness and therapeutic effectiveness, the number of endovascular treatments has been increasing yearly and its role has been growing. So posterior circulation aneurysms account for 15% of all intracranial aneurysms. Posterior have a higher risk of rupture and have worse clinical outcomes than the anterior circulation aneurysms. The common sites, of course, we all know: basilar artery, posterior cerebral artery, superior cerebral artery, and so on. So the treatment of posterior circulation aneurysm poses a great technical challenge because of their location, difficult to reach anatomy, narrow field for microsurgical operations, and the origin and the branches supplying the supplying the cerebellum and the brainstem. So for endovascular coiling, with advances in technique, expertise, and experience, the rate of endovascular coiling is increasing. Although the ultimate goal of aneurysm treatment is permanent obliteration of the aneurysm, which may or may not always be achieved, partial coiling may lead to risk of recanalization, rupture of aneurysmal remnants, and the role of endovascular coiling is still debatable in cases of unruptured aneurysms. For microsurgical clipping, technological advancements have made a profound impact on the success of modern microneurosurgery. However, the microsurgical treatment appears superior for lower rate of rebleeding, lower rate of recurrence, higher rates of aneurysm obliteration. It carries inherent risk and challenges, posing higher risk of mortality and morbidity. So what is the way forward? Each treatment modality has its own advantages and limitations, making it inappropriate to claim one is universally superior. Treatment should be individualized, with institutes equipped to offer both options based on aneurysm anatomy and patient-specific factors. Hence, it is important for an institute to have a team which makes and masters both open cerebrovascular surgery and endovascular treatment. So what is the hybrid approach? The hybrid approach is capable of different treatment methods, understands the advantages and disadvantages of both, and can flexibly select the appropriate method. It is preparing two sword-style practitioners. Through repeated training in both methods, we can choose the best treatment without hesitation or resistance. In our institute, we aim to train all the residents and the younger faculty in both open cerebrovascular surgeries as well as endovascular techniques. So a hybrid operating room consisting of latest angiographic system was started in our institute in 2014. It established an environment that always allows switching to craniotomy whenever it is necessary. So it is a multidisciplinary approach. We dedicate a team specializing in the management of cerebrovascular diseases. We are equipped with a biplane G Innova machine. The treatment decision of open surgery versus endovascular interventions are made following a comprehensive evaluation and multidisciplinary discussion. We have a team which includes neurosurgeons proficient in advanced open surgical techniques and skilled interventional neurologists along with us. Each case is assessed individually considering patient's overall condition, aneurysm location, and morphology, associated clinical and radiological factors. So this was one case which I am going to show you, has anterior circulation as well as posterior circulation aneurysm. I am not showing the video of the anterior circulation aneurysm. This is the video of the vertebral artery aneurysm, and clipping was done in this aneurysm. I think video stopped. It was decided to clip because this patient had a large anterior circulation aneurysm also, and we could complete the clipping in both the aneurysm in one sitting. This is the post-op angiogram. This is a PCA dissecting aneurysm in which coiling was done. You can see the dye filling up and the coiling, the first coil. Now the aneurysm has been completely coiled. This is a basilar artery aneurysm. So the advantage of having a neurosurgeon with an endovascular exposure is that they can decide what kind of procedure they want to adopt for their patient. Another one. So in our experience, we have had 1,445 patients of intracranial aneurysms since in the last 10 years. And I would like to show that the endovascular treatment has been gradually increasing over the last years. See, initially we had clipping more than endovascular coiling, but in the last 3, 4, 5 years, the number of endovascular treatment has increased exponentially. However, clipping has remained nearly stable. So in our institute, the outcome was that overall mortality was 21.26% in microsurgical clipping. And the 82% of patients went in MRS grade 2. For endovascular treatment, the overall mortality was 16%, and the number of patients in MRS grade 2 post-coiling were 81%. So in conclusion, microsurgical occlusion should be considered alongside endovascular treatment. The clinical value of one modality should not be overshadowed by the strengths of another. It is essential in formulating the most suitable treatment plan depending upon the location and morphology, expertise and preference of the surgeon and the patient's condition. Thank you very much. And I would like to emphasize that we should have teams which develop endovascular treatment option as neurosurgeons. And I would like to invite all of you to Jaipur in March 2026 for the NeuroEndocon. Thank you.
So we can have discussion at the end of the session.
Thank you. Shall I invite Dr. Ali, who will be giving a talk on surgical strategies and decision making in malignant skull-base tumor.
Good morning, still morning. Good morning, everyone. Thank you, chairpersons and moderator. And thank you, organizing team, for having me here. Thank you, Adesh, for taking good care and personally ensuring everything goes well. My topic is going to be a little different from what we've heard over the last 2 days, focusing a lot on benign tumors, skull-base approaches. But I'm going to talk a little bit an overview on how we as neurosurgeons approach malignant tumors of the skull base, and I will focus on the anterior skull base malignancies. So I would say at the outset that, like most skull base work, I think malignant skull base definitely requires a teamwork. The neurosurgeon is a component, but you also have other surgical specialties including head and neck, ENT, oncology, plastic reconstructive, and also a lot of other oncologists as well as rehab specialists involved. And what I will talk about is emanates from our experience at Tata Hospital over the last 15 years, where we have the skull base clinic and a skull base team consisting of all of them. So as a background, anterior skull base tumors are not very common. Amongst all tumors that neurosurgeons see or even head and neck surgeons see, they are a very small component, but they are varied. Heterogeneous mix of histologies. Most of them arise within the nasal, paranasal sinuses, complex lesions because of the location and the extent. And generally, conventionally has been thought of to be no man's land, neither in the neurosurgeon's domain nor in the head and neck ENT domain. Crossroads, so to say. But we've come a long way since the last 2-3 decades. We've understood better how these tumors behave. We've improved in our anatomy, in our surgical skills, and also in our teamwork. And that is also reflected in the evolving paradigms of treatment with these tumors. So as I said, a lot of these tumors arise, or rather all of them arise in the nasal, paranasal sinuses, but they also tend to involve the neurocranium and the orbit. And this is important because it's crucial in the decision making when you're talking about surgical management of these tumors. We are not so used to grading and staging tumors in neurosurgery, but oncology, there is a staging system which actually takes into account this regional as well as distant dissemination of tumors, and it's important to know that because it's also important in decision making about surgery, neoadjuvant treatment, adjuvant treatment. As I said, epicenter in most tumors, and this has been our experience also, is nasal, paranasal, but there could be other regional tumors which involve the anterior skull base. Important here is you can see that there is a wide mix of histologies, and this is very crucial because in the management decisions that you make when you are discussing this in your clinic or in the tumor board, tissue diagnosis becomes important. The next important management decision revolves around the extent of the tumor and how that will dictate your surgical approach. And of course, the third component is the adjuvant, neoadjuvant treatment that you would require. So we'll quickly deal with each of them. Tissue diagnosis is most important when you're dealing with anterior skull base malignancies. You have to have a biopsy and a tissue diagnosis to make your treatment decisions. And that's important because radiology cannot always tell you the differential diagnosis histology base. And also because it's not just surgery, there is chemotherapy, radiotherapy, and these are important, and some of them come into the picture before surgery, and that's why knowing the histology is always important when you're dealing with this. Very often we see patients who've been operated thinking it to be maybe a benign tumor and come with residual tumor. The surgical field is violated, and then you have other problems in making decisions or optimizing the treatment. So the histology is wide. It's important to have adequate tissue and to have a good workup from an experienced pathologist, because there can be subtle differences between histologies which only immunohistochemistry or advanced molecular diagnosis can tell you. And again, it has a bearing on your strategy for treatment. Once you have your histology, you need to understand where the tumor is, where it is extending, and what would possibly be your first step in your treatment, whether surgery is possible, and if so, how much of surgery. CT, MRI, multimodal imaging, and I think we all know CT is good for bony anatomy, MR is good for soft tissue reconstruction, multiplanar imaging, and then you also have staging investigations like PET, which tell you systemic dissemination of these tumors, which is important. Okay, I'll skip that. Differentiating benign from malignant is possible, but not always so, and that's why tissue diagnosis is important. The other thing that you need to also plan when you're doing imaging is to understand the extent of the disease and the local involvement, as I said, of the brain, of the dura and orbit. And dural involvement is very important to assess, because that has a big bearing on your surgical strategy. So MR is as the modality of choice, and you can have tumors which just abut the dura, and there is nothing wrong with the dura. There could be extradural disease, there could be intradural disease, and there can be parenchymal disease. And this upstages all the tumors serially. It has an implication in not only the prognosis, but as I said, in your surgical strategy, including reconstruction. And in some cases, when you have this extensive disease, you may want to fall back on neoadjuvant chemotherapy, which is chemotherapy. It's also called anterior chemotherapy, or it's given before you plan the surgery to downsize the tumor, but also in certain very malignant, especially round cell tumors, malignant neuroendocrine tumors, or some of variants of malignant skull-based tumors, where there is a propensity for systemic dissemination, and you give the chemotherapy 2 cycles before you take up for surgery. In our own experience, almost 15 to 20% of patients go in for neoadjuvant chemotherapy. And then the most important decision making in surgery is the choice of the approach. The location and the extent decides what the surgical approach will be. And we talked about a little between endoscopic and open in the last session, and the same debate goes on in anterior skull-based malignancy. If the tumor is limited to the nose paranasal sinuses, you could do a completely endoscopic resection. If there is breach of the anterior skull base, an option is to do an endoscopic craniectomy or an endoscopic craniofacial resection. If there is lateral extension or involvement of skin, then you might have to resort to some open subcranial skull base approaches. And if there is a combination of extent or very large extent, and provided it is still resectable, you have to do the open transcranial or craniofacial resection, combined approaches. Decision making hinges on the extent, including the cranial involvement and the orbital involvement and skin involvement of these tumors. In our own experience, a lot of the tumors which are T1, T2 stage go in for endoscopic resection, and some of them, depending on their local extent, would be candidates for more advanced or complex open and endoscopic assisted surgeries. The principles of surgery, be it endoscopic or open, are the same. You have to try to remove completely the tumor. I put en bloc in brackets because that is the conventional notion that you have to have en bloc resections in oncology. But when you're doing endoscopic resection, the philosophy is slightly different. You have a complete resection, one compartment, the next compartment approach, that is you go into the next compartment and go around the tumor, but you still will do it piecemeal, though it may be complete. You disassemble the tumor, address the local extent, and make sure that there is no neurovascular injury, and then reconstruction is paramount, no matter whether you do it endoscopically or open. The classical open craniofacial resection is what all of us are very familiar with, using a bicoronal and the modifications of bicoronal incision with a bifrontal craniotomy to remove the tumor, not only for access but for excising parts of the anterior skull base. I'll skip the video. In the endoscopic resection, it's an identical surgical outcome. It's just that you use an endoscope. There are certain guidelines or certain criteria that the tumor has to fulfill, which will help you determine whether this is amenable. I already spoke about it. But the surgical approach is almost the same. You have to have a head and neck ENT surgeon with you well versed with doing extended endonasal approaches to expose the skull base, and then you do an endoscopic craniectomy, removing the skull base, removing the dura, removing intracranial extension of the tumor, and assessing whether a reconstruction is required just purely endoscopically or combined. The reconstruction is crucial, not only to provide support and to separate the neurocranium from the visceral cranium, but also reduce dead space in certain cases, and various techniques are available beyond the scope of my talk right now. There can be potential morbidity in these cases, and literature discusses morbidity in the range of 20 to 80%. Our own experience, we've had morbidity, combined morbidity in almost 17 to 18%, with CSF leaks in the range of 6 to 7%. Now, comparing endoscopic with open, especially in malignant skull base, the literature, I must admit, is still evolving. A lot of the series are small, single center series with specific experience in that modality. Also, like we discussed, they may not be comparable in terms of staging of the tumor, the same stage tumors, and then follow-ups need to be longer in order to ascertain the eventual oncological outcomes. What we probably know is endoscopic surgery has better cosmesis and quality of life, but leak rates may be higher. In our own experience, leak rates have been slightly higher in the endoscopic series. In terms of quality of life, the endoscopic skull-based surgeries offer better quality of life, and when you evaluate objectively in different domains, especially physical and emotional, they seem to be better than open, rather morbid, extensive craniofacial surgeries. What about oncological outcomes? Because that's the biggest question when you talk about endoscopic versus open surgery. Whether it's piecemeal or oblong, sometimes even when you're doing open surgery, it's difficult to get oblong. Unless you do a very extensive surgery and the tumor is contained, it becomes sometimes difficult. So the question is not doing an oblong, but doing a complete resection. And this is what literature has shown. We know that even with endoscopic surgery, it's possible to get that. And more than the type of surgery, what drives the prognosis is histology. Between different surgical techniques, as long as you get a margin negative complete resection, you will have similar outcomes provided histologies are similar. And not just surgery, you need to back it up with adjuvant treatment, which includes a combination of radiation and sometimes chemotherapy and serial follow-up assessments. The histology remains the most important predictive factor for overall prognosis. The stage of the tumor, including the extent and involvement of intracranial component, and your surgical margins are an important prognostic factor. Therefore, planning surgery and executing it well is very, very important. In spite of all this, some of the more malignant varieties of tumors can have poor control rates, with progression-free and overall survival rates varying. They do come back, and then you have to offer salvage treatment. However, evidence that has accumulated over the last many years through multiple large collaborative studies across the world have shown that surgical resection is very important. Having negative margins is crucial, and backing it up with adjuvant treatment is important. So if I were to summarize for us neurosurgeons, important to understand that, and we often may be involved in treatment of these tumors, that histology is very important. It's important to know the histology before you start your treatment. It is a multidisciplinary discussion and a combined multimodal treatment strategy that is devised. Surgery is very important, and you have to devise the surgical strategy according to the histology and the regional extent of the tumor. Craniofacial resections, the open craniofacial resection is the workhorse, but endoscopic approaches, if they are able to achieve complete resection with margins negatives, are also very good and probably more cosmetically and better for the quality of life. However, the bottom line is radical excision, negative margins, and good reconstruction backed up with a Cuban therapy. Thank you very much.
Thank you, Dr. Ali. We'll take questions in the end after this. So now I invite Dr. Manjul Tripathi for his talk on the paradigm shift in management of posterior fossa tumors, radiosurgery as a complementary and supplementary tool. Dr. Manjul.
Thank you so much, sir. Coming back to Bhopal is like coming back to your home. And this is me and Adesh in 2007. This is me and Adesh in 2024. I think our hairline is gradually receding, and probably in next 10 years, we both would be bald. And it's an overwhelming and emotional feeling to be in company of your teachers who ingrained and who actually imbibed your interest in neurosurgery. Dr. Chauras here, Dr. Sandeep Sorte, Dr. Nitin Garg, Dr. Pal, all are here, and this is really a very overwhelming feeling for me. So I'm here in capacity of a microneurosurgeon and gamma knife radiosurgeon, and we are going to discuss the complementary and the supplementary role of the neurosurgery and radiosurgery, a saga of royal neglect to the silent acceptance and probably a roaring acceptance this time. I do not have any financial disclosure. This is based on my experience of treating on both 4C and perfection over close to around now 11 years with close to around 8,800 patients. सर्जरी युद्ध की तरह है और गीता से ये मिलता है कि युद्ध तभी करें जब शांति के सारे प्रयास आपके विफल हो गए हों। हालांकि हम पिछले 2 दिनों से युद्ध की सारी डिस्कशन कर रहे हैं और रेडियो सर्जन को आप लास्ट में लेकर आए हैं। ये एक टिपिकल कंसेप्ट है, ये एक किस्म का बायस है जो कि रेडियो सर्जन्स के अगेंस्ट हमेशा रहता है। जब ऑडियंस कम होती है, हम आखिरी समय पे होते हैं, उन्नीदे होते हैं और फ्लाइट पकड़ने की चिंता में होते हैं, लेकिन ये ज़रूरी है अब डिस्कस करना, तो मैं आज इसी बारे में डिस्कस करूँगा।
मंजू, तुम्हें हमने इसलिए रखा है क्योंकि हमें सबसे धमाकेदार प्रेजेंटेशन सबसे लास्ट में चाहिए।
So this is my actually a request to all the young neurosurgeons here who are in training. Always try first to learn the disease and the natural history of the disease. Then only you will be justified in your endeavors to help that patient at what particular step, in which age, for which symptoms, and with which modality are you going to attack that tumor, your enemy. If you do not know that, you are bound to fail. You might be happy in your own outcomes, but the patient is really getting benefited or not, that remains a questionable issue. So with radiosurgery, when do we treat? With this advanced radiology, we are getting patients more and more earlier and earlier, and we are getting the patients early in the course of the natural history without creating the neurological symptoms. Patient is able to hear better on 1 year, he goes for an MRI and is diagnosed with a vestibular schwannoma. But with the microsurgery, the patients are coming late. They are coming with the mass effects, with clinical symptoms, and then you attack over them. So that's why it's very necessary to know the natural history of this disease. What are we aiming with an SRS? We are aiming at progression-free survival, overall survival, free from additional treatment, enjoying a good quality of life with a smiling face, with a hearing ear, devoid of radiation-induced complications. That's why your radiation tool is also going to matter over here. If you look at the SRS, you can divide this era into the 3 eras. The RQ SRS, when it was crude imaging, it was in 70s, usually based on the CT, high doses, creating deficits while creating a tumor control. Then came a middle era of 90s and 2000 when we had advanced imaging, we had reduced on the doses, and we were creating the lesional effect. And now we are living in a new SRS era when we talk about the neuromodulatory effects of the radiosurgery, when we are integrating the AI into the radiosurgery, and then we are getting the more benefits. The seasoned here are able to see these sorts of the radiation techniques when we used to fry the brain, and from that time we have entered into an era when you can actually pinpoint the facial nerve at the capsule of a vestibular schwannoma, and you are treating the vestibular schwannoma without injuring your facial nerve. That sort of a sophistication you demand for yourself and for your patients. So this is one article. Whatever the articles I am quoting here, these are all my articles, so आप कह सकते हैं कि मेरा भोगा हुआ यथार्थ है. There have been conceptual mistakes in the generations when the vestibular schwannoma, the blue-eyed boy of the radiosurgery, and the skull-based radiosurgeons and surgeons have been discussed. They say that the resection is more radical, thus more effective on the long term. Modern microsurgical resection is far enough. In cases of failure, retreating doesn't make any sense. Resection after SRS is more difficult and is carrying more functional risk of hearing loss and facial palsy. Small acoustics are rarely growing and have better chances to keep a functional hearing. SRS is increasing the mortality because of the increased carcinogenesis, especially in syndromic ones. K4 is a strict no. Hearing loss is a direct effect of the tumor compression, and you are sure about the natural history of your disease, whether it's a residual tumor, recurrent tumor, internal auditory canal tumor, or the tumor which is just peeping into the cistern. You find yourself to be in a certain position while you're discussing with the patient when the literature itself is not certain, and if you go with the natural history of the vestibular schwannoma on PubMed, you are going to find close to around 600 articles that shows you have gaps in your knowledge. We have gaps in our knowledge, and we should accept over it. There have been a shifting gear over here. 50s to 60s, it was life-centric, then we became paresthesis-centric, then we became nerve-centric, facial-centric, and now we discuss the quality of life because we are looking at the hearing preservation, facial preservation, and the vertigo and the tinnitus over there. But why is it so difficult to change? The change is that we have too much overconfidence, we have a selective memory loss for our complications. We believe in the happy endings of the surgical results of a black scan in the post-operative period, when we do not know what exactly causes the hearing loss, when the tumor does not increase in size, but you lose your hearing because there has been a different milieu of the endolymph, perilymph, tumor necrosis factors, biological effects, mechanical compression. You do not know that, but still we claim that we know that. And there is a huge variability in the surgical and the radiosurgical and the biological care because the experience our earlier generation could get by operating on so many patients. With these so many neurosurgeons coming up every day, this is going to create a much lesser operative experience over the course of time. That's why we need a technique with which you can, with a certain level of radiosurgical knowledge, provide nearly uniform results across the specialties, reducing your interoperative variability. The quality in life in vestibular schwannoma is not decided by your scan's appearance. It is decided by vertigo, headache, imbalance, tinnitus, facial nerve, and then last comes the hearing. I was surprised to do this study, and we found that patients are least concerned with their hearing. Their concerns are something else which decide their quality of life, and in those cases, gamma knife providing a tumor control rate for Coos grade 1 and 2 more than 98% down the line 10 years, for Coos grade 3 and 4 more than 93% 10 years, a hearing preservation across all SRS platforms of 40%, but facial nerve preservation more than 99%, and that's actually the gold standard for these ones. These are all studies which I published over vestibular schwannoma, some my personal, some as a part of my international collaboration, and the size does not matter. If there is a radiological compression, you do not need to jump over there. If there is a clinical compression, definitely jump over there, and if the patient is having hyperactive nerve syndromes, jump over there. Trigeminal neuralgia. If it is a trigeminal schwannoma, any schwannoma, it behaves in a similar way, whether it's a trigeminal schwannoma or hypoglossal nerve schwannomas. And once you are dealing with the lower cranial nerves, these are extremely non-forgiving structures. Be very careful whether you are dealing with the jugular foramen schwannomas, hypoglossal schwannomas, or paragangliomas. Your surgery or radiosurgery is not a teenage sex or midlife crisis. You do not need to be overexcited. It's a very partial conservative approach, and it's a very individualized patient-centric approach for which you need to develop a philosophy not only in the neurosurgery but also in the radiosurgery. I'm not daring to say this, but paraganglioma is not a surgical disease anymore because the surgical complications worldwide are significantly high. You need a patient who can eat well, who can speak well after radiosurgery, after your surgical procedure or radiosurgery, and that results are significantly better in the radiosurgery in comparison to your IMRT or the surgical arms. The problem is that neurosurgical progress or lack thereof is based on the things that we can measure rather than the things which we should measure, and there is a significant difference over there. You give radiosurgery to these jugular paragangliomas and the patient is better in 6 months, irrespective of the volumetric reduction of these tumors, and you start getting better deglutition, better speech in the long term. And this is proven repeatedly in the literature, and practically even in the major institutions, the surgery for paragangliomas is obsolete until unless it is causing a brainstem compression. I used to think that it might not work in the secretory paragangliomas, but I did a systematic review and meta-analysis, and I found that with the limited experience published in the literature, it's very helpful even in the secretory paragangliomas, which we recently published in the neurosurgical review. Chordomas we have already discussed, so if it is a small one and you can give 20 gray away from the brainstem, you are sure about the margins, go with proton, do not go with a technique with a huge financial toxicity as well. Role of hysterectomy radiosurgery for intracranial epidermoid. I have not tried it, but I was skeptical and I was curious about it. And I came to know that if you get a recurrent epidermoid, they have a chance of conversion into the squamous cell carcinoma. And if you want to prevent that, if your patient is coming second or third time recurrence, they have a high chance of conversion into the squamous cell carcinoma. And giving a proactive radiosurgery in those patients retard that progression of the squamous cell carcinomas. If you go with what should I do with the
Suppose you ask me, what I will do if I have a small pretrocleval meningioma which is detected instantly, I am not symptomatic. I'll go to Manjul only.
That's not my self-promotion, but this is Dr. Suresh Nair, who has promoted skull-based surgery for the pretrocleval meningioma for whole of your life. And now, after so much years experience, he is convinced that for a small pretrocleval meningiomas, there is no need to go with your microsurgical knife because you are giving a better quality of life, especially when it is medial to the fifth nerve. So, if it is children, adolescent, you are sure it's a grade 1. You can go with surgically inaccessible recurrent or residual pediatric meningiomas directly straightforward with stereotactic radiosurgery. And if you have smaller ones, it's a much better technology across the location of your meningiomas with a primary radiosurgery in those cases. Intracranial histiocytosis, for the unifocal histiocytosis, it provides beautiful results. You do not need to subject those patients to long-term chemotherapies. Skull-based metastasis, especially the radio-resistant ones. I'm frequently doing these for the prostatic cancers, renal cell carcinomas, and we found that with a single session radiosurgery, you give an excellent long-term local control and progression-free survival in those patients. This we recently published in Journal of Neurology, Neurosurgery, Neurology and Psychiatry. So this was the low-grade dural AV fistulas, which are actually on the tentorium. This is a 304 patient series, and giving a single session SRS has provided, as an upfront treatment, a significant symptomatic relief in 95.1% patients with a good improvement in the MRS score. This is something of fruit. This child was actually a case of a hemifacial spasm. If I can. This was a very interesting case. A 2-year-old female presented with hemifacial spasm and a slight ptosis over there. And this patient was having a lesion at the fourth ventricular floor. We discussed with the radiology, did all the scans, and we finally zeroed on the diagnosis of a facial nerve hematoma. Then, extrapolating my experience with the hypothalamic hematoma, we treated it because the family didn't want a surgery for that with a primary radiosurgery, and this is the result of this patient at the end of 1 year. She still gets 1 or 2 episodes in a week, but she significantly improved from that one, and you can see the radiological resolution of that hematoma in the follow-up, and this is just at 1 year follow-up. Every treatment modality has its own set of complications. Yes, radiosurgery may lead to malignancy, but that risk is not different from the general population, and this has been repeatedly proven in the literature. A word of caution, once you start a busy radiosurgical practice, many patients come to you for a primary radiosurgery. If you are not convinced with the with the radiology or the history of the patient, never touch it with the primary radiation. Confirm your pathology first. This patient was treated at some other center with a diagnosis of glomus tumor, and after 10 years, it failed, and when we did the biopsy, it turned out to be extraskeletal mesenchymal chondrosarcoma. It was never a glomus from the very beginning. This patient from Bihar had a characteristic facial redness over the B2 distribution with a trigeminal thickness, sent as a trigeminal schwannoma. I was not convinced, took a biopsy from the face. It turned out to be a leprosy, and the patient is treated just with a dapsone. This is a skull-based aspergillosis. This is a lymphoma. So never treat them just on their face value. Otherwise, your complications are going to increase. To minimize your complications, you should know what you are treating. Keep the minimum possible but effective dose. Respect your organs at risk, and always, always notify your complications. And for these, once it's a matter of brain, you all guys are very sensitive and finicky about your precision. Use the machine which has the highest precision for your particular machine, for a particular patient. Now it's an era of the AI in radiosurgery, probably which is going to reduce the inter-observer variability over the course of time. We are going to see an era of the adaptive SRS, looking at the microneuro environment and the flash SRS. So I would conclude that the psychology of understanding says that human beings learn things so well that when it comes a time to unlearn them, it becomes very difficult. And if you are in your 50s, 60s, and you have been practicing neurosurgery for the last 30 to 40 years, a guy sitting over here is standing and teaching all this, you want to throw something at me. But believe it or not, change is the rule of the life. And we must move with the science. We must look at the technologies, embrace the technologies to help our patients. There are certain studies which become the non-threatening studies, like then Aruba. After Aruba, probably you are treating more and more AVM, which you used to treat earlier. There are certain studies which are moderately threatening to your understanding, and you accept them with an skepticism, like radiosurgery for the vestibular schwannoma. And there are certain studies which are so iconoclast, which changes your practice pattern, which the generations of neurosurgeons have been doing, like coiling foreign aneurysm. So I'm extremely proud of this team with which I am working in PGI Chandigarh, and thank you so much. This is Professor Shihan Ajay. He is a core teacher for all of us. And this is the son of Lars Lexell, who actually invented gamma knife radiosurgery. He expired 2 years earlier, but he has been an instrumental figure in my career. Thank you so much.
Thank you. So we are now open for discussion. All three were different talks, not related with each other. So if there are any questions from the audience. So by the time, I'll ask Dr. Manish one question, that in your statistic, you showed that there is a significant increase in the number of endovascular procedures. So is it a treatment bias or is it some technical reason? Because many times in a busy neurosurgical department, sometimes if you have an alternative option, non-surgical option available, you tend to get biased towards that.
No, it is not actually a bias. It is a change in technology. Earlier we had a single plane machine, and now we have a biplane machine. So with that, the results improved. Results of the endovascular treatment improved. Our faculty is more trained for endovascular treatment now. And we made a team with the interventional neurologist. We created 3-4 faculty who would go for training. And now we have at least a pool of 10 faculty members who can independently do endovascular work. And all the residents are also being trained in that. So with the improvement in the results, of course, the number of cases in endovascular treatment are increasing.
Yeah. Thank you. Yes.
Manjul, very impressive talk as usual. I just want to know this glomus jugulaire. You were saying about the brainstem compression. So for pituitary cranium, we have some distance from the optic nerve, 1 millimeter, 2 millimeter. Similarly, you have any cutoff from the brainstem where you can safely give radiation?
Actually, so most of these glomas, in their natural tendency, they try to go along the nerves and going into the upper part of the neck from the temporal side, destroying the petrous bone, and rarely you find a glomus which is actually growing in the intracranial component or going towards the fifth nerve. So we usually get a good space from brainstem, and brainstem needs to be preserved if you are treating in a single session from 12 gray, and if you are treating into 3 fractions, you can actually give up to the 30 gray. If you are treating in 5 fractions, you can actually go to the 50 gray. So your range increases. It hardly becomes a reason for me because the dose for glomus is close to around 14 gray to the 60 gray, 30 gray in a single session. That depends on whether you are dealing with the non-secretory paraganglioma or a secretory paraganglioma. Secretory paragangliomas happen only 2%. So if I give a dose of around 18 to 20 gray, which is a moderate dose for these glomus tumors, and most of the times I am able to secure my brainstem from 12 gray radiation. If I am not able to do that and there is a large paraganglioma, then I usually fractionate it into the 3 fractions with the 9 gray in each fraction. With that, the brainstem is easily saved and we do not find any radiation-induced complications in that. If pituitary is there and it is a non-functional pituitary adenoma, then the dose is usually 13 to 15 gray. And we need at least 1 millimeter gap so that we can do dynamic shaping, preserving optic apparatus from 8 gray. The problem with optic is that their radiation tolerance is less. They are 8 gray, so we need to be more cautious. But brainstem, you can give up to the 12 gray. If it is a functional pituitary adenoma like acromegaly or Cushing, then the dose is much higher, it's 23 to 25 gray, and in those cases, the fractionation schemes may increase up to the 5 fractions. So yes, definitely, at least 1 millimeter gap I need with a pituitary adenoma, but with brainstem, I can manage with that.
Dr. Ali, one question to you. Do you have surgical oncologists in your team? Because when we discuss with our surgical oncologists such cases, most of the times they say ki we need en bloc dissection, and many times we are unable to proceed with the procedure. Like you said in your data that it doesn't really matter, it is the negative margins, whether you remove piecemeal. So how do you manage them?
So they are surgical oncologists, basically head and neck surgical oncologists, and they are part of the team. In fact, they are an important part of it. And in fact, the entire concept of endoscopic, this thing with piecemeal, it's piecemeal because you have to debulk it and get around it. So it's like even in gliomas nowadays, when you talk of circumferential resection, subpile resection, it's not that you're removing it en bloc, you're decompressing it to make it sizable and go around it. You convert an intraxial to an extraxial kind of. So as long as you get everything out and you have your predefined margins that you are able to get. Anyway, it's difficult in skull base because it's so complex. You can't get the classical margins that you would get anywhere else. So our team, and I think most head and neck surgical oncologists agree on that. Maybe they are not very familiar with endoscopic and then they have that reservation. That is the old school of thought, but it has evolved now and it is possible to do it, not necessarily en bloc, as long as it's complete, as long as you go around it beyond the margins.
Professor, thank you very much. All the speakers, they actually presented very nicely. So I was just discussing with one of my colleagues that just like samosa, या तो वो अच्छा होता है या बहुत अच्छा होता है. ऐसे ही I think we micro neurosurgeon are good or very good. We don't grade ourselves as an average micro neurosurgeon, or we need some cadaveric exposure, some master-mentee relationship. So starting from here, see, interperson means biasness is less when you are, using very modern gadgets like advanced stereotactic radiosurgery in the form of gamma knife. When you compare, patient outcome point of view, a very good group doing the microneurosurgery and a very good group doing the SRS, one thing. Second is, what is patient burden to you? What is the waiting list for you? What happens to those patients who are waiting for their turn, and what is the cost effectiveness? Because in India and the developing country, we keep these things in mind, and I think as a microneurosurgeon, please don't mind, we should be encouraging our microneurosurgeon to become better microneurosurgeon because we have many cases to serve in the country like India. What's your take?
Chief, there is a dictum we say that bet on the jockey, not on the horse. So fool with a tool is still a fool. The kind of the way you deal with your machines and with your knives, that is going to actually make an outcome, and that you should be comfortable in that one. Now looking at those microsurgical, as you told, yes, the centers which are high volume, which are doing a dedicated job over that definitely makes a difference. But we should look at the changing landscape of the neurosurgery and the number of the neurosurgeons over there. If you are talking about AI in radiosurgery and to reduce the inter-observer variability, the denominator, as large it is, it's better. But if you talk about the microsurgery, if the denominator is large, then probably those people wouldn't be operating more than 10 or 15 vestibular schwannomas in a decade period, the kind of the number of the neurosurgeons and the number of the neurosurgeons that we are generating these years. So that's going to create a trouble. Every neurosurgeon has their own learning curve. Dr. B.K. Mishra, Dr. Goel, these people actually were in an era when they had loads of patients to operate, and they, over the course of time, garnered that much experience, which the latest generation, the current generation, is not able to get. So that important factor, I totally agree, philosophically we should do that. And we are neurosurgeons, we are microneurosurgeons, endoscopic neurosurgeons, we should encourage our knife, but we need to have that limitation in our mind with the number of the patients, what we get, and the opportunities these people get to operate. If that scenario is going to continue, then probably we need to rely on the machines in which the inter-observer variability is less, and with a certain level of knowledge, you are able to produce an equal result, because finally, whatever the good or harm is going to happen, that's going to happen to the patient.
One small comment, Manjul. When you present, the problem is a surgeon who has spent time in learning the technique of microsurgery also feel, why I have learned like this, we could have gone for gamma knife. Your talks are like, you are an influencer. YouTube influencer, something like that.
Yeah, he's a KOL now.
Having said that, I would say one thing. See, if you are talking of preservation of facial in a 3 centimeter tumor, 4 centimeter tumor, the gamma knife which is given for less than 1 centimeter tumor, Shukla always used to say that, if you can see all the nerves around you in schwannoma, I think your chances of preservations are much, much higher. There is no question of doubt about it. And coming to the practice of neurosurgery and learning neurosurgery, I think over years you will learn. It's not that the microsurgical training is so complex or very difficult one. You will get it, but only the thing is that you should be exposed to a good center with reasonable experience. But there are enough problems with the gamma knife which you never highlighted. I'm sorry to say that. There are cyst formations. Let me finish up, man. You are influencer. There is a problem. I'll forget my point. There are cyst formations. Meningiomas, you see, they give gamma knife. They never improve. Let me be honest with this. Cavernomas, you keep on radiating them, nothing happens. You know, better that they are operated. And once you don't learn the microsurgical technique in trigeminal neuralgia, you know, you give gamma knife. Where is the chance for neurosurgeons, microsurgeons to learn a small technique of microsurgery? Let me finish off my question because otherwise again I will forget. So if you are not learning in the microsurgical techniques in smaller cases, when it comes to bigger cases, it becomes difficult. So gamma knife is taking away that opportunity from young surgeons. Your comments.
So Chief, I totally agree with you. That's why I had 5 slides on the complications of gamma knife. The second important point, which I add to you, is that whatever the complications in microsurgery are going to happen, they are going to happen upfront. The patient, whatever the complication, if he is going to have a facial paresis, it would be evident in 2 or 3 days of your microsurgery. In complications with the radiosurgery, they compound over the years. That you need to be very careful. The problem is that most of the radiosurgeons who are actually doing it, or the neurosurgeons who are practicing the radiosurgery, it's a very sorry state of affairs, they leave it to the radiation oncologist. And there is a difference in the philosophy. A neurosurgeon treats a patient with radiosurgery, and an oncosurgeon treats, or a radiation oncologist treats it with the radiosurgery. So that philosophy, a benign tumor, like you are leaving a small tumor in an internal auditory canal, if I have to preserve the hearing, probably I would also leave that tumor with radiation exposure to preserve the hearing. I do not want to treat every cell of that one. I told that if the patient is coming with a hyperactive nerve syndrome, with a vestibular schwannoma, straight away go with surgery. Because trigeminal neuralgia, secondary to a skull-based pathology, is not going to improve. But in your practice, in my practice, you are getting octogenarians, septuagenarians, people who actually come with these diseases which have a low growth potential. Those people are actually much better benefited. Yes, if you are not careful with your dose, careful with your pathology, you are going to create. That's why I said, bet on the jockey, not on the horse. You can create complications with a good machine, and you can actually deliver good results with your bad machine or with your microneurosurgery. So it shouldn't be gifted to the patient. It's each patient needs to be custom tailored according to their understanding, their demands, their presentation, the natural history of the disease, and their age. So there is no dictum over there.
Yeah, I just, devil's point of view, yeah. Both Rao and Manjul, as neurosurgeons, we love to operate. But see, we love to clip aneurysm, but even if we want to clip, we cannot clip because most ago. So we had 1 or 2 gamma centers, now 3, 4. I think the next 10 years there will be more such centers and more radiation oncologists will be doing RAN neurosurgery. So finally, without our knowledge, we'll be losing many of these patients, though we don't do. So I think it's better to know the flip side of both of it, and I think, but finally patients will take the call. 10 years of time.
Very true what Dr. Rupesh said. As a closing remark, I echo the thoughts of Dr. Agarwal, Manjul, and I think most of the audience over here. The message for the upcoming neurosurgeons who will hold the baton in the coming decades, you have to understand that technology is changing. If you don't embrace the technology, you'll lose the game. What happened with Nokia, who was once the king, now you don't see it in the market, will happen to neurosurgeons. So you don't, okay, you love neurosurgery, you like operating, you get that adrenaline rush of the blood gushing out of the incision, but would you like to have that done to your own self or to your loved one if they had a similar disease, God forbid? So please, come out of your comfort zone, embrace the technology, and change is the rule, as Manjul said. I think one last comment by sir.
Just one word I would say that you can't compare these instruments, Nokia, and with the surgical skills.
No, sir,
So
it's not comparing instruments.
Not to grab
it's
the
more of
technology.
those who
What
don't
is-
embrace technology
just-
gradually die.
Whatever is for the good, then you should adopt that for
Obviously,
the good.
obvious reasons.
Not for that, because this is an alternate technique. There microneurosurgery or radiosurgery. So I go for radiosurgery because I get more patients. When I started doing endoscopy, before that I had done only few colloid cysts. When I started doing with the endoscope, I got 50 cases to do of the colloid cyst. So that was the attraction. The patients are willing for this. And today for coiling also, my team is operating just now. They have asked the patient to be, means for clipping. But the patient is insisting coiling. Now it becomes difficult for us. तो क्या है कि ये टेक्नोलॉजी से, जैसा मंजुल ने कहा कहावत हिंदी में कुछ तो अंगली पकड़ते पकड़ते क्या और पोंछा पकड़ लेते. So that should not happen. So you should be trained with microneurosurgery and you should try to promote that and pass it on to our next generation.
Yeah, true,
I think we
absolutely.
conclude with this. We
And
have to
the-
go for the
I think, sir, the mool
valedictory
mantra is
function also.
the mool mantra for everyone is don't offer or do anything to the other person which you would not like to be done to your own self.
That's right. Thank you.
Thank you, co-chairpersons and the moderator for this concluding session. Thank you, Dr. Adesh, for this wonderful meeting, and the entire teams at AIMS Bhopal as well. Thank you very much.
With this, actually, this is the most discussed session. This is like a climax of a movie.
Thank you, sirs. Thank you for the very stimulating conversation. Now we'd like to move forward towards the last section, the valedictory function and the award ceremony, sir. I would request Dr. Ashok Nayak, sir, Dr. Hemant Bharti, sir, Dr. Rupesh Kumar, sir, Dr. Amit Agrawal, sir, and Dr. Adesh, sir, to please come up on the dais. I invite Dr. Ashok Nayak, sir, to please share a few words about the ceremony.
I am happy to see the people standing here and our gathering real and nice speaker, very learned one, and all the PG students, other faculty members. So we are happy to have this all response from the you and from our the seniors and all the guests. They are worth to be thanked, and we are highly obliged to organize, and we are benefited out of it so well. We thank you, Dr. Sir, and Dr. Rupesh, Dr. Amit, Sandesh, and everybody. Everybody here, Manju Tripathi, everyone is impressed so much well. Narasimha sir, everybody. Sir, very nicely.
Sir, any comments?
Sir Hemant Bharti, sir, please share a few words with us.
I thank you all for attending the meeting and participating actively in presentation and discussion also. And the discussions were all very high content, very good quality, and at par with the international levels. There is no doubt about our competence, our excellence, our innovations, our advancements. I think we are no less, and we are, I should say, even better than many, many centers in the world. I would like to thank and appreciate the efforts of the organizing team, the way they have organized. They have kept this and put this as an example for others in future, how to manage these midterm conferences. Annual conferences are different, definitely different, but the midterm conference, I personally had not expected this level of program, scientific program, the content, and the participation and the involvement. Thank you, Dr. Adesh and Dr. Agarwal, for doing such a wonderful job. Thank you very much. Now,
Dr.
the
Rupesh Kumar,
Secretary
sir.
Rupesh Kumar.
I think Adesh has set a bar very high. I think we should all stand and give a standing ovation for no, no. Yeah. So thank you again, and I think putting the name as course, skull-based course, really mattered. It's not just on name, but really it was like, so the way discussions were happening, the course, actually you should rename it now. It's a skull-based course rather than the interim meeting. It has a lot of meaning in it. So thanks again to Dr. Amit and Adesh. Really proud of both of you.
Dr. Amit Agrawal, sir, please share a few words with us.
Just, we are very thankful to all the participants. I have something interesting to share. Over a period of 10 years, we are either work together or junior to each other. Dr. Dhawal, he is my senior. Rupesh is immediate junior. Ali is junior to Rupesh, so 4 generations are there. And then you go down, then Adesh from GMC. I did from Gandhi Medical College. So like that, if you see for at least 10 batches we are here, then Nitin is there, then again he is junior. So it's a very interesting chain what we can make, and Rao is there. So somewhere we have worked together. So it's very nice that all of us sitting together in such a way, like one family kind of thing it is.
Last but not the least, can we have Adesh sir say a few words about the ceremony, please?
I think I have said a lot through the last 2 days. I am overwhelmed with feelings with the responses we have had, the support I have had right from my department to the industry, to the delegates. Everybody has supported us, given us so much love, given us confidence that yes, Bhopal can do it. Our seniors from the city, they helped us. They said, "Karo, hum log hain saath mein." And I think it's really, God has been very, very, very kind to us that we were able to conduct this meeting successfully. I'll not take much time. Now we'll begin with one of the most awaited moment of this ceremony. We have to give awards to our star residents and young neurosurgeons. And after that, we'll have a few felicitations. Over to you, Isha. Please start with the awards. Sir, if
We'd
we
like
can
to start
come
with the
here.
award paper presentation. Third prize goes to Dr. Abhishek Shukla.
Abhishek Shukla, first
Minimally
prize for
invasive
the
lateral
award paper.
transorbital endoscopic assisted approach. Our initial experience and preliminary report of 1 year.
So Abhishek Shukla gets the first prize for the SBSSI
Third.
Excellence.
Third prize, sir.
Third prize. Okay, you are going the other way.
Yes, sir.
So he's getting the third prize, the SBSSI Excellence Award and Medal. So he gets a cash prize as well as a medal. I think the award has, you have to wait for the award. Come fast. I think the meeting went quite well. It's only the last minute goof-ups. They are not finding his medal. क्या हो गया? Medal बांध दिया आपस में, खोल के भी नहीं रखी. Bronze.
Now may I announce the second prize? Dr. Prachi Gang. Can I have Dr.
Prachi Gang from PGI Chandigarh.
Radio surgery for trigeminal neuralgia, secondary to dolioectatic vessels, case series and review of literature.
Sarvesh. Sarvesh Goel.
Moving on to the first prize, Dr. Sarvesh Goyal.
Sarvesh Goel. So Sarvesh gets
Building
the first
AI-ready
prize.
data set for neural-based pathologies, a systemic approach to data curation, and ocean challenges and potential solutions. Moving on to the next section, we have quiz prize winners. We have a tie-up at this position, starting with Dr. Sagar Balal, Dr. Abhishek Govda, Dr. Amar Pratap, Dr. Surya Prakash, Dr. Paras Gupta, and Dr. Mukesh Banya. I'm repeating the names: Dr. Sagar Balal, Dr. Akhilesh Govda, Dr. Amar Pratap, Dr. Surya Prakash, Dr. Paras Gupta, Dr. Mukesh Banya. Next, we move on to the poster prize winners. We have Dr. Apurva Ranjan, Dr. Apurva Ranjan, Dr. Kaustav Saha, Dr. Sanjay Sharma, Dr. Soham Kundu, Dr. Shubham Gupta, and Dr. Tanvi Joshi. I repeat the names: Dr. Apurva Ranjan, Dr. Kaustav Saha, Dr. Sanjay Sharma, Dr. Soham Kundu, Dr. Shubham Gupta, and Dr. Tanvi Joshi. Thank you all. Now we'd like to facilitate our industry partners. Starting with the endoskull base and microvascular anastomosis workshop, we have AOSQ Lab, Brain Lab, Carl Zeiss, Johnson & Johnson, Carl Storz, Medtronic, Sanma Medinos, Stryker, and Surgiware.
Can we have representative from B. Braun Asculab, Brain Lab, Carl Zeiss, Johnson & Johnson, Carl Storz, Medtronics, Sanma, Stryker, and Surgiware? These companies supported us in conducting the endoskull base and the microvascular anastomosis workshop on 13th of this month. First to call is Bebron Asculap. These names are in alphabetical order. We request all of you to come and
Can we have a representative from the Brain Lab?
your names are displayed on the screen. Please come in front.
Carl Zeiss, Johnson & Johnson.
Carl Zeiss.
Carl Storrs, Medtronic. Sanma, Stryker. And Sojiwe. Next, we have our premium industry partners. Arena. Can we have a representative from Arena? Entas. Laranon. Sanix Formulation. CNS Clusters, Sun Pharma. Entas. A representative from Entas, please. अच्छा ठीक है ठीक है Our other industry partners, 3M Advanced Sterilization Products. Can we have a representative from 3M? Advanced Sterilization Products, Alchem, Allengers, Elysia, Alvarez, Arena Medical Care, Avalac, AVM Surgical, Baxter, BAT Medical Private Limited, Celagenics, Desai Surgicals, Dynamed, Intas, Eris, Gelvit, Jesco Healthcare, Happy Reliable Surgeries, Medtronic, हाँ, actually वो award
I request all the participants and delegates who are available here to come on the stage so that we can have a group photo. All the delegates. नहीं टूटेगा. Come, Raja. Delegates and faculty members
So we
who
have
are
one
still with
workshop.
us. Sandeep sir. Yeah, we can come in the. All the participants. Shashank. Come. Vibhu. Kaustav. Lalit. Jiten Shetty. Come. सब लोग आओ. ये टूटेगा तो नहीं. आगे बैठ जाओ. We'll stand. Yeah.
से आ जाओ. तुम देखो
Three cheers for Team ISBM 2025. Hip hip. Hip hip. Hip hip.